Good morning, everyone. I'm Kip Talbot. I'm the chair of ACIP, and we are going to get started this morning because we have a lot of stuff to cover. I'm going to turn the meeting over to Melinda Wharton.
Good morning. Next slide, please. Welcome to the June 26th through 28th, 2024 ACIP meeting. Copies of the slides being presented at today's meeting are available or will be available soon on the ACIP website. A few notes on meeting logistics for those who are listening in on the Zoom line. Please keep your line muted until you're called on for discussion. When the meeting is opened for discussion, please use the raise hand function in Zoom to virtually raise your hand if you wish to be recognized. During the discussion, questions will be taken first from voting ACIP members and ex officios, and then as time allows from liaison representatives. Please keep your video off until we get to votes. We'll then ask those voting to turn their video on during voting. Next slide, please. The Advisory Committee on Immunization Practices is, at its heart, a public body, and engagement with the public and transparency in our processes are vital to the committee's work. For this meeting, we will be holding 2 oral public comment periods. The first will occur today at approximately 3 p.m. Eastern Daylight Time, and the second will occur tomorrow at approximately 4:10 p.m. Eastern Daylight Time. To create a fair and more efficient process for requesting to make an oral comment, we ask those interested to submit an online request in advance of the meeting. We give priority to advance requests, and if there's more requests than can be accommodated in the allotted time, we select speakers through a blinded lottery. The 7 speakers selected by lottery for each of the 2 sessions in this meeting have already been notified. We thank all those who requested an opportunity to make a public comment. Members of the public also had an opportunity to submit written public comments on issues coming to ACIP via regulations.gov. The docket number for today's meeting is ID CDC 2024-0043. More information on the public comment process can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forgo participation in certain activities related to vaccines during their tenure on the committee. For certain other activities that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Can we have an audio check? Do we have audio? Pardon? Yeah. Can we check audio now? Is the sound coming through?
Yes.
Okay, great, thank you. All right, so I think I have to go back and start over. Can we go back to the second slide, please? Thank you. All right, apologies for that. Welcome to the June 26th through 28th, 2024 ACIP meeting. Copies of the slides being presented at today's meeting are available or will be available soon on the ACIP website. A few notes on meeting logistics for those who are listening in on the Zoom line. Please keep your line muted until you're called on for discussion. When the meeting is open for discussion, please use the raised hand function in Zoom to virtually raise your hand if you wish to be recognized. During the discussion, questions will be taken first from voting ACIP members and ex officios, and then as time allows from liaison representatives. Please keep your video off until we get to votes. We will then ask those voting to be on camera during their votes. Next slide, please. The Advisory Committee on Immunization Practices is, at its heart, a public body, and engagement with the public and transparency in our processes are vital to the committee's work. For this meeting, we will be holding 2 oral public comment periods. The first will occur today at approximately 3 p.m. Eastern Daylight Time, and the second will occur tomorrow at approximately 4:10 p.m. Eastern Daylight Time. To create a fairer and more efficient process for requesting to make an oral comment, we ask those interested to submit a request online in advance of the meeting. We give priority to advance requests, and if there are more requests than can be accommodated in the allotted time, we will select speakers through a blinded lottery. The 7 speakers selected by lottery for each of the 2 sessions in this meeting have already been notified. We thank all those who requested an opportunity to make a public comment. Members of the public also had an opportunity to submit written public comments on issues coming to ACIP via regulations.gov. The docket number for today's meeting is ID CDC 2024-0043. More information on the public comment process can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forego participation in certain activities related to vaccines during their tenure on the committee. For certain other activities that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains on all votes related to vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next slide, please. We are currently soliciting applications and nominations for candidates to fill upcoming vacancies on the ACIP. Detailed instructions for submission of names of potential candidates to serve as ACIP members is now available on the ACIP website. The deadline for applications for ACIP membership is August 15th, 2024, for the 4-year term beginning July 2025. We anticipate filling 3 positions in this next round of applications. Next slide, please. Speaking of new members, I am delighted to welcome new members to the committee. We have three of the new members who have joined us for the first time at this meeting are here with us this morning, and I'd like to briefly introduce them and give our welcome. Dr. Denise Jamison is Vice President for Medical Affairs, Dean of the Carver College of Medicine, and Professor of Obstetrics and Gynecology at the University of Iowa. Her scientific work is focused on emerging infections and vaccines in pregnancy, and we are delighted to welcome Dr. Jamison to the committee. Next slide. We're also pleased to welcome Dr. Robert Schechter, who's Chief of the California Department of Public Health in the Immunization Branch, where he has worked for over 20 years. He has served previously on the National Vaccine Advisory Committee and on a number of ACIP work groups, including COVID-19, influenza, and other vaccines. Welcome, Dr. Schechter. Next. Finally, we're delighted to welcome Dr. Albert Shaw, who's Professor of Medicine in the section of infectious diseases at the Yale School of Medicine. Dr. Shaw is an infectious disease physician whose field of expertise is changes in the immune system function in older adults, and we welcome Dr. Shaw to the committee. There is one additional member who could not be with us today, and we will be introducing her tomorrow. Next, please. And finally, I am delighted to welcome back to the committee Dr. Kip Talbot, who is chair of the committee. And Dr. Talbot has been on ACIP since 2018 and is well known, I think, to most of our members. But she has now returned as chair of the committee with a term that will end mid-2025. And Dr. Talbot is Professor of Medicine and Health Policy in the Division of Infectious Diseases at Vanderbilt University. Welcome back, Dr. Talbot. We're glad to have you with us. And with that, I will turn the podium over to you to resume to begin the roll call.
I'll be happy to. I'll take roll call, starting with ACIP members, and then liaisons, and then ACIP members ex officio, and then our liaisons. For liaisons, announce the organization, and I should have had a second cup of coffee. All right, I'll announce the organization name, and then please indicate if you're present and your first and last name. For the ACIP members and ex officio, I'll ask you to state your name, affiliation, and whether you have any conflicts of interest. So we'll start with Oliver Brooks.
Oliver Brooks, clinical professor of pediatrics, Charles R. Drew University of Medicine and Science. I have no conflicts. Good morning.
Wilbur Chen.
Wilbur Chen, professor of medicine at the Center for Vaccine Development and Global Health at the University of Maryland School of Medicine. I have no conflicts.
Sybil Cineas.
Good morning, Sybil Cineas. I'm an associate professor of medicine and pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Matt Daly.
Good morning, Matt Daly. I'm a senior investigator at the Institute for Health Research at Kaiser Permanente, Colorado, and also at the University of Colorado School of Medicine, and I have no conflicts of interest. Thanks.
Camille Cotton.
Good morning. Camille Cotton, Clinical Director, Transplant Infectious Disease, Massachusetts General Hospital, and Associate Professor, Harvard Medical School. No conflicts.
Denise Jameson.
Denise Jameson, Dean and Vice President for Medical Affairs, Carver College of Medicine, University of Iowa, and I have no conflicts.
Jamie Lair.
Jamie Lair, private practice, family medicine in Ithaca, New York, and I have no conflicts.
Sarah Long.
Good morning, I'm Sarah Long, professor of pediatrics at Drexel University College of Medicine and pediatric infectious disease doctor from Philadelphia. I have no conflict to disclose.
Robert Schechter.
Rob Schechter, Chief Immunization Branch, California Department of Public Health. No conflicts. Good morning.
Albert Shaw.
Good morning, Al Shaw, professor of medicine in the section of infectious diseases at Yale School of Medicine. I have no conflicts.
And I'm Kip Talbot, professor of medicine and health policy at Vanderbilt, and I have no conflicts. All right, ex officio members, Centers for Medicare and Medicaid Services. Food and Drug Administration.
David Caslow, Office of Vaccines Research and Review, CBER FDA, no conflicts.
Health Resources and Services Administration.
Commander Reed Grimes, representing the Health Resources and Services Administration.
Indian Health Service. NIH.
Good morning, John Weigel from the National Institute of Allergy and Infectious Disease, NIH.
Office of Infectious Diseases and HIV/AIDS Policy. Okay, we'll come back. All right, liaison representatives, American Academy of Family Physicians. American Academy of Pediatrics. American Academy of Pediatrics Red Book. American Academy of Physician Associates.
Good morning.
American College Health Association. American College of Nurse Midwives.
Carol Hayes, present.
American College of Obstetrics and Gynecologists. Obstetricians and gynecologists, pardon me. We'll come back. American College of Physicians.
Good morning, Jason Wolfman, American College of Physicians, President, and congratulations on becoming chair.
Thank you, Jason. American Geriatric Society. America's Health Insurance Plans.
Good morning, Jessica Barton, HIV.
American Immunization Registry Association.
Good morning, Rebecca representing the American Immunization Industry Association.
American Medical Association.
Sandra Breitenberger, representing the American Medical Association.
American Nurses Association. American Osteopathic Association.
Good morning.
Good morning. American Pharmacists Association.
Good morning, American Pharmacists Association.
Association of Immunization Managers.
Good morning, Molly Howell, representing me.
Association for Prevention, Teaching, and Research.
Richard Zimmerman, President.
Association of State and Territorial Health Officials.
Good morning, Nisha Tanya, representing ASTA.
Biotech Innovation Organization.
Phyllis Arthur and Emily Acker, representing SAG. Good morning.
Council of State and Territorial Epidemiologists.
Christine Hahn, present.
Canadian National Advisory Committee on Immunization. Infectious Diseases of America.
Good morning, this is
International Society for Travel Medicine. Okay. National Association of County and City Health Officials.
This is Matt Zahn, representing Pedro.
National Association of Pediatric Nurse Practitioners.
Yes, and representing National Association of Pediatric Nurse Practitioners.
National Foundation for Infectious Diseases.
Good morning, Mama Hopkins and Mama Dalton, congratulations.
Thank you. National Medical Association. Pediatric Infectious Disease Society.
Saran Paulson with kids. Thank you.
Pharmaceutical Research and Manufacturers of America.
Good morning. President.
Society for Adolescent Health and Medicine.
Good morning, everyone. Thank you very much for staying.
Okay. Society for Healthcare Epi. Okay, real quick, we'll try again for American College of Obstetricians and Gynecologists. Okay. And then National Medical Association. Yeah, we'll do that later. All right, we have quorum, which is great to see with our new members, and we're ready to proceed. All right. So first up, hold on, I got to get the right one. Respiratory syncytial vaccines, and we're going to get started with Camille Cotton.
Good morning. So we'll open the session on adult RSV vaccines. Next slide, please. Here's our list of voting members, ex officio members, our amazing CDC co-leads, Michael Melgar and Amadea Breton, all of our liaisons and our consultants. And I'd just like to thank everyone who has worked very, very hard, attended extra meetings, and really gone the extra mile over well, recent months especially, but I really value the opinions, insightful input, and great discussions on our work group calls. Thank you very much. Next slide, please. Dr. Albert Shaw from Yale University will be the incoming work group chair for the adult RSV work group starting, I believe it's July 1st, 2024. Next slide. We have many, many contributors from across the CDC. We have heard from many of them as we have had work group deliberations, and we really appreciate their input, expertise, and insightful input. So thank you very much to everyone. Next slide, please. So the current status is that CDC and ACIP are recommending that adults age 60 and over may receive a single dose of RSV vaccination using shared clinical decision making. We voted on this at the meeting a year ago, June 2023. The recommendation was not product specific, and we said to administer whichever vaccine is available. Next slide. So just to recap our session from February 2023, Moderna presented, I think that may be 2024, actually. So sorry, there's a typo in the slide, I believe. So Moderna presented safety and efficacy data from the first 9 months of follow-up in their phase 3 trial in adults aged over 60 years of age and over. We had a presentation from the CDC on risk stratified rates of RSV-associated hospitalizations in U.S. adults age 50 and over. The CDC gave an update on uptake and implementation of RSV vaccine in U.S. adults age 60 and over during the first season following the recommendation. The CDC and FDA presented on post-marketing safety of the protein subunit RSV vaccines, including the GSK product and the Pfizer product in adults 60 years of age and over. And the CDC presented an analysis comparing the estimated magnitude of public health benefit and potential risk of Guillain-Barré syndrome associated with protein subunit RSV vaccination in patients in adults age 60 and over. For adults age 60 and older who remain unvaccinated, the ACIP agreed with encouraging timing of RSV vaccination in the late summer and early fall to optimize public health benefit. Next slide, please. Recent workgroup discussions have included Moderna's Mrezvia for use in adults age 60 and over, which was approved by the FDA May 31st, 2024. GSK Arexvy for use in adults aged 50 to 59 at increased risk of RSV vaccine received FDA approval earlier this month on June 7th. And we had continued discussion of safety, including the risk of Guillain-Barré following RSV vaccination. And we have discussed a shift from a shared clinical decision-making recommendation to potential universal recommendation in adults 75 years of age and over, potential risk-based recommendation in those aged 60 to 74, and a potential risk-based recommendation in adults 50 to 59. Next slide, please. So we have been reevaluating the shared clinical decision-making recommendation. We made that recommendation for RSV vaccine in June 2023 for adults 60 years of age and over. In addition to the benefits of vaccination, the shared clinical decision-making discussion as intended by ACIP is also meant to include discussion of the potential risk of vaccine-associated adverse events associated with the RSV vaccine, specifically Guillain-Barré syndrome. Since making this recommendation over the past year, we have learned that feedback from healthcare providers that having shared clinical decision-making conversations is not simple in practice. Unlike a universal recommendation where there's a clear call to vaccinate, with the shared clinical decision-making, the call to action is to discuss with the healthcare provider a less clear message. So we thought that a risk-based recommendation for adults 60 to 74 and a universal recommendation for those 75 and over would potentially highlight more clearly for providers and other public health officials which adults are most likely to benefit from an RSV vaccine and provide a clearer recommendation for patients. Next slide, please. Here's our agenda. You'll see we'll have a busy morning. Thanks to all the speakers who've put together their work very, very nicely. Next slide, please. And let's get started.
Okay, we're going to start off with a few presentations from our vaccine manufacturers. Our first one will be the manufacturing presentation by Pfizer about the safety and immunogenicity in non-pregnant adults aged 18 to 59. So we'll go ahead and give the floor.
Today I'll be reviewing updates from our adult clinical trials and from post-licensure. I'll be discussing our RSV bivalent vaccine, a stabilized prefusion F subunit vaccine comprised of RSV-A and B strains. Today, we will be talking through clinical trial data from 3 studies in adults: our Renoir study, our Monet trial, and a real-world effectiveness study. Our clinical trials have formed the basis of our licensed Briscoe indications for both maternal and older adult populations. And the additional data today contributes to the application we submitted for FDA review to expand the indication for immunization to adults 18 to 59 years. This is the RSV PREP Adult Clinical Development Program and the studies that guide an understanding of the safety and efficacy used in this population. Today, I will be reviewing our Renoir study, our pivotal efficacy study through 2 seasons, efficacy data from a real-world study, and safety and immunogenicity from our Monet study in adults who are 18 to 59 years with chronic medical conditions. PREF has demonstrated safety and non-inferiority co-administration with flu and COVID in published and submitted studies, and Pfizer has studies that are ongoing regarding revaccination in immunocompromised populations. I'll start with data from Renoir. Renoir was the global study in over 38,000 participants, 60 years of age and over, that demonstrated safety and efficacy through 2 RSV seasons. As you see in green, surveillance in seasons 1 and 2 was for an average of over 7 months each, for a combined surveillance period that averaged over 16 months through the 2 RSV seasons. The Renoir data demonstrate that efficacy against lower respiratory tract disease due to RSV remained high through 2 seasons following a single dose of PREP. Efficacy in season 1 was 88.9%, shown in dark blue, and efficacy in season 2 alone remained strong at 77.8% in light blue, for a combined efficacy across 2 seasons at 81.5%. The lower bounds of the 95% confidence intervals of all these time points are above 50% each. Cases in each season and across 2 seasons are shown here for cases overall, RSV-A, and RSV-B cases. Both subgroups A and B have been shown to be clinically relevant to lower respiratory tract disease. Based on case accrual, RSV-A was more commonly circulating in study season 2, and RSV-B was slightly more commonly seen in RSV season 1. Observed efficacy was over 80% for RSV-A and B in both seasons 1 and 2, potentially reflecting the first signs of the importance of the bivalent vaccine and coverage of both serogroups. I'll now review data from a real-world effectiveness study performed after implementation of the RSV PREF vaccine in Briscoe this past winter in the United States. This real-world observational retrospective case control study we conducted with Kaiser Permanente in Southern California uses a test-negative design. In the gray box to the right, you'll see that this analysis' source population included adults 60 years and older who were either hospitalized or seen in an emergency department with lower respiratory tract disease events. Study events with test results were categorized as cases or controls based on RSV positivity, and participants were stratified by a Briscoe vaccination status. We leveraged the large KPSC network and increased RSV test results for this study by salvaging nasopharyngeal and nasal swabs collected for other respiratory pathogens. The primary analysis controls were pre-specified as negative for RSV, human metapneumovirus, flu, and SARS-CoV-2, and positive for non-vaccine preventable disease pathogens. A sensitivity analysis was also conducted using any RSV negative as a control. Here's the data. In the primary analysis involving 1,336 hospitalizations and visits, vaccine effectiveness was 89%, with a 95% confidence interval from 52 to 97% as shown in the box in the table on the upper right. These results are similar to those I showed from Renoir, but this study expands on those results by using a clinically severe endpoint and by having a study population that includes persons at the highest risk of severe disease. Specifically, 57% of the study population is over 75 years of age, 93% had at least one Charleston comorbidity, and 14% were immunocompromised. Results from a sensitivity analysis with the use of any RSV negative samples as controls was comparable. The study is planned to continue in order to provide vaccine effectiveness in patient subgroups and through subsequent RSV seasons. I'll now discuss data from our MONET study in adults 18 to 59 years of age with chronic medical conditions. There is an accompanying sub-study in MONET for adults over 18 with immunocompromising conditions that are receiving 2 doses of the vaccine. This sub-study is still ongoing, and that data will be available later this year. Our application for licensure in adults 18 to 59 years was driven not only by the successful MONET study, but also by the acceptable safety profile demonstrated in over 5,400 adults aged 18 to 59 years of age from our maternal and adult clinical studies. MONET was a double-blind study with a 2-to-1 randomization with pre-F or placebo. Participants had immunogenicity blood draw assessments before and 1 month following vaccination. Safety assessments were obtained through 6 months, including self-reported electronic mobile diaries during the first week. The immunogenicity samples in this study were compared to a historical cohort from the Renoir study, in whom blood was taken at the same time points. The patient demographics are shown for the pre-F and placebo groups here. By design, the study was racially and ethnically diverse, and we had an approximately equal number of persons below and above 50 years of age, as comorbidities increased with increasing age in this population. Participants all had to have at least one pre-specified medical condition, with about a third having 2 or more. The most common were chronic cardiopulmonary conditions, followed by diabetes. The comorbidities by type were similar between the vaccine and placebo groups. Electronic diary reported local reactions, grouped on the left, were more common in the pre-F recipients compared to placebo. These results are comparable to other non-adjuvanted subunits vaccines, and the intensity scores were mostly mild in green or moderate in blue, and resolved on an average of 1 to 2 days. On the right, we show the systemic events. These were similar between pre-F compared to placebo, with the exception of muscle pain, which was slightly higher in the pre-F group. Adverse events were not common, but were similar in incidence for any event through 1 month following vaccination between the pre-F group at 6.8% and placebo group at 7.6%, as shown in the top row. Severe and serious events were rare, and there were no related serious adverse events, or SAEs. There were no adverse events of special interest, including no cases of Guillain-Barré or atrial fibrillation observed in this population. Regarding the immunogenicity endpoints, the success criterion was met by 4 co-primary endpoints. An analysis of covariance model was used to adjust for participant gender and baseline titers. The first 2 endpoints shown in the top figure evaluate the neutralizing titers 1 month following vaccination in adults 18 to 59 years with comorbidities in a ratio against samples from those 60 years and older from the prior pivotal Renoir study. The geometric mean titer ratio, or GMR endpoints, met the 1.5-fold non-inferiority margin for RSV A and B, with lower bounds well above the 0.667 value shown with the dotted line. Similarly, seroresponse endpoints were also met for RSV A and B, as shown by the bottom figure, with lower bounds well above a negative 10% difference. I'll summarize these studies in my last slide. The clinical development plan presented today and previously supports the use of Abrismo in adults 18 years of age and older, including use in pregnant persons, those with underlying chronic conditions, and in the elderly. The Renoir study demonstrated efficacy for 2 years with strong efficacy for RSV A and B maintained in season 2. Preliminary real-world observational data reinforces its efficacy in an older and sicker population, largely with comorbidities. RSV pre-F given to adults 18 to 59 years of age from the MONET study demonstrated robust immunogenicity responses with an acceptable safety profile. The data presented could extend our indication for adults down to 18 years of age. I'd like to thank our clinical trial site partners for all of their work, and I would now be happy to take any questions.
We'll have a few minutes for questions, but before we start, I'd like to make sure everyone has their computers on mute and also sound off, because apparently there's some issues with sound for those that are online. Open for questions. Yes, Sarah.
Good morning, thank you. That was very informative. I have a comment more than a question. It's about the post-licensure study, retrospective case control, negative control study. It's very helpful for us to see that so many of the enrollees were 75 and older, as we hadn't seen that data pre-licensure. And the other was striking to me was that 93% of those who came to the emergency room or were hospitalized with RSV disease or another identified virus, 93% had comorbidities, which is much higher than we would expect from our data that we have from the population at large, at least at 50 and above. And I think it will help me understand a little bit better the risk-based recommendations that we'll consider later. Thank you.
Jamie?
Thank you for your presentation. Could you go to slide 10 for me? Tell me if I'm reading this slide correctly, but it seems that the test positive cases added up to 576, and the test negative added up to 760, which suggested about 40% of the people tested were RSV positive. That just seems very high to me, and I'm wondering if I'm reading this slide correctly. Thank you.
Would Pfizer like to comment? Have we muted Pfizer?
Apologies, I had some difficulties getting off mute there while sharing the screen. So regarding slide number 10, I'll bring it up just now. In the cases, we had 576 of the cases test positive, and that was due to the salvaging of swabs. Our test negative controls in this primary design had to be positive for non-vaccine pathogens, but as you see from the sensitivity analysis, controls with any RSV negative were comparable. I have our clinical partner on the line, Sarah Tartoff, from the site in which this was conducted, and she may have anything additional to add.
Hi, thank you. I apologize. I'm having a little bit of technical difficulties, and I'm not seeing the slide. I'm not sure if my colleague Nagar at Pfizer is able to see the slide.
Sarah, we're not able to see the slide either.
Yeah, the question is just regarding the number of RSV positive cases that we had in the study, where we had 576 total test positive cases for RSV, and I think the question was, why are we seeing such a higher rate? And I think Iona addressed this in her response, in that we don't normally see high rates of RSV testing in the clinical setting. In some studies elsewhere, we've seen rates of 4.3% among older adults admitted with LRTIs who test positive for RSV. In this study, one of the advantages was that we didn't rely only on clinical testing, and we salvaged a large number of swabs from people who came in with other lower respiratory tract disease and had swabs collected that weren't tested for RSV. So we did see a larger proportion testing positive. I don't know if that answered the question, or Sarah, you want to add anything else?
I had
don't have anything else to add at this time. Thanks.
Sarah Long. I had a thought about that, Dr. Lehr, when I saw it, and that is related to Dr. Daly's population. This is a Kaiser Permanente group. I would assume they're highly vaccinated against influenza and coronavirus, so they had to be negative for that. So it's not a population at large, but probably a skewed population who would be less likely to come to the emergency room and be hospitalized with the two biggies, influenza and coronavirus. So what's left? RSV is the next most serious.
Are there any further questions from the committee?
Yes, Dr. Sineas.
Good morning, thank you. Could you go to the slide on the adverse events between vaccine and placebo groups? And could you comment on the adverse events leading to death in the treatment group? Or
May I ask a question from ASTO?
Are we unmuted now?
We have a couple questions here still. Just a moment. Thank you. No, you're fine. Thank you.
Can we get audio check, please? Somebody? Kip, can you do an audio check, please?
Yeah, audio check.
Yes, thank you. We can hear the audio now, but can't when others are talking.
But what?
Did you hear the last question from Dr. Sineas?
We did not. Would you mind repeating it, please?
yes, on the slide on the adverse events comparable between vaccine and placebo groups, there is an adverse events leading to death in the vaccine group. And could you comment on what that was?
Yes, absolutely. So this was a death case that was not related to vaccination that occurred on post-vaccination day 106. This was a 57-year-old male, and although we don't have any further details of the cause of death, he was known to have significant comorbidities, including hepatitis A, hypertension, type 2 diabetes, hyperlipidemia, depression, and steatohepatitis. A further investigation was made, but cardiopulmonary arrest was the final diagnosis made.
Thank you. We have one more question from Dr. Daly, and then we'll move to ASTO. Okay. ASTO?
Sorry, thank you. Given the description of the way the swabs were done and then additional testing done on tests that may not have originally tested positive or been tested for RSV, would that suggest that there may have been co-infection, or do you have rates of co-infection with any other viruses that were identified on any of the patients that were tested?
Thank you. We do have those rates of co-infection, and further analyses are ongoing as the study numbers continue. I'll hand it over to Dr. Tartoff again if she would like to add anything.
Yeah, thank you. Co-infection was quite rare in our study. We had 23 cases. We did conduct a sensitivity analysis where we removed cases with co-infection, and we found very, very similar results to the original infection. I also, if it's all right, I would like to return to the first question on the study and respond about why the proportion of cases is so high. I think this is because of the way we construct our control definition for the primary analysis, which is, for this, when we select controls, we selected those that were positive for non-vaccine preventable diseases. So when we have our broad definition, which was one of our sensitivity analyses, and we look at all RSV negative controls, we have a much, much larger control group, and the proportion that are RSV positive is much smaller. But from the way we construct our strict definition, which is the primary analysis, we only include those that are positive for a non-vaccine preventable disease, which substantially reduces the size of our control group. Thank you.
Thank you, and we'll close this part of the session. Due to time, I am going to ask that everyone in the room please log out of the meeting. There's some interesting sound problems going on, which we've never had before. So if you would just log out of the meeting completely, we're hoping this will help. Okay. Camille, is this about this presentation?
It was relating to the Pfizer study.
Yeah, go ahead, quickly.
Okay. So could Pfizer comment, it looks as though they used historical controls from prior years from the Renoir study to compare with the more recently vaccinated people for immunobridging comparisons. Could you explain, did you in fact use historical controls, and if so, why did you decide to do that rather than enrollment in the same vaccine year? Thank you.
Yeah, thank you very much. Your interpretation is correct. We used historical controls from the Renoir study, and the reason that we did that was the pivotal efficacy study in which we did demonstrate vaccine efficacy over 2 seasons. So using the neutralizing titers from that study was the immunobridge comparison to the younger age group.
Okay, I would just highlight that that is a historical control, and so the ACIP should consider that in their deliberations. Thank you.
Thank you. We'll move on to a presentation by GSK about the immunogenicity with a 24-month revaccination interval. Dr. Gerber?
Hello, thank you very much. Can we please have screen share for GSK screen share? Thank you.
You've been made a co-host, so you just need to share your screen from the Zoom meeting.
Please share with GSK screen share. Thank you. You hear me?
Yes, Dr. Gerber, we can hear you.
Yeah, thank you very much. Could we please have GSK screen share?
I believe you already have it. Oh, sorry, they're working on it. My apologies.
No, that's okay. Thank you very much. Thank you, thank you.
What the hell's going on?
Thank you very much. Good morning, and thank you for the opportunity to provide a 2-year update on RSV. I'm Dr. Susan Gerber, Medical Director at GSK. First, we'd like to share that the FDA recently expanded the indication for Arexvy to include use in adults 50 to 59 years of age who are at increased risk for lower respiratory tract disease or LRTD caused by RSV. And this is important because 13 million adults 50 to 59 years of age and 30 million adults 60 years of age and older have at least one diagnosed risk factor for severe RSV disease, with a significantly higher prevalence among Hispanic and non-Hispanic Black adults compared to non-Hispanic white adults. Let me now update you on the results from GSK's immunogenicity study 004. Here is the study design for 004. The vertical line in the middle indicates the current analysis and results at the 25-month time point. The top line in green is the 1-dose group, participants who received 1 dose of vaccine at day 1 and who were not revaccinated. The line underneath in purple is the RSV annual group, those participants who were vaccinated at 12-month intervals. The bottom line in pink is the RSV month 24 revaccination group, who received the initial first vaccine dose at day 1 and who were revaccinated at month 24. Approximately 30% from each group were evaluated for cell-mediated immune measures. The grayed out part on the right represents a study extension to 60 months and includes a re-randomization of the one-dose group. Roughly half the participants in this group will be revaccinated at 36 months. Also, the RSV annual revaccination group will continue to be followed and evaluated. The RSV M24 revaccination group will be revaccinated again at 48 months. Here are the 25-month results that reflect RSV-A and RSV-B neutralizing antibody responses after the initial vaccination at day 1, and then revaccinations at months 12 and 24. First in green are the results after one single vaccine dose administered at day 1, up until 25 months. There are robust RSV-A and RSV-B neutralizing antibody responses 1 month post-dose observed, followed by initial waning that then plateaus. Next in purple, we see the annual revaccination group that received vaccine doses at day 1, month 12, and month 24. Although there were increases in neutralizing antibodies observed 1 month after the 12 and 24-month revaccinations, the neutralizing antibody titers observed at 13 and 25 months do not achieve the same magnitude as compared to the response observed after the initial vaccine dose at 1 month. Next in pink, we see the RSV M24 revaccination group. This group received the initial vaccination at day 1 and then an additional revaccination at 24 months. You can see for both RSV-A and RSV-B neutralizing antibody responses that the magnitude surpasses the annual vaccine group at both the 13-month and 25-month time points. Although this interval of 24 months between vaccine doses does not demonstrate neutralizing antibody responses to the same degree as 1 month after the initial vaccine dose, these results indicate that there is a potential relationship between extending the time interval between vaccine doses and an increase in neutralizing antibody responses. And when we look at RSV pre-F3 CD4 positive T cell responses for each of the revaccination groups, responses are increased after each vaccine dose. Here we see results of pre-revaccination RSV-A neutralizing antibody titers and resultant seroresponse rates 1 month post-revaccination dose. On the left are study participants who were revaccinated annually at 12 months, and on the right, those who were revaccinated after an interval of 24 months. On the x-axis, individuals included in the annual or M24 revaccination groups were equally distributed into 4 quartiles related to their neutralizing antibody titers at the time of revaccination at either 12 or 24 months respectively. On the y-axis are the percentage of individuals with seroresponse rates, defined as at least a 4-fold increase in neutralizing antibody titers at the time of revac. The lower the pre-revaccination neutralizing antibody titers, represented in quartile 1, the higher the 1 month revaccination seroresponse rate. The results are the same for RSV-B. Overall, the safety and reactogenicity profile in individuals who were revaccinated at month 24 were similar as compared to the first vaccine dose. In summary, revaccination at a 24-month interval provides higher RSV-A and RSV-B neutralizing antibody titers as compared to a 12-month interval. The lower the pre-revaccination titers, the higher the seroresponse rates after revaccination. Future results from this trial will help inform optimal revaccination timing. Now let me provide a brief post-marketing safety update. With approximately 8 million doses of Arexvy administered in the US, post-licensure safety surveillance after 1 year reflects the acceptable safety profile observed in our clinical trials. With respect to GBS, reports to GSK have not exceeded the expected background incidence using established rates in the literature. Some other more recent analyses have compared reporting rates of GBS and VAERS following RSV vaccines to those with COVID vaccines during the pandemic. These should be assessed with caution. Well-controlled analyses using appropriate comparative incidence rates, such as the rapid cycle analysis in the Vaccine Safety Data Link and the BEST initiative, will provide additional assessments of GBS following Arexvy vaccination. The totality of evidence support our assessment that the safety profile of Arexvy remains unchanged and acceptable. Let me highlight a few aspects from GSK's RSV clinical development program. Third season efficacy data from the pivotal study 006 will be available soon. These results, along with continuation of the 004 immunogenicity trial, will help inform decisions related to revaccination timing. Study 025, currently in progress, includes adults 18 to 49 years of age at high risk for RSV LRTD, comparing safety and immunogenicity to adults at least 60 years of age. These results will be available later this year. Importantly, I'd like to add that the immunobridging study 018 that included adults 50 to 59 years of age at high risk for RSV LRTD showed an acceptable safety profile and comparable immunogenicity to adults 60 years of age and older, inferring high vaccine efficacy. Over 2 calendar years, Arexvy provides high and consistent efficacy against RSV-associated LRTD and severe LRTD, and with advancing age, as well as high and consistent efficacy against RSV-associated LRTD among vulnerable individuals. In conclusion, immunogenicity data supports the potential for revaccination with Arexvy. Results from future time points in the ongoing phase 3 studies will help inform revaccination timing. Overall, Arexvy provides protection over 2 calendar years and continues to have an acceptable safety profile following administration of approximately 8 million doses. Recent FDA label expansion will make Arexvy accessible to approximately 13.4 million individuals 50 to 59 years of age with diagnosed medical underlying conditions that place them at increased risk for severe RSV disease, and will help to address disparities with respect to RSV-associated hospitalizations among Black Americans, Hispanic Americans, American Indians, and Alaska Natives as compared to non-Hispanic white Americans, thus helping to close this equity gap ahead of the upcoming RSV season. GSK would like to thank all the study investigators and trial participants whose contributions are greatly appreciated. Thank you for your time. Now we're happy to answer any questions.
Thank you. And they ran a little bit over, so we have 2 minutes for questions. Dr. Cotton? Dr. Long.
Thank you. I think I remember you presenting some data about revaccination in the work group considerations, and it seemed to me there was more fall off at 12 months of efficacy in your trial, and that the boost in the neutralizing antibody did not increase efficacy at 12 months. And I appreciate that's not as high a level as after the first dose, but it would certainly seem to be a level that should have been more highly protective. Do you have any comment about this?
No, thank you very much for that question. I think I can comment that there was a response at 12 months that did actually increase neutralizing antibody titers, though not to the degree as 1 month post first dose of the revaccination. What was increased was at 24 months as compared to 12 months. The neutralizing antibody titers for both RSV-A and RSV-B actually increased as compared to the 12-month time point. Efficacy, we have found that Arexvy has protection over 2 calendar years.
Dr. Cotton.
Thank you for your presentation. So it looks as though GSK is sort of honing in on a updated vaccine recommendation for 2 years after the first dose, potentially. I have to say, I'm not really sold on that, and I'm wondering, this is a fairly expensive vaccine. It is $300 plus close to $300 plus administration fees, and so far I'm not seeing a need or data showing vaccine efficacy at 2 years. So I would encourage GSK to think about additional clinical data. I know that the country is currently really suffering from vaccine fatigue, overload. Many people feel that they're done with vaccines, they've had enough. So before we would consider incorporating this into a routine schedule just based on immunogenicity data, I would hope that we would have additional trial data really supporting the need at either 2 years, 3 years, 5 years, whatever it might be, especially where we are considering vaccinating people who are younger and might live, decades. And so what would that vaccine recommendation actually look like? Furthermore, I'm not really seeing significant data in the immunocompromised patients, and although you were able to show interesting results that people who had a lower initial response had a higher second response after the second vaccine, I don't think we've seen that for immunocompromised, and my understanding is that trial you mentioned is a very small number of patients. So I'm really hoping that for the estimated, according to the most recent CDC data, 7% of Americans who are immunocompromised, that you would be able to provide better data, and not just immunogenicity data, but clinical trial data. Thank you.
Thank you very much for that question. First, I'd like to say that we will have upcoming third season efficacy from the pivotal efficacy trial 006. Those third season efficacy results will be available soon in the coming months. In addition, we are going to have 36-month immunogenicity data from study 004. Together, these phase 3 trials will help to inform revaccination timing and strategy, and actually will help with decision making. From the data presented today, we see a stronger immune response at the 24-month interval, and that gives us confidence that Arexvy can be used for revaccination.
Can I? Oh.
Yes. Dr. Shaw.
Yes, and just to add one more.
Yeah, hang on. We have a couple questions and we're already out of time, so if you can hang on. Dr. Shaw?
Oh, thanks. I just had a question. There's quite a range in the seroresponse rates, and do you have any information on clinical correlates of the post-vaccine response? Is it number of comorbidities? I mean, who does better than the other folks do? And the second question was, are you going to analyze CD8 T-cell responses? Is that also in the plan?
Thank you very much. No systemic trends were observed in association with different subgroups within this 004 study. We did not see any trends when we looked at different groups. We did see that immune responses were consistent amongst participants. In addition, we are actually continuing the study, and we will have 36-month immunogenicity results that will be available soon in the coming months. And just to make a quick comment on
Dr. Gerber, I believe we're out of time. I think, Dr. Brooks, did you have a question? Okay. Thank you very much. We would eventually love to see that data, and looking forward to the third year of the study. We're going to move on.
Thank you.
To Moderna's presentation about season 2 safety and efficacy.
Can I get the screen share rights, please? Okay, great. Great, thank you very much. Good morning, my name is Rita Das, and I'm the head of respiratory vaccines at Moderna. I'll present to you our update on mRESVIA, Moderna's RSV vaccine. Mrezvia, or mRNA 1345, was licensed in the US on May 31st. The indication is for prevention of RSV lower respiratory tract disease, or LRTD, in adults 60 years of age and older.
Dr. Das,
Yes.
can you be a little bit louder? Thank you.
Sure, I'll move closer to the microphone. It's available in a pre-filled syringe to administer without reconstitution. Here's an outline of what I'll discuss today. Study 301, the pivotal trial, was a randomized, double-blind, placebo-controlled study conducted in 22 countries. All participants are planned to be followed for 2 years. More than 50% of the trial was enrolled in the US, and here are the analyses to date against the backdrop of US RSV hospitalization rates in adults 65 and over. This is shown in the orange line. The vaccination period was from November 2021 to December 2022, shown in the purple line at the top. The primary analysis, the blue line, was case-driven, based on 85 RSV LRTD cases, which were achieved in November of 2022. The DSMB reviewed this analysis to declare study success. When almost all study participants reached 6 months of follow-up, an additional analysis, shown in the green line, was conducted. 2 RSV seasons were covered in this analysis, with a median follow-up of about 9 months. In March 2024, we conducted a third analysis, shown in red. The median follow-up here was almost 19 months, and 3 RSV seasons were covered in this analysis. All the RSV vaccine efficacy studies were conducted differently. We used comprehensive RSV surveillance year-round during Study 301, with weekly e-diary prompts for symptoms. All confirmed RSV cases were included in the efficacy assessments. The study covered 3 RSV seasons, including the 2 recent seasons in which high transmission of RSV was observed. As a result, we identified more than 680 confirmed cases of RSV to provide a clear picture of vaccine performance over this study period. We enrolled over 36,000 adults. The demographics were well matched between vaccine and placebo recipients. 30% of study participants were 70 to 79 years old, and approximately 3,000 participants were 80 or older. The racial and ethnic makeup was representative of the US population, and more than 20%, 8,000 participants, were classified as frail. Numerous conditions increased the risk of severe RSV. Approximately 1/3 of our study population, nearly 11,000 participants, had 1 or more of the comorbidities shown here. First, I'll review the safety data from our most recent analysis. Occurrence of adverse events, regardless of their relationship to vaccine, were balanced between the study arms. Serious adverse events leading to discontinuation, adverse events of special interest, and severe adverse events also were balanced. Looking more closely at the adverse events of special interest, there were no cases of acute disseminated encephalomyelitis. There was no safety concern with Guillain-Barré syndrome, or GBS. 3 GBS cases have been reported in the study to date, 1 in a vaccine recipient and 2 in placebo recipients, all more than 500 days after vaccination. There was no imbalance in other neurological disorders, such as Bell's palsy or facial paralysis. For cardiac events, there was no imbalance in cardiac arrhythmias, including atrial fibrillation. We routinely perform surveillance for myocarditis and pericarditis in all our studies and send any potential cases to a panel of independent cardiologists for confirmation. There was no myocarditis identified in vaccine recipients, and there were no pericarditis cases within 6 weeks of vaccination. Moving now to efficacy. Here are the efficacy data that are in our approved product prescribing information. Vaccine efficacy against RSV, lower respiratory tract disease with 2 or more or 3 or more symptoms, was about 80% in the primary analysis and 62% in the additional analysis. The lower bounds for the confidence intervals for both endpoints were above 20%, which were the pre-agreed success criteria for the study. And now here is the 18-month analysis from the March 2024 data. Efficacy for both endpoints, RSV LRTD with 2 or more symptoms and with 3 or more symptoms, was approximately 50%. Here are the efficacy results from the full 24-month analysis from the March 2024 data, along with the analysis of risk groups. Efficacy is consistent in participants 70 to 79 years old. Now with more cases, it's also consistent in those 80 years and older. Efficacy is also consistent in participants with comorbidities and participants who are vulnerable or frail, confirming that the efficacy of mRESVIA is maintained in those people who are at increased risk for RSV. Shortness of breath has been shown to be associated with poor outcomes in older adults, such as seeking a higher level of care or hospitalization. As there were very few RSV hospitalizations in this clinical trial, we used this symptom as a proxy for severe disease. Vaccine efficacy to prevent RSV LRTD with shortness of breath was high across all study analyses. It was 57% at 18 months. As expected, since protection due to natural RSV infection is not lifelong, there have been lower estimates of vaccine efficacies over time seen with all RSV vaccines. This figure shows the best fit line for efficacy of mRESVIA over time, modeled based on the actual efficacy from the trial calculated in 2-month intervals. The decline for mRESVIA is approximately 2.4% per month. Now we turn to revaccination. The data here come from a different trial, Study 302. Study 302 initially assessed co-administration of RSV vaccine with standard dose influenza vaccine and Spikevax. Co-administration was well tolerated, and immune responses to co-administration were consistent with the single vaccine administration. In the next part of the study, we revaccinated 500 adults 50 years of age and older with mRESVIA 12 months after the first dose. The rates of local and systemic reactions were generally balanced between revaccination and the initial dose, and there were no reports of the events listed on this slide. Here are the RSV-A neutralizing antibody response results from the study shown as an example. Antibody levels were above baseline through 12 months post the initial vaccination. After revaccination, neutralizing antibodies were similar to the level following initial vaccination. The geometric mean titer ratio between revaccination and the initial dose was 1.08 for RSV-A, meeting the pre-specified criteria that were agreed upon with the FDA. These success criteria were also met for RSV-B, with a GMR of 0.91. This confirms that for mRESVIA, revaccination as soon as 1 year after the initial dose is immunogenic and returns antibody titers to the same level as seen after initial vaccination. So in summary, our RSV vaccine, mRESVIA, was well tolerated in over 19,700 adults age 60 and older. There were no cases of ADEM, vaccine-related cases of GBS, or any other safety concerns. The vaccine was shown to be efficacious through a median of 19 months of follow-up. Efficacy was comparable regardless of age, including in those 80 and older, presence of comorbidities, or frailty status. The vaccine prevented severe disease as evaluated by prevention of RSV with shortness of breath. As presented at the February ACIP meeting, strong antibody and cellular CD4 and CD8 T-cell responses to mRESVIA were observed. Now we see that immune responses were durable through 12 months. And revaccination, as soon as 1 year after primary vaccination, elicited responses similar to that following primary vaccination. Revaccination was well tolerated with no safety concerns. As shown in our last ACIP presentation, pre-specified immunogenicity criteria were met and no new safety concerns were observed with co-administration with standard dose influenza vaccine or with Spikevax. This concludes our presentation. Thank you so much for your attention, and I'd like to thank the individuals listed here who made this study possible. I'd be happy to address any questions.
Thank you. Any questions from the voting members? Dr. Chen.
Thank you, Dr. Das, for that presentation. I think it was slide number 21, the immunogenicity revaccination slide. Do you have a breakdown of the antibody titer declines over time for the different age groups? Because I think that was a summary for all the participants 60 years of age and older, and I'm wondering if there are age effects.
Yes, so we have that done, and you're right, this study was done in 50 years and 50 years and older. So we have that breakdown done, and so 50 to 59 versus 60 plus is also the same. It is very similar. We've also done this for age groups above 60, and it looks quite similar as well.
So in other words, there were not age effects that you could detect, and did you look at decades, older decades, 70 plus years of age or 80 plus years of age?
Yes, so in this and in our pivotal immunogenicity study, we have not been able to detect any differences in the kinetics of the immune response. So specifically, those over 75 or those over 80 do not decline, do not have a more rapid decline in what we've observed. And the boosting here and the revaccination here is also very similar across decades.
Thank you, Dr. Brooks.
Yes, thank you for the presentation, and I laud you for the diversity in your clinical trials. So my question is, did you have any difference in responses based on the different groups in your in the clinical trial, in terms of either clinical or GMT responses?
Yes, thank you for that. We worked really hard on our clinical trial diversity. So we have looked at efficacy by race and ethnicity subgroups, and there is no difference. We also analyzed the revaccination data by ethnicity subgroups, and we do not have any differences in the immunogenicity or the revaccination.
Thank you.
Any other questions from voting members? Okay. Thank you very much. We're going to move on to a little bit of a different set of presentations. We're going to look at vaccine safety. I'm going to let the committee know that we are going to have both presentations, and at the end, we'll take all the questions. So if you need to write them down so you remember them, that would be great. So our first speaker is Dr. Donahue, who's going to talk about data from the vaccine safety data link.
Okay, thank you, Dr. Felton, and thanks for the chance to speak today to provide an update on the safety surveillance for the RSV vaccine in older adults in the vaccine safety data link. Next slide, please. So I'll start with just a brief description of VSD and the rapid cycle analysis approach, then review our methods, and then get into our findings so far. Next slide, please. So, as I'm sure most of you know, VSD was established decades ago now to provide improved vaccine safety using active surveillance and epi studies. And it has electronic health record data on over 13 million people every year from the sites that are shown on this map. Not all these sites are data providing, most are, and 9 of these sites contributed data for this analysis. And VSD is well suited to evaluate the safety of new vaccines like RSV. And the rapid cycle analysis, which I'll discuss next, was developed to do just that. On the next slide. So rapid cycle analysis permits prompt assessment of vaccine safety using near real-time data. And in general, outcome incidence in vaccinated people as compared to outcome incidence in the comparator group, with analysis typically done on a weekly basis, but can also be weekly, bi-weekly, or monthly. And because we're doing analyses so frequently, sequential analytic methods are used to detect statistical signals while maintaining a predefined type 1 error rate. And just to refresh your memory, type 1 error is when you mistakenly reject the null hypothesis of no association, and otherwise known as a false positive. So signals that we find, if we find any, are interpreted as potential associations, and further investigation is required before we can conclude that we actually have a safety concern. Next slide, please. So our objectives for the RCA are to monitor vaccine uptake in VSD, monitor the occurrences of pre-specified outcomes following vaccination, and conduct near real-time surveillance for those pre-specified outcomes. Next slide, please. So this is a prospective cohort analysis in which the study population consists of RSV vaccine recipients who are at least 60 years of age and members of a participating VSD site. We extract the data weekly, but we conduct our sequential analysis anyway every other week. And the surveillance period goes from August of 2023 through the end of May of 2025. And the project is going to end September of 2025. Next slide, please. And as mentioned, we do sequential analysis every other week that tests a one-sided null hypothesis that the vaccine does not increase the risk in the risk interval. And a statistical signal occurs when an analysis produces a one-sided p-value that is less than the pre-specified threshold. And that threshold is determined from an alpha spending plan that keeps the overall chance of a type 1 error less than 0.05 throughout the entire surveillance period. The formal sequential analysis, if we did get a signal, stops, but surveillance will continue. This design and analysis is really similar to that was used in the VSD RCA of the COVID-19 vaccines. Next slide. The primary risk interval for all our outcomes is 1 to 21 days following RSV vaccination, except for anaphylaxis and CIDP, which we monitor only. The primary comparison interval is 43 to 63 days, but we also have a secondary comparison interval of 22 to 42 days. And we also have a secondary risk interval of 1 to 42 days with a comparison interval of 43 to 84 days. Next slide, please. So this analysis uses vaccinated concurrent comparators. This is an approach developed by our colleagues at Kaiser Northern California and was used in the COVID-19 RCA that I mentioned just a minute ago. The comparators are RSV vaccinees who on the same day as the exposed case in a risk interval were in the same stratum. In other words, they had the same age group, sex, race, ethnicity, and VSD site, but they were in a comparison interval. So the comparators are in fact vaccinated with RSV vaccine, but they are further removed from their vaccination date compared to people who are in their risk interval. And the outcome incidence is computed during the risk interval compared with incidence in the comparison interval, and rate ratio estimates are computed with 95% confidence intervals adjusted for calendar time, age group, sex, race, and VSD site. And this type of comparator group is expected to have fewer differences and less bias compared to unvaccinated persons who would be comparators or other comparator groups. And this is particularly important for RSV vaccines because they are recommended based on shared clinical decision-making and targeted to those who are chronically frail. So hopefully it would be, for instance, less confounding by indication, which might happen, for example, if someone with a chronic illness is more likely to seek RSV vaccination. And they may also be at increased risk of some condition of interest, such as atrial fibrillation. Next slide, please. And so this slide is just sort of a visual relationship, shows a visual relationship between the risk and comparison intervals when using vaccinated concurrent comparators. So on each calendar day that an outcome occurred in a vaccinee, let's say June 3rd, we compare vaccinees in their risk interval with similar vaccinees in their comparison interval. And again, similar here means people who are in the same age group, sex, race, and VSD site. Next slide, please. So for this analysis, we have 4 exposure groups: GSK vaccine with and without another vaccine administered on the same day, and Pfizer vaccine with and without another vaccine administered on the same day. And analyses are conducted separately for each of these 4 exposure groups. Next slide, please. And these are the pre-specified outcomes for this RCA. I won't go through the entire list, but they include outcomes that are relatively common in this particular age group anyway, is AFib, and some that are less common or rare, such as GBS. Next slide, please. So now move on to the results, and this table shows the total number of RSV vaccines administered to older adults in VSD through May 25th of 2024. And nearly 9 of 10 RSV vaccines were GSK, the remainder were Pfizer. We did have a few vaccines that were unspecified with respect to the manufacturer, but it's a really small number, and so all subsequent analyses and slides exclude those vaccines with unspecified manufacturer category. Next slide, please. And this graph shows the total number of RSV vaccines administered per week by manufacturer and overall. And GSK is shown in blue, Pfizer in orange, and the totals in light green. I also have a vertical red line there to indicate that that's when we began our sequential analysis, which was about mid-March. And you can see that we had lots of data in the bank at the time we started the sequential analysis. We're adding to it each week, but only in pretty small increments, as you can see here, probably 2,000 to 3,000 a week. Next slide, please. So now moving on to our sequential analysis results. Next slide, please. We've had 6 runs of the sequential analysis of results that I'm reporting here with data through May 25th of this year. And this table lists the outcomes for which we do sequential analysis and summarizes the results so far. We've had one statistical signal. It was in the very first analysis that we did, and it was for immune thrombocytopenia, ITP. Next slide, please. So this is the table from that very first analysis showing a signal. And the signal occurred in the 1 to 21 day risk interval compared to the 22 to 42 day interval among people 60 years of age and older who were administered GSK vaccine without simultaneous vaccination. And right next to that cell-shaded red, it says yes, is the number 19. That's the number of ITP events in the risk interval. And the number next to that is 6. That's the number of events in the comparison interval, the 22 to 42 day comparison interval. The adjusted rate ratio just further down on that row is just a little over 3 with a 95% confidence interval of 1.2 to 8.5. The p-value for the sequential test is 0.012, and so it's just under the threshold of 0.014. And since it is, that's why we have a signal. Next slide, please. Next slide. There we go. So we were obviously really interested in whether ITP cases were real or not, so we asked the VSD site to do a really quick or preliminary review of the 19 cases of ITP in the 1 to 21 day risk interval. And to speed things along, we really just wanted to, not the detailed medical record review that we usually do, but basically the answer, was this ITP, was it in this case, and did signs and symptoms of ITP begin after RSV vaccination? So in addition, next slide, please. In addition, we asked them to do 6 cases in the 22 to 42 day comparison interval, and next slide, the 8 cases in the 43 to 63 day comparison interval, for a total of 14 ITP cases in comparison intervals. Next slide, please. And so the results are that of the 19 cases in the risk interval, 4 were considered to be incident, that is, a new case relative to RSV vaccine. And of the 14 cases in the comparison intervals, 2 were considered to be incident, 1 in the 22 to 42 day interval, and 1 in the 43 to 63 day interval. So it appears from this preliminary review that most of these ITP cases were not related to RSV vaccine. Since that signal in the very first sequential analysis run back in mid-March, there has been 1 additional case in the risk interval and 1 additional case in the 22 to 42 day comparison interval. So our plan going forward is to do a detailed chart review of these cases and any cases in this group going forward. Next slide, please. So I'd also like to present our results for GBS because it was observed in the randomized trials for both RSV vaccines, and we have no statistical signal for GBS, but we did observe some cases, and they're summarized on the next slide. So we have 12 cases that were observed after RSV vaccine in the automated data. 11 have been reviewed and adjudicated. 1 is pending. Of the 11 reviewed cases, 2 were excluded as not GBS. And of the remaining 9 cases, 7 were given a Brighton diagnostic certainty level of 1 to 3, and 2 were classified as BL4, which basically means we have little or no information with which we can elevate their diagnostic certainty above simply a diagnosis code in the automated data. The 7 cases that are Brighton level 1 to 3 had onsets of after RSV vaccination ranging between 6 and 76 days. Next slide, please. The results of the sequential analysis are shown here. They include GBS cases that are confirmed as Brighton level 1 to 3, so no Brighton level 4 cases. And the far right column is shaded light green and shows that the p-values, the one-sided p-values for the sequential test are all well above the threshold of 0.014, but it is important to note that we have relatively few cases. Our exposed population is relatively small for a rare outcome such as GBS, and so we don't have a lot of power. And this is particularly true for Pfizer vaccine, which is sort of underrepresented. So next slide. This slide shows crude incidence rates. This has nothing to do with sequential analysis, but it does show crude incidence rates after RSV vaccination, both per million doses and per 100,000 person years. And the estimates are provided for the risk intervals of 1 to 21 days and 1 to 42 days. That's in the top part of that slide. And then in the bottom part is the risk estimates for the comparison interval of 43 to 84 days. And in addition to the point estimates of the rates, we have 95% confidence intervals, which, as you can see, are very wide, indicating a lot of uncertainty in these estimates, again, because our case counts are quite small. And again, just to emphasize, these are rates that have no adjustment. I've also included a bullet with background rates from the literature for those 6 years of age and older, just to provide some context. Next slide, please. So I'd also finally like to present our results for atrial fibrillation and balances for which were observed in the randomized trials for both vaccines. As with GBS, we don't have a signal for AFib. We do, however, in contrast to GBS, do have a lot of AFib cases. And in fact, it's the most common of our pre-specified outcomes in our RCA. Next slide, please. And this is a table from the sequential analysis, again, showing on the far right column there that's highlighted in green the one-sided p-values, most of which are really far removed from the threshold of 0.014. A couple columns to the left of that is the adjusted rate ratios, and you can see the largest of those rate ratios is 1.14. Next slide, please. So just to summarize, we started our surveillance of RSV vaccine safety in older adults several months ago. We have over 385,000 doses of vaccine been administered to older adults. Since August of 23, 88% are GSK product. We did identify a statistical signal for ITP in those 60 years of age and older who received the GSK vaccine without simultaneous vaccination. But most of these cases appear to be misclassified or not temporally related to the RSV vaccination. We have no statistical signal for GBS, but we also have very few cases. And we have no other signals, statistical signals besides ITP. But surveillance is going to continue for all outcomes, including GBS, through May 2025. Next slide, please. And lastly, I just want to say a big thank you to all the VSD sites and CDC for their assistance on this project. Next slide, please. And I'd be happy to try and take any questions.
Thank you. We are going to hold questions until after the presentation by the FDA. Dr. Lloyd, are you prepared?
Yes. And I think that the slides were going to be shared. I think they're coming up right now. Perfect. Thank you so much. Good morning, everyone. My name is Patricia Lloyd. I'm a health statistician with the U.S. Food and Drug Administration. I'm pleased to be able to share results from our evaluation of Guillain-Barré syndrome, or GBS, following the respiratory syncytial virus, RSV, vaccination among adults 65 years and older. Next slide, please. Here's the outline of my presentation, brief introduction, as well as summarizing results from our observed versus expected analysis, which was presented in February of this year, as well as sharing results from our self-controlled case series analysis, and with a discussion and concluding remarks. Next slide. So there are 2 RSV vaccines that were approved for use in the US in adults aged 60 years and older that I will be focusing on today. This is RSV Pre-F3 AS01, or GSK Arexvy, and RSV Pre-F, Pfizer Abrysvo. I do want to note, as mentioned earlier in the presentations, there is a recently approved vaccine as of May 31st, 2024, the mRNA 1345, Moderna mRESVIA, that is not going to be presented, but that is also approved for use in the US, and also the expanded approval for adults aged 50 to 59 for GSK Arexvy. Again, I'm only focusing on the first 2 approved uses in the US in older adults. So there was an imbalance in the rates of GBS between vaccine and placebo recipients in clinical trials that supported the licensure of RSV vaccines. And so FDA is conducting a post-licensure RSV vaccine safety study using 2 designs. an observed versus expected analysis, as well as a self-controlled case series analysis, or SCCS analysis. Next slide, please. So just to summarize the results or the methods from the observed versus expected analysis, we evaluated the risk of GBS following one dose of either RSV pre-F AS01 or RSV pre-F vaccines using a retrospective cohort design with a 2022 historical comparator. We also estimated the observed incidence rates and compared the historical comparator or expected rates to obtain incidence rate ratios with 95% confidence intervals. We also estimated GBS positive predictive value or PPV adjusted rates based on multiple imputed data sets. This is based on historical chart review where the PPV for GBS was 71%. Next slide, please. So I'm presenting the results here for both RSV pre-F3 AS01 on the left and RSV pre-F on the right from our observed versus expected analysis. There were about 2 million RSV vaccine doses, of which about 2/3 were the RSV pre-F3 AS01 and the remaining RSV pre-F. There were less than 11 cases observed in the RSV pre-F AS01 and 13 observed in pre-F. Just to note, there was an elevated incidence rate ratio observed for GBS following vaccination. However, in our PPV adjusted analysis, only the RSV pre-F association remains statistically significantly elevated, and that's shown here in this table. Next slide, please. So while this was very useful information, the observed versus expected analysis was a crude method with limited adjustment for confounding. We utilized aggregate historical incidence rates rather than using individual historical persons, and that increased the potential for confounding and bias. So we also conducted an SCCS study, which is a robust method that controls for time invariant confounding and does not rely on historical background incidence rates. Next slide, please. So this figure is just a high-level overview of an SCCS design. I want to highlight here that all individuals in the study have received an RSV vaccination and have reported an incident, have a reported incident GBS outcome during the observation period, where the observation period is defined as the risk interval and the control interval, where the risk interval is the days 1 through 42 following RSV vaccination, and the control interval are days 43 to 90. This study compares the risk of GBS during the risk interval to the risk of GBS in the control interval. I also wanted to highlight that in order to identify identify incident cases of GBS, we ensure that the individual has not had a GBS outcome prior to, so 365 days prior to the current GBS outcome of interest. Next slide. So just an overview of the SCCS design. Our data sources included Centers for Medicare and Medicaid Services, or CMS, Medicare beneficiaries that were aged 65 years and older that were enrolled in Medicare fee-for-service Parts A and B and D on the date of RSV vaccination, as well as during that clean window, so the 1 year prior. The study period was May 2023 to April 2024. I want to highlight here that our analysis restricted RSV vaccinations prior to October 8th to have complete observation in the 90-day post-vaccination observation period with 90% or greater of data completeness. As I mentioned, we defined the risk interval as 1 to 42 days, the control interval as 43 to 90 days, and we identified GBS cases in the inpatient care setting with the primary physician only. In our statistical analysis, we calculated the incidence rate ratio with 95% confidence intervals, as well as the attributable risk per 100,000 doses and per 100,000 person years. We also performed several adjustments, including adjustment for outcome-dependent observation time, or a Farrington adjustment. We adjusted for seasonality as well as for PPV, as we did in our observed versus expected analysis. Next slide, please. So this figure just shows our weekly vaccination uptake trends for the two vaccines. I want to highlight here in blue is the vaccination cutoff date, again, to ensure complete observation of that 90-day window. Next slide, please. This table, I'm just going to highlight really the last row here, which is among all 1.3 million individuals who received an RSV vaccination, where again 2/3 received the RSV pre-F AS01, and the remaining received the RSV pre-F. There were 11 GBS cases that qualified for the SCCS analysis that received the RSV pre-F3 AS01, and 17 that received 17 GBS cases, I should say, that received the RSV pre-F vaccine. Next slide. So this slide here, I'm now presenting a forest plot of the analyses. And on the left-hand side, this is presenting the incidence rate ratios of GBS following RSV vaccination for RSV pre-F AS01, and on the right side for RSV pre-F. And we, as I mentioned before, we performed several analyses. The order of the incidence rate ratios that are presented here go from most adjusted to least adjusted analysis. And I've highlighted in blue a box that, again, has the most adjustment, which includes the PPV, or the outcome-dependent observation time, as well as seasonality and PPV. And what we saw here was that when we did adjust for PPV, the results were not statistically significant. Whereas when we looked at the least adjusted analyses, we did identify elevated incidence rate ratio following RSV pre-F vaccination. So you can see that for the seasonality in Farrington alone, on the right-hand side, you can see that the confidence intervals do not include one, which indicates that those results were statistically significant. Next slide, please. This table summarizes the results from our most adjusted analysis. So again, from the forest plot, this was these were the results that were in that blue box. So again, there were about 2/3 of the study subjects had received the RSV pre-F3 AS01. And there were less than 11 cases in the risk and control intervals. I want to just present here, I know that they were presented in the previous slide, but the incidence rate ratios, and now we are presenting here the attributable risk per 100,000 doses, as well as per 100,000 person years. Next slide, please. So the strengths of this study is that we are able to perform more robust adjustment and adjusting for time and variant confounding, which we were unable to do with the observed versus expected analysis. The large database, so using the CMS Medicare claims databases, we were able to more precisely evaluate health outcomes, including GBS. And the study findings are generalizable to the US population 65 years and older. We also encounter some limitations with the study, first being that there is potential for outcome misclassification. There's also potential for misspecification of the risk and control intervals, as well as potential for residual confounding. Next slide, please. So for our observed versus expected analysis, just to summarize, there was an elevated incidence rate ratio observed for GBS following RSV vaccination, but only the RSV pre-F association was statistically significantly elevated following a PPV adjustment. This, again, is a crude method. It utilized aggregate historical comparator rates rather than individuals, and it increased the potential for confounding. And the statistically significant results of GBS, they do not establish causal association between RSV vaccines and GBS. Next slide, please. In our SCCS analysis, although an elevated incidence rate ratio was observed for GBS following RSV pre-F vaccination for 2 analyses that had the least amount of adjustment, these results were not statistically significant when we adjusted for the PPV. I also want to highlight here, as I mentioned before, only cases, so those individuals with an incident GBS outcome contributed to the SECS analysis. And in this design, the estimation of the outcome risk occurs within rather than between individuals, so we are able to adjust for time and variant confounding here. Next slide, please. And in conclusion, the results from these two different types of analyses of potential GBS risk following RSV vaccination are mixed and highly uncertain. These analyses do not provide clear, conclusive, or consistent evidence of an elevated risk of GBS, although an elevated risk cannot be ruled out at this time. FDA is conducting medical chart review on the GBS cases and will continue to evaluate the safety of RSV vaccines as more data are available. And in closing, FDA maintains that the benefits of the RSV vaccination in preventing RSV hospitalizations outweigh the potential risks associated with the vaccines. Next slide, please. Here are references, and next slide, please. And I want to acknowledge everyone at FDA who worked on this project, as well as our FDA partners. Thank you.
Thank you so much. Greatly appreciate Dr. Lloyd and Dr. Donohue's presentation. I would like to open this up for questions from the work group. Dr. Lair.
Thank you very much for these presentations. Dr. Lloyd, could you go to slide 9, please? I'm not sure I'm understanding what PPV means in this context. I'm thinking about it in statistical terms, and you're somehow using PPV to do some adjustments. I'm sorry, slide 11. And so I was wondering if you could explain a little bit more about what PPV means and how you're using it to make adjustments. Thank you.
Sure. And similar to how we did this before in the observed versus expected study, we are essentially, we know that not all of our GBS cases are true GBS cases. Well, we're assuming that based on the PPV that was obtained from a previous study that was done. About 71 cases were true cases. And so we're taking that into account and essentially performing multiple imputation to estimate what the true number of GBS cases we would have. And so while the estimate may not necessarily change a whole lot, the precision of that estimate does change, so our confidence intervals get a little bit wider. As you can see, when in the first two incidence rate ratios and the confidence intervals surrounding those incidence rate ratios, those become a little bit larger. So our estimates are a little more imprecise because we're taking into account the fact that not all of the GBS cases that we've observed are true GBS cases.
Thank you very much.
Sure.
I actually had a question on slide 9. I don't mind going back. Can you tell me, and you may not know off the top of your head, the number of vaccines that were given pre and post that blue line?
Yeah, I do not have that off the top of my head. You can try to pull some of that. But yeah, as we can see, we did receive, or we did have reports of more doses after that cutoff date. And so in a later analyses, we do plan to perform an additional SECS analysis to use all of these data that we weren't able to include here. Because we had planned to do an early analysis, we wanted to ensure that we had at least 90% of data completeness. Unfortunately, we had to draw our cutoff at this time point. So while I don't have those numbers available, we do understand that there are a lot of vaccinations that occurred after that cutoff date.
We greatly appreciate you doing the early one and look forward to the later analysis. Dr. Cotton.
This is a question for Dr. Lloyd. Thank you very much for the excellent presentation and for all the work you've done thus far. I do agree with the overall conclusion that RSV vaccination, that the risks of RSV vaccination are greatly outweighed by the overall benefits. Nonetheless, I remain quite concerned about the signal that we've seen persistently throughout the entire time we've been looking at vaccine data. It really looks like the RSV pre-F vaccine has a higher rate of Guillain-Barré syndrome across pretty much all analyses, perhaps not yet statistically significant in the work you've done, but nonetheless, the message is really persistent. And I'm wondering, especially as we're heading into another season with a recommendation to give a RSV vaccine for those who haven't previously had it in either, August, September, that kind of time frame before RSV season happens. Given our desire to enhance vaccine safety, understanding, for having robust conversations with patients, and for also having the public embrace the safety of vaccines and the work that we're doing here and have better trust in the CDC and FDA, when do you think you might be able to do these few dozen chart reviews? I mean, what kind of time frame are we looking at for data, and will we have that data available before the next season so that we can help make patients, have patients make appropriate decisions? Thank you.
Yes, thank you for that comment and the question as well. So we are currently, we have our partners who are working on the chart review right now. So while we have accrued a number of charts, we are still in the process of getting more and having the appropriate clinicians review these charts as well. As in terms of a timeline, I think it's really difficult for me to say. I think we would want to have this information by fall, as you mentioned, but at this time it is still ongoing and we're unable to put a date there.
Thank you. Hopefully we can have that data within the next couple of months so that we can ensure the safety of the vaccines for the American public. Thank you.
Dr. Daly, you've been patient.
Well, most of my question has been asked, so, but I do want to sort of highlight, if you, this is a technical question, it relates to PPV adjustment, and so it's just a follow-up on that. And I'm going to try to state this and see if you agree with me, which is with a PPV adjustment, what you're saying is that we think 29% of the cases are not true cases. So then when you make a PPV adjustment, I'm assuming that the assumption, what are the assumptions inherent in that adjustment? And I would assume the assumption is that that 29% is randomly distributed. And is that true? But I think at the end of the day, what we're saying is once chart review is done, there's no PPV adjustment because you know which of these are true cases. Is that correct?
That's correct. The chart review will provide, yeah, I think that will really be, we won't need to use this historical chart review PPV. We would know which are the true cases and which are not. Yes.
Dr. Brooks?
Yeah, thank you. Thank you for the presentation. So go to slide 11 again, please. So, and then on you don't have to go to slide 14. The slide 14 basically stated there is no statistically significant link between GBS and vaccination. So that feels to me almost subjective. I mean, I'm looking at, for this pre-F, and 2 of the 4 are, to me, you know, they don't go past the negative. I can look at that and say, I think that is statistically significant. And so I just want to, the question then is, can you square the statement that there is no statistically significant link between the vaccine and GBS while I'm looking at this slide?
Sure, thank you for the question. I think we want to be very careful in saying that there is a consistent significant association because we have seen right from these 4 analyses that there is inconsistent evidence. We know, as I mentioned before, that the PPV is not 100%. So some of these cases that we've observed, which I should also state again, these are small, relatively small number of cases for how many individuals were vaccinated, relatively speaking, that some of those cases are not true cases. And so if we don't take that into account and we assume that everyone is a true case, then it does appear that there is a significant finding from those bottom 2, right, the Barrington and seasonality and Barrington adjustments. However, I think that would be very kind of careless of our team to do that, knowing that some of these cases are not true cases. And so that's why we have to account for that. And so while in these 2 analyses that had the least level of adjustments, we did see that there was statistical significant associations. When we do account for PPV, we no longer see that anymore, and I think we have to take that into account. And in doing that in these 2 analyses, where we're accounting for PPV, seasonality, and Barrington, and then PPV and Barrington, we are still seeing in both of those that we are not seeing these significant associations. I think that really is the analysis we think is more accurate or more appropriate at this time, given that we haven't done that chart review.
Dr. Long?
Yes, thank you. We're going to hear later about the work group deliberations. Being a work group member and agreeing entirely with Dr. Cotton about the preponderance of data, the preponderance of data is that it's highly likely there's association of Guillain-Barré syndrome with RSV vaccines, maybe one more than the other, and that we consider this, and it started pre-licensure and it's gone post-licensure, so we understand the statistical tyranny of small numbers. But this is an uncommon event if it is associated, and we don't know the quantification of the association. If it is 1 in 100,000 or 1 in 150,000, we couldn't know that for certain at this point. But the likelihood is very high. I'd just like to ask one question. When you do the chart reviews of who really has Guillain-Barré syndrome, what Brighton levels do you accept as true cases?
I believe that it would be Brighton level classification 1 and 2, but I would need to go back and confirm that.
Difficulty being that not all patients in this kind of analysis are fully evaluated. The 3 level is something that would occur if there wasn't complete evaluation, but pretty darn close if the clinical association is good. So that will be another consideration.
Dr. Cotton?
Thank you. So one quick question. So this includes only where there's been a billing code of Guillain-Barré syndrome, correct? Does it include like ADEM or anything related, or does it rely on the clinician accurately billing for Guillain-Barré syndrome?
It would simply come directly from the claims and only looking for that one diagnosis code, then it really does rely on the clinician accurately billing for GBS.
Okay, then I would emphasize to my colleagues out there, you better bill correctly so we can get good vaccine data. Everyone hone their billing skills. And then my second question is, so we've heard for a couple of months that you're waiting to do chart review. So as an active infectious disease clinician, when I'm admitting a patient to the hospital and I need to do chart review, I usually spend 1 or 2 or 3 days getting an outside chart. I'm wondering if you can comment on time frame for the FDA and why we've heard for several months that we're waiting on chart review, and what the details are of your type of chart review. Thank you.
Yeah, I am unable to speak to the details of the chart review. I'm not sure if my colleagues on. I see Steve, you want to?
Yeah, so this is Steve Anderson from FDA. So what I'll say is that sometimes it does, so we've done the chart review, the chart retrieval for these, and I think that so what we do is early on as we're identifying cases, we're even trying to retrieve charts of cases, but it can take up to 2 to 3 months to get a chart. Generally, we sort of request 30 days for the provider to supply us with the chart, but it can take longer, and then sometimes you have to do follow-up to get those. So I think what we have as far as charts for the total number of cases that we were looking at, I think we have about 65 out of like 82 cases where we've retrieved a chart, and we're currently in adjudication. So I will say within the next probably month or two, we should have the chart review sort of completed. But again, the real sort of stickler here is really just retrieving the charts. It does take some time for us to do that.
Thank you for that answer. On behalf of the American public, I would hope that we could expedite that so that we could get an answer before we head into another vaccination season. Thank you.
Yeah, I mean, we're entirely aware of the importance of doing that. So this is being expedited to the extent possible.
Dr. Schechter.
Thank you for the presentations. A few GBS questions and a few non-GBS questions. I presume the small number of case numbers don't yet allow a comparison by age group or analysis by age group for risk of GBS. Is that correct?
In the analysis that was presented, no, the numbers were already pretty small, but I think if we would have very imprecise estimates for smaller age groups. Thank you.
I'm wondering for both studies, how to think about background rates and attributable risk in populations that may be, I guess, under shared.
Did it go off? Let me start again. I'm wondering on both studies, how to think about the populations under shared clinical decision-making and whether they might be sicker than populations and how self-controlled studies adjust or don't adjust for that, account for that. Or I guess thinking about background rates and attributable risk, it looks like rates might have been higher. And what do we know within the VSD population or in the FDA study about the comorbidity or the illness of the population and how similar they might be to the rest of the population receiving the vaccine? Any thoughts or comments about how representative the populations are and the background rates of GBS in the population?
This is Jay Donahue. I can't make any comments really about how representative this particular 16 and older age group is for the population in general. VSD in general is fairly representative of the population to some extent. In terms of comorbidities or risk factors associated with GBS in this age group, that would be an interesting question. We don't have that information, but we do, as mentioned in the presentation, have vaccinated current carriers. So everybody, there are cases who are also vaccinated. So it's hopeful that sort of balance is out there. Over.
Hopefully, two quick questions on VSD. How severe were the incident ITP cases? And when you look for stroke signals, is it possible to distinguish hemorrhagic from thrombotic stroke? I guess that topic came up with COVID and thrombosis too.
Yeah. So with regards to the severity of ITP, we don't have that level of detail chart review yet. We hope to get that in the coming weeks, probably by early August. We'll have chart reviews on all these cases so that we'll be able to gauge that. It does appear, based on just the preliminary chart review that we had, that most of these people, or at least some of these people, for which we have some information on, had diagnoses such as chronic thrombocytopenia or idiopathic thrombocytopenia purpura or thrombocytopenia unspecified, suggesting that maybe they had, and it's not uncommon for ITP in older adults, it would be chronic disease. Regarding stroke, we only had the one classification that included both hemorrhagic and ischemic stroke in VSD.
Thank you.
Dr. Laird, quickly.
Very short question. When you say the ITP cases, 19 cases and 4 were incident, does that imply that 15 had data before they got the vaccine that suggested ITP, that only 4 were after the vaccine? Is that Thank you.
Dr. Shaw.
Hi, I just had a quick question. My understanding is that the Brighton criteria for GBS do not detect any of the variant forms of GBS. So is there any effort to, obviously these are rare among the rare, but is there any effort to capture some other neurologic events that would not be covered by the Brighton criteria?
Thank you for that. If the question was to the FDA SCCS studies, or I think we were only focused on GBS. That's my understanding.
I think the Brighton criteria, there are variants of GBS. That was my question, but thanks.
Y'all are eating up your break. Yes, Dr. Long.
A very quick mathematical, as Dr. Laird does. I did it on a napkin. If you're, you could look at that graph of how many vaccines were given, or how many in your system, and you multiply that, there are less than 1 million. So if this occurred at maybe 100,000 or 200,000, I would just say the data are inadequate to conclude rather than suggest in the negative. Thank you.
Great. Any other questions? Okay. Yes, go ahead.
There was a question about how representative the population was. I didn't have a chance to answer from our side, but I did want to mention that using data from CMS, we know that CMS or Medicare is the largest health insurance program that covers this age group. In terms of whether or not this group is sicker than others, I mean, I think that's really why we, in doing the SCCS analysis, we were able to control for some of those factors, that we know that some people might have higher comorbidities than others, and so that those time invariant confounders we are able to control for using the SCCS analysis. I just wanted to mention that. Hopefully that answers the question that was raised.
Thank you. All right, we're going to adjourn for a break. We will start promptly at 10:12, so I think you get less than 5 minutes. So walk around quickly, get the blood flowing, because we have a lot more information to come. All right, welcome back. We have a lot to cover today for RSV. You may hear some background noise as everyone gets back to their seats. We are going to start off with some vaccine effectiveness studies for the RSV vaccine, and Dr. Suri will start us off.
Good morning. Today I'll be presenting post-licensure observational vaccine effectiveness of the GSK and Pfizer RSV vaccines that were used during the 2023 to 2024 RSV season in the United States. Next slide, please. First, I'll review the ways in which randomized vaccine trials are different from observational vaccine effectiveness, or VE studies. The purpose of randomized vaccine trials is to answer the question, can the vaccine reduce disease caused by the target infection safely under ideal conditions designed to detect a protective effect? To maximize chances of detecting a protective effect, vaccine trials often enroll healthy individuals in the target population and minimize or exclude enrollment of individuals with comorbidities that might reduce the immunogenicity of vaccines. Therefore, post-licensure observational VE studies are needed to assess vaccine performance in a heterogeneous population under routine vaccine program conditions. Next slide, please. Some of the main limitations of the GSK and Pfizer RSV vaccine trials are listed on this slide and contrasted with data from observational VE studies that will be presented today. Adults with immunocompromise were categorically excluded from both RSV vaccine trials, but are included in the observational VE studies presented today. Additionally, RSV vaccine trials underrepresented adults at increased risk for severe RSV disease, including adults aged 80 years or older and those with chronic conditions. The observational VE studies presented today include at least 3 times as many older adults, and almost all of the included adults had at least one chronic condition. Importantly, because most adults included in the RSV vaccine trials were relatively healthy, there were insufficient numbers of RSV-associated hospitalizations. Therefore, symptomatic RSV-associated lower respiratory tract disease was used as a surrogate for severe RSV disease instead. By contrast, all of the observational VE studies presented today include effectiveness of RSV vaccines against hospitalization, and one includes VE against critical illness, defined as ICU admission or death. Next slide, please. Today's presentation will include VE results from 4 U.S. government observational VE studies listed on the left of this slide. Both the IV Network and VISION use a test-negative design. The Veterans Health Administration analysis uses a target trial emulation design, and the Medicare analysis, which is focused on an end-stage renal disease population on dialysis, uses a retrospective cohort design. All of these study designs have previously been used for real-world vaccine effectiveness analyses. Next slide, please. This slide shows demographic characteristics across all 4 studies. Together, these platforms represent populations that are overall older and more racially or ethnically diverse than patients included in the RSV vaccine trials. VISION and VHA populations skew slightly older, with a median age of 76 years, compared with 72 years in the IV Network and 74 years in the Medicare analysis. IV and Medicare analyses are more racially diverse, with 20 to 21% of included patients of Black race. Next slide, please. Similarly, clinical characteristics varied by platform, but were overall more inclusive of patients at increased risk of severe RSV disease than the RSV vaccine trials. The Medicare ESRD population on dialysis is the sickest population, with 84% of included patients having at least 4 chronic conditions. Although definitions of immunocompromise were different for each study, 11 to 25% of included patients were immunocompromised, and about 1/3 to half of included patients had chronic lung disease. RSV vaccine uptake was 9 to 10% in the IV, VISION, and Medicare cohorts, with at least 2/3 of these vaccinations being GSK product, whereas almost 70% of RSV vaccinations in the VHA study were Pfizer vaccines. Next slide, please. The next several slides will provide an overview of each of the observational VE studies and their main results, beginning with the IV Network. Next slide, please. The IV network analysis uses a test-negative case-control design. The analysis period was from October 1st, 2023 through March 31st, 2024. Adults aged at least 60 years who were hospitalized with acute respiratory illness, or ARI, and had RSV test results within 10 days of illness onset and 3 days of admission were eligible for inclusion in this analysis. Among these patients, those who tested positive for RSV by nucleic acid amplification test, or NAT, or antigen test were included as cases, and any co-infections with SARS-CoV-2 or influenza were excluded. Control patients were those with ARI who tested negative for all vaccine-preventable respiratory viruses, including RSV, SARS-CoV-2, and influenza by RT-PCR, to avoid any VE bias that may occur due to correlated vaccination behaviors. Vaccination status was determined from 3 sources: plausible self-report, electronic medical records, and city or state vaccine registries. Vaccinated patients were defined as those who had received a single dose of either the GSK or Pfizer RSV vaccine at least 14 days before illness onset. Unvaccinated patients had not received the RSV vaccination before illness onset. Lastly, nasal swabs were obtained from all patients for central RT-PCR testing and whole genome sequencing. Next slide, please. This slide shows VE against RSV-associated hospitalization among all adults aged 60 years or older in the IV network, of whom 24% had immunocompromising conditions. The first 2 rows show VE against hospitalization using 2 different approaches. The first row shows results for the primary analysis that uses the unweighted enrolled sample in which potential confounders are adjusted for using multivariable logistic regression. The second row shows results using inverse probability of vaccination weighting, or IPVW, in which a weighted sample is generated that balances an expanded set of potential confounders between vaccinated and unvaccinated patients. The remaining 2 rows display VE against hospitalization stratified by age group. RSV vaccination occurred a median of 84 days, or about 3 months before illness onset, which is shown in the 4th column. The last column shows VE results. VE against RSV-associated hospitalization in the primary analysis was 75%, with a confidence interval of 50 to 87%, and 79% in the IPVW analysis, both with mostly overlapping confidence intervals. When stratified by age groups, VE remained high at 75% among adults aged 60 to 74 years, and 76% among adults aged 75 years or older, with overlapping confidence intervals. Next slide, please. Next, I'll present an overview of methods and results from VISION. Next slide, please. Similar to IV, VISION uses a test-negative design to assess VE. Adults aged at least 60 years who visited a participating emergency department or were hospitalized for RSV-like illness, or RLI, and had an RSV test result within 10 days before or 72 hours after an encounter were included in this analysis. Among these patients, cases were those with RLI who tested positive for RSV by antigen test or NAT, and controls were those with RLI who tested negative for RSV by NAT. Vaccination data were obtained from electronic health records, state and city registries, and claims data. As with the IV network analysis, RSV vaccination was defined as receipt of a single dose of either the GSK or Pfizer vaccine at least 14 days before illness onset. Unvaccinated persons had not received RSV vaccination before illness onset. Covariate data were obtained from electronic health records. Next slide, please. This slide shows VE against RSV-associated ED visits, hospitalization, and critical illness among immunocompetent adults aged at least 60 years within VISION. The 4th column shows the median duration since RSV vaccination, and the last column displays VE results. VE against RSV-associated ED visits was 77%, with a confidence interval of 70 to 83%, and was similarly high against RSV-associated hospitalization at 80% and critical illness at 81%, all with overlapping confidence intervals. Next slide, please. This slide also shows VE against RSV-associated ED visits and hospitalization among immunocompetent adults, but this time results are stratified by age groups. VE against RSV-associated ED visits was 75% among adults aged 60 to 74 years and 78% among adults aged 75 years or older, both with overlapping confidence intervals. Similar VE was observed against RSV-associated hospitalization, with a VE of 81% among adults aged 60 to 74 years and 79% among adults aged 75 years or older. Next slide, please. To assess for waning vaccine-induced immunity within a season, VE against RSV-associated ED visits and hospitalization were also stratified by the number of days since RSV vaccine receipt. VE point estimates against RSV-associated ED visits decreased from 85% when RSV vaccine had been received between 14 to 59 days before the ED visit to 70% between 60 to 215 days from RSV vaccine receipt, with only 1 percentage point of overlap between the confidence intervals. Similarly, VE against RSV-associated hospitalization decreased from 90% within the first 14 to 59 days after RSV vaccination to 73% between 60 to 215 days from RSV vaccine receipt, also with nearly separate confidence intervals. Additional time is needed to determine the duration of protection from these vaccines. Next slide, please. VE against RSV-associated ED visits and hospitalization were also stratified by RSV vaccine manufacturer. VE against RSV-associated ED visits was 77% for the GSK vaccine and 79% for the Pfizer vaccine. VE against hospitalization was 83% for the GSK vaccine and 73% for the Pfizer vaccine, all with overlapping confidence intervals. Next slide, please. Among immunocompromised adults aged 60 years or older in vision, RSV vaccines provided protection against RSV-associated hospitalization with a VE of 73% and confidence interval of 48% to 85%. However, these results may not be generalizable to all people with immunocompromise, especially those with severe immunocompromise. Next slide, please. Next, we'll review results from the Veterans Health Administration, or VHA, which is America's largest integrated healthcare system, serving 9 million enrolled veterans each year. Next slide, please. As previously mentioned, the VHA used their National Electronic Health Record data to emulate a target randomized controlled trial of RSV vaccination, including either GSK or Pfizer RSV vaccines, compared with no RSV vaccination for the prevention of documented RSV infection and RSV-associated ED or urgent care visits or hospitalization among veterans aged at least 60 years. Enrollment occurred during September 1st and December 31st, which coincided with the period during which RSV vaccines became widely available across the VHA, and follow-up continued through March 31st, 2024. This analysis was executed as 4 monthly nested sequential trials during the enrollment period. Next slide, please. This slide depicts the nested sequential trial study design and matching process. During each enrollment month, eligible RSV vaccinated persons were matched with up to 4 persons who remained unvaccinated as of that same day, using exact matching followed by propensity score matching to emulate baseline covariate balance achieved through randomization. The 5 exact matching factors included age, immunocompromised status, Care Assessment Need or CAN score, which is used by the VHA to predict 1-year mortality, Veteran Integrated Service Network, or VISN, which represents geographic regions within the VA, and outpatient healthcare utilization in the previous year. Within each exact matching stratum, an additional propensity score matching step was performed using a number of demographic, geographic, and clinical factors. Next slide, please. The data used for this analysis come from the Department of Veterans Affairs Corporate Data Warehouse, which integrates real-time electronic health record data across all VHA facilities and includes demographic, geographic, and clinical data. RSV tests were performed on respiratory specimens within VHA facilities using nucleic acid amplification or antigen testing. And RSV vaccinations were administered at VHA facilities or outside facilities and recorded within the VHA EHR. Next slide, please. Veterans were eligible for enrollment during September 1st through December 31st, 2023, if they were aged 60 years or older and had had at least one primary care encounter within the VHA during the 18 months prior to the first day of each trial month. Exclusions are listed on this slide for reference. Next slide, please. The primary outcome in this analysis is documentation of any positive RSV test result in the EHR occurring from day 14 following the index date through the end of the study period on March 31st, 2024. Secondary outcomes evaluated include ED and urgent care visits, as well as hospitalizations. A negative control outcome was also used to assess for residual confounding or ascertainment bias by comparing the incidence of laboratory-confirmed RSV infections occurring 0 to 13 days following the index date between vaccinated and unvaccinated groups, which should be similar in this early period after vaccination. Vaccine effectiveness was calculated using Cox proportional hazards regression as 1 minus the hazard ratio multiplied by 100. Next slide, please. This slide shows the cumulative incidence of documented RSV infections and their associated healthcare events following the matched index date by RSV vaccination status. The teal-colored lines represent RSV incidence among unvaccinated persons, and the red lines represent persons with either GSK or Pfizer RSV vaccination. Starting at the figure on the top left, which represents the negative control outcome results, we see nearly identical incidence of RSV infection among vaccinated and unvaccinated persons during the first 13 days after the index date, as expected. The figure on the top right, as well as all subsequent figures, show a notable difference in the incidence of RSV-associated outcomes between vaccinated and unvaccinated persons beginning 14 days from the index date. Next slide, please. The vaccine effectiveness corresponding to each of the outcomes shown on the previous slide are displayed in the last column of this slide. In the intention to treat analysis with a median follow-up time of 124 days, VE against any documented RSV infection was 77%, with a confidence interval of 71 to 81%, and this was similar for prevention against specific outcomes of RSV-associated ED or urgent care visits at 77%, as well as RSV-associated hospitalization at 82%, with overlapping confidence intervals. Findings from per-protocol analyses were similar to intention to treat estimates shown here. Next slide, please. When the primary outcome of any documented RSV infection was stratified further by age and immunocompromised subgroups, we again see similar protection of RSV vaccines across these subgroups, with VE point estimates ranging from 71% to 78% and overlapping confidence intervals throughout. Importantly, VE against documented RSV infection was 72% among adults aged at least 80 years and 71% among immunocompromised adults. As with the VISION analysis, these results may not be generalizable to all immunocompromised adults, especially those with severe immunosuppression. Next slide, please. Lastly, VE against documented RSV infection was not different between RSV vaccine manufacturers, with a VE of 77% for both GSK and Pfizer RSV vaccines and overlapping confidence intervals. Next slide, please. The last set of VE results that we'll review are from a Medicare analysis of people with end-stage renal disease, or ESRD, and on dialysis. Next slide, please. These results were presented to the committee by Dr. Woodruff during the February ACIP meeting. As highlighted by the red rectangle, adults aged 50 years and older with chronic kidney disease had a higher rate of RSV-associated hospitalizations compared with community-dwelling adults, shown in the black bars. Although ESRD patients are a unique population, assessing the protection of RSV vaccines in this population is important because of their high risk of severe RSV disease. Next slide, please. The Medicare ESRD analysis uses a retrospective cohort design to evaluate VE against RSV-associated hospitalization using Medicare fee-for-service claims data. Patients are eligible for inclusion if they are age 65 years or older and have ESRD with at least one dialysis encounter in the 90 days before the index date of October 1st, 2023. As with previous analyses, RSV vaccination was defined as a single dose of either GSK or Pfizer RSV vaccines received at least 14 days before the index date. The primary censoring event was RSV-associated hospitalization, and follow-up was continued through February 24, 2024. VE was calculated as 1 minus the adjusted hazard ratio multiplied by 100, where the hazard ratio is the rate of RSV-associated hospitalizations among vaccinated persons divided by the rate among unvaccinated persons. Next slide, please. VE against RSV-associated hospitalization for adults aged at least 65 years with ESRD are shown on this slide, stratified by additional immunocompromised status. The top row shows VE of 78%, with a confidence interval of 45 to 91% among ESRD patients without any additional immunocompromising diagnoses, including hematologic malignancy, solid tumor malignancy, transplant, rheumatologic or inflammatory conditions, or other intrinsic immune conditions or immunodeficiency. The second strata presented show VE results for ESRD patients who also had any one of these additional immunocompromising conditions, and VE against RSV-associated hospitalization was similar in this group at 80% with overlapping confidence intervals. Next slide, please. Next slide, please. In summary, observational VE from multiple real-world studies show RSV vaccines protect against severe RSV disease, similar to results from RSV vaccine trials, although endpoints differ. The first 3 rows in this table, shown in blue, display vaccine efficacy endpoints of symptomatic lower respiratory tract disease that were defined differently in the GSK and Pfizer RSV vaccine trials. The subsequent rows, shown in brown, display observational vaccine effectiveness against RSV-associated hospitalization and build on the evidence from the trials to demonstrate similarly high protection of RSV vaccines against severe RSV disease, even in expanded populations of heterogeneous immunocompromised adults. Next slide, please. Observational VE studies also have limitations. RSV vaccine uptake in these study populations was 5 to 10%, which is low for accurate assessment of VE in observational studies. Early adopters of new vaccines may have different healthcare-seeking behaviors than the general population, which could bias VE estimates upward. Although multivariable adjustment and inverse probability of vaccination weighting were used to minimize bias, residual bias from unmeasured confounding may remain. Additionally, as previously stated, definitions of immunocompromise varied across studies, and studies were not powered to assess VE for specific types of immunosuppression. Lastly, the median duration since RSV vaccination in these studies was about 3 to 4 months, which is insufficient follow-up time to determine duration of RSV vaccine effectiveness beyond a season. Next slide, please. In conclusion, under real-world conditions, RSV vaccination with either the GSK or Pfizer RSV vaccine provided protection against severe RSV disease among U.S. adults aged at least 60 years in this first season of use. These results expand on those from the RSV vaccine trials in 2 ways. First, they provide evidence of vaccine effectiveness against RSV-associated ED visits, hospitalizations, and critical illness. And second, they demonstrate protection in a population that more closely represents those at high risk of severe RSV disease, including adults aged 75 years or older, adults with a composite of various immunocompromising conditions, and adults with underlying conditions, especially cardiopulmonary disease. Ongoing monitoring of RSV-VE is needed to confirm findings from this initial season and to further assess durability of RSV vaccine protection. Next slide, please. Thank you.
Love to open this up for questions. While y'all are thinking of questions, I have one. You mentioned the early adopters and the possibility of a healthy bias effect. Could you talk about why you're concerned about that, and is it consistent across all studies?
Yeah, Yeah, thank you for the question. We have seen differences in RSV vaccine uptake. This is most clearly seen with the IV network and the VISION analyses, in which RSV vaccine uptake is higher among patients or people who reside in communities with low social vulnerability index. That said, these analyses did adjust for social vulnerability index, and we've tried our best to adjust for such potential confounders, but residual confounding may remain. And so I think with additional monitoring over time, we'll be able to continue to evaluate for these changes.
Dr. Long.
Thank you. I don't think I can see that I have your presentation. So I have a question. It was a marvelous amount of information. Thank you very much. Very clearly presented. My question is about the reverse Kaplan-Meier curves of vaccine effectiveness in the VA system. If you could show us that. My question is, I think it was over time, and did you see that there was a diminution in the protection at all? I'm thinking about your other data that showed that maybe there was a decrease of 10% efficacy after 60 days of vaccination. So is that what that curve showed? Was it days after vaccination? And there it is.
Yes.
So I don't see that really even. These are days. So I don't see that represented in these curves. Is that because it's too small? It still looks like there's an increase in vaccine effectiveness over those 190 days. Am I interpreting that correctly?
That is correct for these data. I think that the data that if I could please have slide number 14. The data from the test negative design analysis from VISION showed a decline, a potential decline in the VE point estimates against both ED visits and hospitalization. And this is continuing to be monitored. At this time, we think we need additional follow-up time to further assess, but it does appear that the point estimates and confidence intervals are starting to separate.
Dr. Long, Sarah, were you asking about the VA curves? Because we have maybe Dr. Bajema from the VA wants to comment on those.
Yeah, this is Christina Baima. What you're seeing on those are simply the cumulative incidence, and so it's a little challenging to infer potential waning effect from those curves alone. However, in separate analyses that are not shown here, we did not see substantial waning. However, that was over a median 4-month follow-up period, so a little bit limited to assess that at this time.
Any other questions? Yeah, it was a great presentation and an exciting data, so thank you. Now we get to move on to the economic analysis, and Dr. David Hutton from the University of Michigan is going to walk us through this.
Great, thank you very much. Can you hear me? Are you able to hear me?
Yes, we can.
Okay, great. Thanks. So this is David Hutton, and I appreciate the opportunity to present this work on economic analysis. Let's go to the next slide. This is our research team. It's a combination of folks from the University of Michigan and the CDC. A lot of these names are ones you've seen in previous presentations. Let's go to the next slide. I have no known conflicts of interest to declare. Let's go to the next slide. So we made a few updates since our last presentation here in June 2023. The new analysis is looking at risk groups, so we're looking at both risk-based groups and age. We now include the Moderna vaccine. We also have some new inputs, incidence is broken out by chronic medical condition. Mortality now includes both deaths in and outside of the hospital. Vaccine effectiveness is based on real-world observational data for the Pfizer and GSK vaccines. And vaccine adverse events are based on BSafe data, and we now include Guillain-Barré syndrome information based on the new FDA CMS data. Next slide. And next slide. So our question here is to look at the cost effectiveness of RSV vaccination. We're going to compare vaccination versus no vaccination, taking a societal perspective. Next slide. So we're going to do this analysis focusing on 3 different groups. You'll see color coding used throughout my presentations. The first is in green here, adults age 75 years, and this is all adults, regardless of chronic medical condition. And then in purple, we have adults age 60 to 74 years with at least one chronic medical condition. And then in blue, we have adults age 50 to 59 years with at least one chronic medical condition. When I say at least one chronic medical condition, I mean at least one of the following at the bottom here of my slide: chronic obstructive pulmonary disease, asthma, coronary artery disease, chronic kidney disease, diabetes, and severe obesity with a BMI over 40. We're going to look at protein subunit RSV vaccination, which is Pfizer's Abribzo and GSK's Arexvy. And then we'll also look at Moderna RSV vaccination with Moderna's Mrevzia. We are not going to compare the vaccines against each other, but really compare each one to no vaccination. Next slide, please. So why do we combine Pfizer and GSK? These currently licensed protein subunit RSV vaccines have shown similar cost effectiveness.
Dr. Hutton, pause a moment. I think we need to check audio. Hang on. Okay, you can proceed.
Okay, thanks. So we're combining Pfizer and GSK because they have shown similar cost effectiveness. The policy question really doesn't distinguish between the 2 products, and it allows us to simplify some results. I will show some product-specific results and scenario analyses, and then the benefit-risk analysis, which I'll show in a few minutes, will also break out by the different products as well. Let's go to the next slide. This is our decision tree model. It's similar to what you've seen before. At the bottom of the tree, you can see adverse events here. We now include a split-out Guillain-Barré syndrome outcome. And then at the top of the screen, if someone's infected with RSV, you see the outcomes that might occur there. Although the tree shows deaths after hospitalization, we do also take into account deaths that might occur outside of the hospital as well. Let's go to the next slide. One new input is RSV incidence by chronic medical condition. The hospitalization incidence comes from the analysis of data from RSVNet. In this analysis, we include a multiplier of 1.5 to account for RSV test sensitivity, but otherwise it's broken out by these different chronic medical conditions. Emergency department visit incidence is similar to what you've seen before. We weren't able to break this out by chronic medical condition. And then outpatient incidence is based on data from a meta-analysis by McLaughlin. However, those individuals with chronic cardiopulmonary conditions, we took that incidence from a study by Belangia et al., also adjusting for test sensitivity. Let's go to the next slide. When I say adult annual RSV incidence, again, we're going to break this out into different chronic medical conditions. We've taken information from RSVNet looking at chronic obstructive pulmonary disease, asthma, coronary artery disease, diabetes, chronic kidney disease, and those with severe obesity. And oftentimes when I say at least one chronic medical condition, I'm referring to these top conditions at the top of my slide. We also will do some analyses based on additional chronic medical conditions, heart failure and immune compromise. And when I say immune compromise, we're specifically looking at lung transplant, hematopoietic cell transplant, either allogenic or autologous. These conditions at the bottom were considered separately because the parameters were derived from different published sources and couldn't be combined with the RSVNet hospitalization data. Next slide. I do want to highlight, though, that those who have immune compromise in our analysis, we assumed that vaccine effectiveness was reduced in half in those immune compromised populations compared to the others. Okay, let's move to the next slide. And here we have vaccine effectiveness. This is the vaccine effectiveness for the protein subunit vaccine, and this is the combined Pfizer and GSK. The starting vaccine effectiveness during months 0 to 6 was taken from a meta-analysis of the observational vaccine effectiveness data that was just presented. Vaccine effectiveness then declines to season 2 levels, and then we assume there's a linear decay to 0% efficacy at 24 months. However, we will see a scenario analysis, or we did do some scenario analyses that where the efficacy declines to 0% efficacy by month 36. Next slide. We also include vaccine adverse events. Adverse event rates for Pfizer and GSK come from the real-world VSafe data, and about 6 to 10% of individuals with those vaccines experience severe injection site reactions or systemic reactions. We now include Guillain-Barré syndrome data for the GSK and Pfizer vaccines, taking the results from the FDA's controlled case series that ACIP just saw presented by FDA. And the rates are 16 per million for Pfizer and 3 per million for GSK. The Moderna data is based on their trial, with about 7% experiencing severe injection site reaction or systemic reaction, and we did not assume Guillain-Barré risk attributable to the Moderna vaccine since we don't have data on that. But for all vaccines, we include a rare unnamed serious adverse event rate of 1 per million doses administered. Let's take a look at the next slide. Next slide. And so we have medical costs here. Medical costs are broken out. The hospitalization costs include post-discharge skilled nursing facility costs, and all of our costs vary slightly by age. It's about $20,000 for hospitalization, a little over $1,000 for ED visits, and about $100 or so for outpatient visits. But if we go to the next slide, we have multiplied those costs based on the chronic medical conditions. This is based on relative lengths of stay data from RSVNet. So for example, these are multipliers. So for example, individuals with chronic obstructive pulmonary disease would have costs 22% higher than those seen in the previous slide. And those with none of these conditions would have costs about 16% lower than those seen on the previous slide. These are hospitalization costs. Okay, let's go to our next slide. We do have a bunch of additional inputs here you can see on this slide. I just want to say that these inputs have not changed since our prior, skipping, sorry. I just want to show the vaccine administration related costs here. It includes the vaccine costs and the vaccine administration costs. And then on the next slide, we have our additional inputs. I do want to say that these inputs really haven't changed from our prior analysis. Let's go to the next slide. And I just want to highlight we're going to be looking at a bunch of different scenarios in this analysis. But let's skip ahead to the next slide and show some results. So let's go ahead here. And this shows some of our base case incremental cost effectiveness ratios. This slide is showing different columns for the different vaccines and then different rows for the different groups, age and risk groups. So we can see for adults age 75 and older, the cost effectiveness ratios are about $50,000 to $66,000 per quality adjusted life year gained, depending on whether it's the protein subunit vaccine or the Moderna vaccine. The incremental cost effectiveness ratios rise a little bit for adults aged 60 to 74 with at least one chronic medical condition, about $61,000 to $81,000 per quality adjusted life year gained. And then for those individuals aged 50 to 59 with at least one chronic medical condition, the incremental cost effectiveness ratio is about $155,000 per quality adjusted life year gain. If we go to the next slide, I want to show you this kind of visually. And on this slide, we can see the increase in costs compared to no vaccination, and then the increase in quality adjusted life years gained on the horizontal axis if we add vaccination. So here we can see that if we recommend vaccination to all adults age 75 and older, we would get a little bit less than 15,000 incremental quality adjusted life years gained, and but we would be increasing societal costs in the hundreds of millions of dollars. And if we go to the next slide, it'll advance here, and we're paying about $51,000 per quality adjusted life year gain if we give the protein subunit vaccines to all of us 75 and older. If we go to the next slide, we can see that if we then add on, in addition to those age 75 and older, now give the vaccine to those age 60 to 74 with at least one chronic medical condition, we are increasing aggregate quality adjusted life years gained in the population. We're also increasing aggregate spending, and we're doing that at a rate of about a little less than $61,000 per quality adjusted life year gain. we go to the next slide, we can see that if we then add on to the recommendation of vaccinating adults 50 to 59 with at least one chronic medical condition, now we're spending $154,000 or so per quality adjusted life year gain. So this is with the protein subunit vaccines. If we go to the next slide, we can show the same results for Moderna. So if we go to the next slide, you'll see an orange dot here. That's the Moderna vaccine given to all adults age 75 and older. That's about $66,000 per quality adjusted life year gain. If we go to the next slide, we can see adding on the individuals age 60 to 74 with at least one chronic medical condition, and that's about $81,000 per quality adjusted life year gain. So that's kind of visually the aggregate impact on the population of adding on more and more groups to the recommendation. Okay, let's now look at some scenario analyses. So let's go to the next slide and then the next one. So now this is looking at results specific to the protein subunit vaccines. So GSK and Pfizer split out separately. You can see the incremental cost effectiveness ratios are slightly different for the two products, but they're largely similar between the two vaccines. Let's go to the next slide. The next slide shows the results for different time horizons. On the left-hand side, or efficacy assumptions, on the left-hand side, you see the original table with the original cost-effectiveness ratios, assuming that these vaccines decline to 0% efficacy at month 24. And on the right-hand side of your screen, you can see a table showing the results if we assume the vaccine efficacy declines to 0% at month 36 instead of 24. You can see the cost-effectiveness ratios do decline if we assume longer vaccine efficacy. So the cost-effectiveness ratio is about $40,000 per quality adjusted life year for adults age 75 and older, about $45,000 to $50,000 per quality for adults age 60 to 74, and a little over $110,000 per quality adjusted life year gain for those age 50 to 59. On the next slide, we'll see some results for cost effectiveness by age and whether people have these chronic medical conditions or don't have these chronic medical conditions. The blue bars are for people with at least one condition. You can see they're much lower and much better cost effectiveness ratios. The orange bars represent individuals without these chronic medical conditions. You can see they're much higher, particularly for the adults in the age group 60 to 74. In those groups, the incremental cost effectiveness ratios are above $500,000 per quality adjusted life year if we're giving them the vaccine and they don't have any of those chronic medical conditions. On the next slide, we'll see, I just want to give you a high-level view of things. I want to show results for specific conditions. There are 10 different groups here, and I'll show them for the protein subunit vaccines first and then for the Moderna vaccine. So let's look at the next slide, which is showing results for the protein subunit RSV vaccines. Here we have different bars for each chronic medical condition or groups of chronic medical conditions. The horizontal axis shows us the incremental cost effectiveness ratio in terms of dollars per quality adjusted life year gained. Different colors represent different age groups and groups of chronic. So we have the blue bars representing those age 50 to 59, the purple bars representing those 60 to 74, and the green bars representing those 75 and above. I don't want to point out every single bar on here, but I do want to highlight a few. So all adults age 60 to 74, that incremental cost effectiveness ratio is a little bit over $175,000 per quality adjusted life year gain. And those with at least one chronic medical condition, again, that's about a little over $150,000 per quality adjusted life year gain. Those with diabetes, age 50 to 59, that cost effectiveness ratio is a little bit less than $175,000 per quality adjusted life year gain. And then those without any of these chronic medical conditions, particularly those above the age 60 to 74, that's again about $500,000 per quality adjusted life year gain. But for a lot of these conditions, particularly in the old age groups, the cost effectiveness ratios are quite low. If we go to the next slide, we can see the results for the Moderna vaccine. Similarly, we have purple bars and green bars here, purple for those 60 to 74, green for those 75 and above. You can see that the cost effectiveness ratios, I just want to highlight a few. For all adults age 60 to 74, the incremental cost effectiveness ratio is a little bit high. And then particularly for those with none of the above conditions, that cost effectiveness ratio is quite high as well. On the next slide, I just want to show, in the next slide here, we'll look at a sensitivity analysis for those and look at how different parameters change the cost effectiveness of the GSK RSV vaccine for those age 50 to 59 with at least one chronic medical condition. You can see the results change as the parameter assumptions change. The x-axis shows how the incremental cost-effectiveness ratio changes, and that each bar represents a different parameter. The blue bars show what the cost-effectiveness ratio does as the parameter is low, and the orange bar shows what happens when the parameter assumption is high. We can see that the incidence of RSV hospitalization is high, then the vaccination in this group becomes more cost-effective. But for example, if the RSV hospitalization incidence is low, then the incremental cost-effectiveness ratio rises. So hospitalization, mortality, quality of life, cost per hospitalization, and vaccine effectiveness are important parameters. I'm not going to show graphs for the other vaccines and the other age groups, but similar parameters are influential to the results. So in the next slide, I just want to highlight some limitations. We don't include dynamic transmission, so we don't include indirect effects. We didn't analyze or include all potential RSV risk factors. Some medical conditions are likely associated with RSV disease, but we just didn't have the literature to analyze that. And we didn't look at some of those additional conditions. And then, of course, there are uncertain inputs. These are new vaccines, and so we have uncertainty about vaccine effectiveness, cost, RSV burden, and duration, and the waning pattern of vaccine protection. Next slide. So in conclusion, if there were a recommendation for RSV vaccination for all adults 75 and older, the incremental cost-effectiveness ratio would be about $50,000 per quality-adjusted life year gain using the Pfizer or GSK vaccines, and about $66,000 per quality-adjusted life year for the Moderna vaccine. If instead we limited the recommendation to those age 75 and older with at least one chronic medical condition, then the incremental cost-effectiveness ratio would drop. If we add in adults 60 to 74 with at least one chronic medical condition, the incremental cost-effectiveness ratio would be about $61,000 to $81,000 per quality-adjusted life year gain. If, however, the recommendation were to include adults 60 to 74 without chronic medical conditions, then the incremental cost-effectiveness ratio would rise to about $500,000 or more per quality-adjusted life year gain. If we add in adults aged 50 to 59 with at least one chronic medical condition, that cost-effectiveness ratio is a little bit over $150,000 per quality-adjusted life year gain. And then by specific condition, the cost of the dollars per quality-adjusted life year saved was lowest among adults 50 to 59 with heart failure, immune compromise, and highest among those with diabetes. And finally, longer duration of protection, if we assume it's 36 months than 24 months, or higher baseline RSV disease burden, made all these policy options more cost-effective. And with that, we'll go to the next slide, and I think either we'll stop for questions or let me know if you'd like me to go on to the next presentation.
Dr. Hutton, let's go on to the next presentation and then combine all the questions, if that's okay.
Perfect. Okay, so let's go to the next slide then. And we'll go into the risk-benefit analysis of RSV vaccination in older adults. Okay, so this one's we're going to look at the risk-benefit comparison of RSV vaccination in older adults. Let's go to the next slide. It's a similar research team here, again, University of Michigan and CDC. Next slide. We have no known conflicts of interest to present. Next slide. So our objective here is to compare the estimated benefits of RSV vaccination and the potential risks of Guillain-Barré syndrome. With RSV vaccination, we're really going to focus on those GSK and Pfizer vaccines. We're going to examine adults in those age groups we just saw. We're using the similar mathematical model you just saw, and it's based on the new vaccine effectiveness and Guillain-Barré risk data you just saw. Let's go to the next slide. Again, so we're comparing benefits versus risks here, and particularly focusing on Guillain-Barré risk. Okay, next slide. We're using the same target populations we talked about here, same color coding we just saw, and this time, though, we are going to split out the Pfizer and GSK vaccines, and we're not comparing them to each other, but comparing each to no vaccination. And we're going to use the same definitions of these chronic medical conditions. In fact, if we go to the next slide, we are still looking at those without chronic medical conditions, those with specific chronic medical conditions, and again, when I say with chronic medical conditions, I'm referring to those 6 conditions above the horizontal line, but we will look at some of the conditions at the bottom here with heart failure and immune compromise, and the same assumption about vaccine effectiveness in half. Let's go to the next slide. Similar models we've seen before. In this analysis, we're really just going to focus on Guillain-Barré syndrome, though, in terms of that adverse events. So let's go to the next slide. And that attributable risk of Guillain-Barré syndrome is based on the FDA active surveillance, which we just saw presented by FDA here. It's based on the FDA analysis and CMS data on inpatient claims data. Let's go to the next slide. So what do we mean, or what numbers are we using here? Again, we're using Pfizer's Abrivio vaccine assumption of 16 Guillain-Barré cases per million doses administered. That confidence intervals from 3 to 29. For the GSK Arexvy, and that's 3 Guillain-Barré cases, 95% confidence interval from 0 to 10 per 1 million doses administered. You will note that the lower end of the confidence interval was negative, but we're not going to assume there's any protective effects of the GSK vaccine. These risk estimates are in excess of background rates of Guillain-Barré, and again, this is of course based on data that's still evolving. So let's go to the next slide. Again, I'm going to present results in terms of per million doses of vaccination over 2 RSV seasons. So let's go to the next slide and look at some results. So these are estimated RSV-associated outcomes avertable over those 2 RSV seasons, and looking at potential cases of Guillain-Barré in red versus the bars showing the events averted. Here, this is showing results for Pfizer on the left-hand side and GSK on the right-hand side. And again, this is adults age 75 and older. We can see thousands of hospitalizations averted with each vaccine and many hundreds of ICU stays and deaths avertable. The lower bounds of our estimates are shown in blue at the bottom, and they're still much higher than the numbers of estimated Guillain-Barré cases per million. Let's go to the next slide. Here we have results for those adults age 60, 74 with at least 1 chronic medical condition. Here we still see some lower numbers of events averted than the previous slide, but the events averted are still higher than the Guillain-Barré cases anticipated per million. Let's go to the next slide. This graph is showing outcomes avertable for adults age 50 to 59 with at least 1 chronic medical condition. These numbers are lower still than what we saw in the previous slides. Let's go to the next slide though, which has things zoomed in. And we can see the hospitalization and ICU stays and deaths avertable are still anticipated to be higher than the Guillain-Barré cases, although getting closer to some of the bounds. So let's go to the next slide. And the next slide, where we're going to look at some scenarios here. The first scenario is looking at outcomes avertable among adults without chronic medical conditions. So the next slide, we have adults age 75 and older with none of these conditions here. The same thing with Pfizer on the left and GSK on the right. These events avertable are lower, but they are still higher than the cases of Guillain-Barré syndrome estimated. Let's go to the next slide, and we're going to look at adults age 60 to 74, again, with none of those chronic medical conditions. Here now, these events avertable are lower still, and let's zoom into the next slide. And here we can see that the base case estimates for events averted are still higher than the cases of Guillain-Barré syndrome. But our lower bound for the deaths avertable does overlap with the confidence intervals, particularly the confidence interval of rates of Guillain-Barré syndrome for Pfizer. So here, again, deaths are getting closer to the Guillain-Barré cases avertable. Or sorry, that might happen. So let's go to the next slide, which is showing specific chronic medical conditions. And if we go to the next slide here, we're going to first focus on the Pfizer vaccine. So these are results for the Pfizer vaccine. And this is the yellow bars are those adults age 75 and older with specific chronic medical conditions. You can see that for those 75 and older, all those estimated, and these are all deaths averted, the deaths averted are all higher than the estimated Guillain-Barré cases. Let's go to the next slide, which is focusing on adults 60 to 74. Now the highlighted bars are for those age 60 to 74. These are still higher than the estimated Guillain-Barré cases as well. If we go to the next slide, we're going to be looking at the GSK Arexvy vaccine, starting again with adults age 75 and older with specific chronic medical conditions. Here we can see that these bars of deaths averted are estimated to be much higher than the number of Guillain-Barré cases that might have happened. If we go to the next slide, we're going to look at adults highlighted here in yellow are adults 60 to 74. And these are also higher than the estimated Guillain-Barré cases as well. And then if we go to the next slide, we're looking at adults 50 to 59 with these specific chronic medical conditions. Here, these are, the base case estimates are still higher than the Guillain-Barré cases. And I will say, I've highlighted a few lower bound estimates. If the lower bound estimates is less than 50, but they're still higher than the estimated Guillain-Barré cases. Okay, let's go to the next slide. And in summary, the estimated numbers of avertable deaths are much higher than Guillain-Barré cases, particularly for adults age 75 and older, and those adults 60 to 74 with at least one chronic medical condition. The estimated numbers of avertable hospitalizations and ICU admissions are much larger than potential Guillain-Barré cases for all age groups for both the GSK and the Pfizer vaccines. The estimated numbers of avertable deaths are larger, but more similar in magnitude than the potential Guillain-Barré cases for the adults age 50-59 with at least one chronic medical condition, or adults 60-74 without chronic medical condition, particularly for the Pfizer vaccine. And with that, we'll go to the next slide, and I will be, bring up some limitations. We do have some uncertain inputs here. RSV hospitalization incidence is uncertain. It's based on RSV net data, which only is about 9% of the US population. We didn't include all conditions that might increase the risk for severe RSV disease. Vaccine effectiveness data is available only for the first, observational data is only available for the first few months after vaccination. We're still uncertain about longer-term waning efficacy. And the risk of Guillain-Barré syndrome, of course, these estimates are calculated using small number of events, so we still have a high amount of uncertainty around the Guillain-Barré estimates. With that, though, let's go to the next slide and open it up for questions. Thank you.
Thank you so much for a great presentation. Very thorough, both of them. Questions from the voting members? You were so clear that no one has. Oh, here comes Dr. Cotton.
Dr. Hutton, thank you so much. Your presentations to the work group and your presentations now are spectacular, and we are so appreciative of your input. I'd just like to go back to slide 34 in the prior presentation, just so we can ponder that a little bit as we think about the different age groups and risk factors and whatnot. I would just like to emphasize, I don't actually have a question for you other than, can we look at this some more, is my question.
Sure, I did love to just put this so that we have extra time, but yeah, welcome to spend more time on this.
I'd like to emphasize on this slide, there's a cost saving, so where there's an asterisk, so for chronic kidney disease in those 60 years of age and over, and COPD in those 75 years of age and over, and lung transplant and allogeneic stem cell transplant, there are cost savings. And then, so as we think today about various cohorts, the 50 to 59, 60 to 74, and greater than 75, I will say there's a lot of blue on this slide. There's less purple and then a lot less green, just being simplistic. So perhaps people could sort of retain this slide as you're thinking just really about cost effectiveness ratios. Thank you.
Dr. Laird. Oh, sorry, go ahead.
Go ahead.
No, it was Dr. Hutton was replying.
Yeah, go ahead, Dr. Hutton. Sorry, I cut myself off.
I just want to thank you for pointing out, too, I went through things so quickly, I didn't point out that those stars suggest that things are cost saving.
And also on this slide, this is Dr. Lair, I find that the chronic kidney disease, even for the 50 to 59, is fairly cost effective. And so I recognize the overall picture, but there seem to be some subsets where the 50 to 59 might be reasonable. So that's a point for discussion for later that I'll probably be bringing up. Thank you.
And I'd like to emphasize, I think that chronic kidney disease is any type of chronic kidney disease. It's not just patients on dialysis. So it's a fairly large and somewhat amorphous population. Can someone define, does someone have the criteria for what chronic kidney disease is? It's, I think, creatinine over 2 or some number. Yeah.
I can, this is Michael Melgar, one of the co-leads of the work group. The epidemiologic inputs for this mathematical model were derived from RSVNet, and specifically the analysis using RSVNet data and BRFSS by Dr. Rebecca Woodruff. So specifically for chronic kidney disease, the epidemiology or the burden of RSV-associated hospitalizations, ICU admissions, and deaths were based on using number of cases in RSVNet among adults who had documented chronic kidney disease of any stage compared with a population prevalence of chronic kidney disease that was dependent on self-report. So, and that is largely true of all of the chronic medical conditions for which we're evaluating cost effectiveness. I think that there is, as Dr. Cotton mentioned, some heterogeneity in terms of risk dependent on how severe the stage of chronic kidney disease is. We will explore some of that during the evidence recommendations framework, but in this methodology, this is taking all comers with chronic kidney disease as best as can be ascertained, regardless of stage. Thanks.
Yes, and I don't know how you thought about cost effectiveness, Dr. Lehr. Cost saving is one thing. Most immunizations are not now cost saving. Here's one that is for certain groups, but cost effectiveness, the blue is all pretty much, except for maybe one or two conditions, in the realm of what we would consider in the United States cost-effective use of our resources.
Yes, Dr. Brooks.
Yeah, first of all, yeah, thank you. Excellent presentation ×2. I agree with Dr. Cotton in terms of looking this graph, this slide being an important one, and the bottom with the none of the above, especially the 60 to 74, as we're going to be thinking about, a vote. The other thing is just a comment. I really appreciate the info on GBS compared to risk benefit. That's the bottom line in what we do. There are issues. Risk may be small, but if it's close, that we have to take that into account. But it really puts into context the discussion we had regarding the adverse event of GBS, and noting that hospitalization and death were some of the comparisons, but it was just GBS, not hospitalization with GBS or death from GBS. So just making that comment.
Thank you. Any other comments? Okay. Y'all ready for the comparison of economic analyses of adult RSV vaccination? Here we go.
Good morning. Can you hear me? Yeah, good morning. My name is Ismael Ortega Sanchez. I am the Senior Health Economist at the NCIRD. And today I will attempt to compare and summarize key elements and findings of 3 economic studies on RSV vaccination in adults. And they intend to address the 3 different policy questions, specifically on all adults 75 years or older, and on adults 60 and 74 and 50 and 59 at increased risk of severe disease. These 3 models were discussed in extension in the adult RSV ACIP working group. Next slide, please. 2 of these studies have been conducted by manufacturers of candidate vaccines. The first study was conducted by GlaxoSmithKline and his collaborators. GSK model will be in orange or brown. The second is the Moderna. Moderna is the manufacturer of the mRNA 1345 RSV vaccine. That will be in green. The third is an analysis led by Dr. Hutton, the one that just saw, and collaborators from the University of Michigan and CDC collaborators. I will refer to this study as the CDC model in light blue. For full disclosure, I have been part of the team conducting the CDC model. Next slide, please. The starting point of the economic models is the policy question regarding potential recommendations for the use of RSV vaccine in older adults populations. Currently, these 3 policy questions being considered focus on age groups as well as those older adults at increased risk of severe RSV disease. Next slide, please. To consider the economics of a policy question is to consider simultaneously the health benefits and cost of vaccination, namely, is vaccinating other adults at any age of risk group against RSV cost effective? To address these questions, the three models use a comparator and vaccinated other adults in the specific age and risk group. Non-vaccination was deemed as an appropriate comparator under the current shared clinical decision-making recommendation. And with this comparator, they focus on analyzing the incremental effectiveness and cost effectiveness of RSV immunization in this age and risk groups relative to no vaccination. Next slide, please. However, the models have to address different incremental questions. In the middle, the CDC model is not one, but in fact 3 models in one, meaning that using data of vaccine efficacy, safety, and vaccine price for each manufacturer, the CDC model reports separate health and cost effectiveness outcomes for combined protein subunit vaccine type and for the Moderna vaccine for age and risk groups considered in each of the policy questions. Regarding policy question 3, it should be mentioned that the GSK model reports 5 conditions included with COPD as the base case. The other conditions are heart failure, coronary artery disease, asthma, and diabetes. Although the CDC model considers 8 risk conditions, the base case scenario was with at least 1 chronic medical condition, and as you have seen, those include chronic obstructive pulmonary disease, asthma, coronary artery disease, chronic kidney disease, diabetes mellitus, severe obesity over BMI over 40, heart failure, and immunocompromise, and some. Not that only a single RSV vaccine is licensed for adults of age 50 and 59 years who are at increased risk of RSV, lower respiratory tract infection. As such, the CDC economic model uses only GSK-specific inputs for the 50-59 years old population. Next slide, please. In general, the 3 models follow similar designs. They all use a static analytical decision-making approach, rely on probabilistic or deterministic sensitivity analysis to manage the various data uncertainties. Each model is specific hypothetical US population of other adults or at an increased risk of severe RSV disease. However, in each model, the selection of a time frame is closely based on the duration of protection assumption. For example, the base case in the CDC model and the Moderna models rely on 2-year time frame, although a 3-year time frame is included only in the scenario analysis, while in the GSK is used as a 3-year time frame in the base case, and that it comes straight from the duration of protection that they assume in their models. Next slide, please. To identify the determinants or influential variables of this analysis, we examine the one-way sensitivity analysis provided by each of the models. Here you may be able to see those of Moderna and GSK. Similar figures were presented by Dr. Hurton for the 50 and 59. These tornado figures help to identify and rank the most influential input variables from top to bottom. Each horizontal bar represents the input variables in the model, so the size and direction of the horizontal bars describes the influence of each input. With this evaluation, we identify these variables, and we're going to try to address each one of these in the following slides. Next slide, please. In this and the following slides, we will focus on describing the specific input values and assumptions about these identified variables. Specifically, in this slide, we could compare the input values of Moderna and the CDC model regarding the incidence of RSV hospitalization and outpatient care and the medical cost for hospitalization. If we look closer within them, we could see marked difference in the rates and hospitalization and outpatient illness, as well as the unitary medical cost of hospitalization. Next slide, please. Likewise, in this slide, GSK shows outpatient and hospitalization rates mostly higher than those used by the CDC model. Also, in the higher end are the cost of hospitalization, and we will see also some other elements regarding this specific value. Once more, the committee should bear in mind that the higher these input values are, the lower the ISS will be, or, what is equivalent, the more cost-effective vaccination program will look like. Next slide, please. Another group of key variables are the initial or early peak of vaccine efficacy inputs and the duration of protection. In this slide, Moderna has updated most of their initial and early peak vaccine efficacy as shown here, and uses an extrapolation with weightless square linear regression. Next slide, please. Although it is important how well the vaccine effectiveness starts at the RSV season, it is much more significant how it performs during the whole season or the seasons. These figures describe how the duration of protection is modeled by Moderna compared to the one used by CDC model. Both rely on new available duration protection data from vaccine trials and cover the first 19 months in the case of Moderna. However, after this initial period, the residual protection is based on assumptions and higher level of uncertainty as intended to be shown by the pink shade areas. In the case of the CDC model, it tries to minimize the uncertainty and the impact of this uncertainty on the outcomes, whereas on the Moderna analysis, you can see that it goes up to 3 years by the extrapolation of the first data, of the solid data that comes in the first months. Next slide, please. In a similar fashion, now we could observe the initial early peak of vaccine efficacy inputs for GSK and CDC models for the cost effectiveness of vaccinated adults 50 and 59 at increased risk of severe RSV disease. Although the values are in the same ballpark, the approach used in the models are different. Next slide, please. This figure you may recognize because it has been presented before to this committee. This slide reports the vaccine efficacy assumptions of GSK, the assumptions that GSK does in an initial peak and a linear decay. Note that the duration of protection assumption as described in the solid line is followed by dotted ones for each outcome. A weighted linear regression to the mean is fitted and estimated to describe the residual protection of the months after the vaccination. The duration of protection would reach 0 at the 48 months for RSV lower respiratory tract disease or at the 36 months for RSV ARI. Note that the 23-month points marks the trial data, they are in solid, used by the vaccine efficacy duration of protection. To its left, the quality of data is higher than the ones that goes to the right, namely that the higher uncertainty as pointed by the pink shaded area. Next slide, please. Using the same updated vaccine efficacy from GSK vaccine for the phase 3 clinical trials, the CDC model relies on a more conservative approach. Specifically, the CDC model resorts to a stepwise approach as shown in this figure. This figure is specific to the GSK vaccine. Again, after the initial period, which are based on the phase 3 clinical trial, the residual protection is based on assumptions and a higher level of uncertainty as intended to be shown by the pink shaded area. The CDC model tries to minimize the impact of this uncertainty on the outcomes. Next slide, please. Up to this point, we describe inputs used in the models. In this and the next slide, we will compare the incremental cost and per quality ratios for each of the policy questions. It should be noted that this is not the only outcome that has been analyzed in these models, but only the most important one that will help us to make the comparisons across them. Specifically for the two-year time frame, regarding the policy question number 1, which is vaccinating adults aged 75 years and older against RSV illness, Moderna and CDC models report societal costs between $55,000 to $65,000 per quality save. This is for the general population, 75 years and older. Regarding the second question, vaccinated adults aged 60 and 74 years old at higher risk of severe RSV disease, Moderna and CDC model report societal costs between $80,000 to $89,000 per quality save. So basically, the estimates are in the same ballpark here. Next slide, please. Using a 3-year time frame, and I want you to focus on the second row of these graphs, yeah? The GSK estimate cost-saving values for 4 high-risk conditions: chronic obstructive pulmonary disease, heart failure, coronary artery disease, and diabetes. Only for asthma, GSK estimates societal costs about $2,400 per quality save. In the base case, the two-year vaccine efficacy time frame that the CDC model uses, The CDC model estimated a societal cost of $154,000 per QualiSave for adults with at least one chronic condition. And remember that this is the one chronic medical condition includes chronic obstructive pulmonary disease, asthma, coronary artery disease, chronic kidney disease, severe obesity, and diabetes. For individual conditions, societal costs ranged from $35,000 for chronic kidney disease to $172,000 for diabetes per QualiSave. When evaluating other special conditions for not included in at least one cost per quality, those ranged from cost saving to approximately $14,000 per QualiSave. In this case, we have to take into account two things. The time frame for the base case scenario for GSK relied not only on a higher hospitalization rate, which is one of the most important variables, but also on the 3-year time frame, along which it is assumed an important degree of vaccine impact. Next slide, please. This summary and comparison identifies some limitations among the models. Factors not considered that may result in underestimating the cost-effectiveness of RSV vaccination are no impact of RSV on long-term prognosis of specific conditions, specifically chronic obstructive pulmonary disease, no indirect effects of vaccination, no productivity or quality of life impact on caregivers during RSV illness. All models partially include RSV-related medical costs incurred after discharge for RSV-associated hospitalization or emergency department visit. Manufacturing models partially include potential vaccine-associated serious adverse events, or for Guillain-Barré syndrome. In particular, the CDC model is the one that did assess the quality of life impact, resource utilization, and costs associated with severe adverse events, including Guillain-Barré syndrome, specifically for protein subunit RSV vaccines. Vaccine efficacy beyond median clinical trials follow-up time is unknown, and all three models assume seasonal vaccination without an off-RSV season vaccination impact. Next slide, please. In conclusion, different key inputs and assumptions among GSK, Moderna, and CDC models explain differences in the results, and these three ones are the ones that we have identified as the most relevant ones. In general, regarding policy question number 1, vaccinating all adults over 75 years old against RSV illness, Moderna, University of Michigan and CDC model reports societal costs between $51,000 to $66,000 per QualiSave. Regarding policy question number 2, vaccinating adults aged 60 and 74 years old at higher risk of severe RSV disease, Moderna and CDC model report societal costs between $61,000 to $81,000 per QualiSave. And regarding policy question 2, vaccinating adults aged 50 and 59 years at higher risk of RSV disease, show more discrepant cost per quality ratios. Outcomes range from societal cost saving, in the case of GSK, to $150,000 per quality save in the case of CDC model. Overall, vaccination will significantly reduce RSV disease burden in adults 50 and 59, 60 and 74 years old at higher risk or RSV disease, and in general population of adults aged 75 years and older. Efficacy of clinical trials data and assumptions support the impact of these reductions. Next slide, please. To finish this summary, let me thank and acknowledge the collaboration of who helped me to put together this presentation. Thank you.
I'm talking to a dead mic. Okay, lots of data, very good presentation, open to questions. Dr. Lair.
Two things. Slide 8. This is the first time I've ever seen a manufacturer model have worse assumptions than a CDC model. And I just wanted to comment on that because for many years, that's not the case. This is an unusual situation that I've never seen before. Just wanted to comment on that. But if you could go to slide 13 and 14, this is more for my colleagues. Does anyone have a sense of, for other vaccines, which of these two assumptions is more likely to be accurate? This one where it goes a more linear decay or a more rapid decay here, and I'm wondering if anyone has any input on that. Thank you. I'm seeing shaking of heads, so thank you very much.
Dr. Schechter.
Thank you very much for the presentation. On slide 10, slide 16 rather, my bad, slide 16, and the $154,000 figure for the 2-year time frame, and I'm just thinking back to the blue bars from the last presentation, which were, for me, the conditions below that, which makes me wonder if sort of the diabetes or something else is driving most of those cases, or I'm wondering if it's too late to pull up that slide too. If many of the conditions are lower than that, but diabetes or other conditions are high prevalence and thereby driving the overall estimate. Okay, thank you.
This is Michael Melgar, one of the 2 co-leads of the work group. In the footnote, we do have some examples of condition-specific results from the Michigan model, again, summarizing those that were shown in the bar graph with horizontal bars. And so the results in the table for the Michigan model are for adults with at least one of 6 common chronic medical conditions. However, taking individual conditions, the ICER, or cost effectiveness ratio, ranged from as low as $30,720 per QALY gained for adults with chronic kidney disease. Again, that's all comers with chronic kidney disease, so a mixture of adults with CKD stage 1 all the way up to end-stage renal disease, to as high as $171,661 per quality adjusted life year gained for adults with diabetes. And that would be adults with diabetes with or without complications. So that would be a combination of adults with an A1C of 6.6 who are highly compliant with their oral diabetes medications, all the way up to patients who have had multiple lower extremity amputations and an A1C of 13. So these are all very heterogeneous populations, but this is as much detail as we're able to provide in these cost effectiveness analyses. Thanks.
Any other questions? Okay, we're actually going to take, I think, a whole 10-minute break. Yeah, well, no, 6 minutes. No, we'll try a whole 10. The next session is very intense. It's going to include conversations with our manufacturing partners, but also we're going to do ETR, clinical considerations, and then we're going to have discussion. So walk around, get the blood flowing again, and we'll see y'all in 10 minutes.
Okay. So I guess.
All right, welcome back, everyone. We are going to have a brief comment from each of the RSV vaccine manufacturers. Greatly appreciate them taking the time to speak with us today. Each manufacturer will have 2 minutes, and we hope that you stick to those 2 minutes, because what we would like to do is have plenty of time for the voting members to have a thorough discussion a little bit later after that. So our first speaker will be Dr. Friedland from GSK.
Hello, can you hear me?
Perfectly.
Hello, I'm Leonard Friedland from GSK. GSK asked the committee to consider 2 requests in the interest of public health. First, as per the FDA approval on June 7, we asked for a vote on a recommendation for Arexvy's use in adults 50 to 59 at increased risk for LRTD caused by RSV. Over 13 million US adults 50 to 59 have at least one known medical condition that increases their risk for severe RSV outcomes. RSV in the US is estimated to cause 42,000 hospitalizations each year in adults 50 to 64, with a disproportional number in Black and Hispanic adults. Without ACIP's recommendation, insurers are unlikely to cover vaccination costs, which may increase inequity. A lack of a vote today is a missed opportunity to provide access for this group in advance of the upcoming respiratory season. Second, GSK asked to amend the vote for use in adults 75 plus for all adults 60 and older, so this group will continue to have reimbursable access to RSV vaccination. This universal AIDS-based recommendation could help address inequity. The profile.
Sorry, this is Jan Salgeri. I will repeat. So the profile of RSV is built on robust clinical trial and post-licensure data with protection up to 2 full calendar years. RSV vaccine effectiveness against severe disease is validated by the observational vaccine efficacy studies presented by the CDC earlier today. Patient safety is our highest priority, and we will follow a proactive and evidence-based approach to safety surveillance, including cases of GBS. The FDA's current robust self-control case series analysis as part of the BEST initiative indicates there is no statistically significant increased risk of GBS with RSV. The VSD analysis shows no statistical signal for GBS after RSV.
The totality of evidence provides further confidence in the unchanged and favorable benefit-risk profile of Arexvy.
Thank you very much. We appreciate you taking the time to speak with us today.
Do not appear warranted at this time. May I just finish that last statement? It's quite important.
We've gone over time, but thank you. Dr. Mancy from Moderna.
Great. Good morning, Dr. Talbot. Can you hear me okay?
Perfectly.
Great, thank you. Well, good morning, and thank you for this opportunity. My name is James Mancy, and I head up the U.S. Medical Affairs for Moderna. As we've seen, RSV remains a significant and often underestimated cause of lower respiratory tract disease, particularly among older adults and those with high-risk conditions. The recent FDA approval of mRESVIA on May 31st marks a significant advancement in the prevention of RSV. As described by Dr. Doss, this FDA approval of mRESVIA was based on positive data from our phase 3 trial that enrolled over 37,000 adults 60 years and above, and included a diverse population by race and ethnicity, individuals with chronic medical conditions and frailty. This trial was distinctive in its year-round recruitment, vaccination, and monitoring, providing a comprehensive understanding of mRESVIA's clinical performance. And the diverse population enrolled was representative of the US population, further enhancing the relevance of these findings, which demonstrated high and consistent efficacy and safety, regardless of the age, comorbidity, or frailty of the individuals. The efficacy persisted through 18 months, which included 3 RSV seasons in the Northern Hemisphere, and mRESVIA elicited robust immune responses across all subgroups, including adults over 80 years, and revaccination after 12 months boosted antibody responses to initial dose levels without safety concerns. And the safety profile for mRESVIA was well tolerated, with no identified cases of ADEM, Guillain-Barré syndrome, or other significant safety concerns. And there were no additional reactogenicity or immune interference when co-administered with quadrivalent flu vaccines or mRNA COVID vaccine Spikevax. And even with the availability of 2 licensed licensed vaccines for RSV, there is still a pressing need to increase awareness and address the low vaccine coverage rate. This is the introduction of mRESVIA, our mRNA vaccine that builds on the extensive real-world clinical experience with mRNA COVID vaccines administered to hundreds of millions.
Dr. Mancy?
Yes.
I'm going to have to cut you off. I'm so sorry.
Oh, no. That's all right.
But thank you.
Thank you.
We're going to move over to Pfizer, Dr. Jodar, please.
Thank you, Dr. Talbot. Do you hear me well?
Yes.
Thank you. Pfizer would like to thank the committee for the opportunity to speak today. My name is Dr. Luis Jodar. I'm the Chief Medical Officer for Vaccines and Antivirals at Pfizer. Pfizer strongly supports the work group proposal to move away from the shared clinical decision-making approach and to adopt a routine age and risk-based recommendation for RSV vaccination. Obviously, this decision will simplify vaccination implementation, increase the uptake of the vaccine, and ultimately reduce the disparities in access and outcomes among different populations. However, Pfizer respectfully asked the committee to consider a threshold of 60 years and older rather than the 75 years of age for the routine age-based recommendation. And this is due to 5 main reasons. Firstly, RSV infection, I think it's clearly demonstrated that it's still a serious public health issue for people 60 years and older, causing an estimated 60 to 100,000 hospital stays and 6,000 to 10,000 deaths. Secondly, around 75% of hospitalizations, ICU admissions, and deaths due to RSV occur in the age bracket from 60 years and older. Thirdly, a Pfizer public health impact model using updated vaccine efficacy following Abrysvo over 2 seasons shows that a routine recommendation starting at 60 years of age is estimated to avert over 80,000 additional hospitalizations and around 6,000 additional deaths compared to a recommendation that starts at 75 years. Fourthly, a routine age-based recommendation at 60 years would help provide those at highest risk of RSV infection and with the least access to care the opportunity to be vaccinated and would better align with the platform for other respiratory vaccines. And finally, the benefits of RSV vaccination of 60 and older outweighs the potential risks and is likely to have a large public health impact in this population. Thank you very much to the committee.
Thank you, greatly appreciated. Now we are going to move into ETR. Dr. Melgar, are you ready?
Yeah, good morning. Thank you, Dr. Talbot. I'm Michael Melgar. Together with Dr. Amadea Britton, I co-lead the ACIP work group for adult RSV vaccination. Today, I'll be opening the evidence to recommendations presentation, and I'll be handing off partway through to Dr. Britton and our colleague, Lauren Roper. Here are the 3 policy questions we'll address through this presentation. Should all adults 75 and older be recommended to receive a single dose of RSV vaccination? Should adults 60 to 74 at increased risk of severe RSV disease be recommended to receive a single dose of RSV vaccination? And should adults 50 to 59 at increased risk be recommended to receive a single dose of RSV vaccination? We'll start with the 2 oldest age groups first, and then we'll return to the 50 to 59 age group at the end. For new committee members, this is the evidence to recommendations framework that ACIP uses to evaluate the evidence supporting vaccine recommendations. We'll discuss each of these 7 domains today and provide the work group opinions on each before discussing the final policy endorsed by the work group. For some domains, we'll present on RSV or RSV vaccination in general, while for others, we'll show data for specific vaccine products, generally splitting the 2 protein subunit vaccines made by GSK and Pfizer, and which have been in use since last year, from Moderna's mRNA vaccine, which has only recently been licensed by FDA. So we'll open with public health problem. During 2016 to 2020, CDC estimates that RSV was associated with 90 to 140,000 annual hospitalization in US adults 65 and older, and an additional 10 to 20,000 hospitalizations in adults 60 to 64. By comparison, during the same period, annual influenza-associated hospitalizations were estimated to number 170 to 470,000 in adults 65 and older. So RSV-associated hospitalizations occur at 2 to 3-fold lower frequency in older adults compared with influenza, but the public health problem is of a similar order of magnitude. Though it's important to note that the annual influenza disease burden is attenuated by the existing routine vaccination program. Another way to look at RSV burden is by looking at per population hospitalization rates. These are data from CDC's RSV Hospitalization Surveillance Network, or RSVNet, which spans 58 counties in 12 states, with a catchment area representing almost 9% of the US population. These are estimated annual rates of RSV-associated hospitalization per 100,000 adults, stratified by age, over the same 4 seasons, 2016 to 2020. Even among adults 60 and older, RSV hospitalization rates increased with each progressive age group, with an inflection point at age 75. Now, these are updated results from an analysis presented to ACIP in February, using RSVNet and CDC's Behavioral Risk Factor Surveillance System, or BRFSS, to estimate specific chronic medical conditions as potential risk factors for RSV hospitalization. These adjusted rate ratios speak to how much higher the RSV hospitalization rates are among adults with each condition compared with adults without the condition. This means, for example, that adults with COPD experienced an RSV hospitalization rate 4.6 times higher compared with adults who do not have COPD. Results were statistically significant for chronic kidney disease, COPD, severe obesity, asthma, diabetes, and current smoking. Here are additional results from the same analysis, adjusting the rate ratios for number of conditions as well as age. In doing so, we can see that having at least 2 chronic conditions and having age 75 or older were the strongest independent risk factors for RSV hospitalization. There are other chronic conditions that have been associated with severe RSV disease beyond those that could be evaluated in this analysis. In particular, heart failure has been consistently identified as a major risk factor for RSV hospitalization, with as many as 28% of all identified adult RSV hospitalizations occurring in adults with chronic heart failure. And of course, immune compromise, particularly in the setting of lung transplant or hematopoietic cell transplant, has been associated with severe outcomes and high mortality following RSV infection in adults. Finally, persons living in nursing homes and other long-term care facilities also experience increased risk of severe RSV disease, with RSV frequently causing large outbreaks of respiratory illness in these settings. Lastly, some additional things to consider regarding burden of RSV disease. Prior to RSV vaccine introduction, disease severity of RSV among hospitalized adults 18 or older was similar to severity of COVID-19 and influenza among patients who were unvaccinated against each of those pathogens, respectively. In a recent cross-sectional study, nearly 1/4 of adults 50 or older hospitalized with RSV infection experienced an acute cardiac event, most frequently acute heart failure, and that included 1 in 12 adults with no documented underlying cardiovascular disease. And in a retrospective chart review of adults hospitalized with RSV infection, most patients required follow-up care and 10 to 16% required skilled nursing either at home or at an assisted care or nursing facility, compared with 7% before admission. In summary, the annual rate of RSV-associated hospitalization increases with increasing age, with a steep rise at age 75. Certain chronic medical conditions are also independent risk factors for RSV disease, and RSV has significant post-hospitalization sequelae in older adults. Having reviewed this evidence, the work group felt that yes, RSV disease is of public health importance among adults 75 and older, and similarly, the work group felt that RSV disease is of public health importance among adults 60 to 74 who are at increased risk of severe RSV disease, in other words, those who have risk factors. Next, we'll discuss the benefits and harms of RSV vaccination in the target age groups. We've organized this section of the presentation by vaccine platform and by age group as shown here. We'll begin by discussing protein subunit RSV vaccination, first in adults 75 and older, and then in adults 60 to 74 at increased risk. We'll include sections on grade, followed by additional considerations beyond grade. Then we'll repeat for Moderna's mRNA RSV vaccine. Here's our first PICO question. Among adults 75 and older, does protein subunit RSV vaccination, compared with no RSV vaccine, impact the following 8 grade outcomes? In the interest of time, I won't read them out loud. We'll use the same 8 outcomes for grade throughout the different policy questions that we're evaluating. Now, the standard for evidence inclusion in grade is very high and requires that all studies be identifiable in systematic reviews of published literature. As such, none of the unpublished safety or effectiveness data that was presented earlier today can be included, and grade is currently limited to clinical trial data only. In light of that, and since ACIP has already seen grade evaluations of the 2 protein subunit vaccines, we've opted to provide only a high-level overview of the grade certainty adjudications for each outcome. The data included here were from 2 large phase 3 clinical trials, one from Pfizer and one from GSK, and for safety outcomes only, also from 2 smaller early phase trials. Data from these studies were pooled in meta-analyses to evaluate each outcome. Additional details on grade methodology for these policy questions can be provided if the committee is interested. In the interest of time, I'll focus on the 4 outcomes that the work group deemed critical for policymaking. From the clinical trial data, we can conclude that protein subunit RSV vaccination in adults 75 and older likely reduces medically attended RSV lower respiratory tract disease with moderate certainty, and it may reduce RSV hospitalization with low certainty. Protein subunit vaccination likely results in little to no difference in serious adverse events when considering all SAEs of any type or organ system with moderate certainty. However, it may increase inflammatory neurologic events, including Guillain-Barré syndrome, with very low certainty. As we noted at the top of the presentation, however, we do know more about vaccine effectiveness and safety than what was captured in grade because we have unpublished post-licensure data from CDC and FDA systems. Synthesizing the vaccine effectiveness and safety data, here are the top-line results of Dr. Hutton's benefit-risk analysis, formatted in a way that may be familiar to ACIP from the February meeting. These results compare the preventable estimated RSV-associated hospitalizations, ICU admissions, and deaths over 2 consecutive RSV seasons per 1 million adults 75 and older vaccinated with a single dose of GSK's Arexvy or Pfizer's Abrysvo, weighed against the number of potential cases of Guillain-Barré syndrome attributable to vaccination. The comparison here is for the general population in this age group, regardless of the presence or absence of chronic medical conditions. The attributable risk of GBS was taken from the analysis presented earlier today through the FDA-CMS partnership, and estimates have been converted to units of attributable cases above background per 1 million persons vaccinated. And bottom line, preventable outcomes far exceed potential cases of Guillain-Barré syndrome for both vaccine products. In addition to GBS, there remain several uncertainties in the balance of benefits and harms for protein subunit RSV vaccines. As we saw today, there was a statistical signal for immune thrombocytopenic purpura, or ITP, after vaccination with GSK's Arexvy. Although chart review revealed that most initially identified cases were not new cases of ITP occurring after RSV vaccination, there remained a numerical imbalance in the small number of remaining cases. Additionally, publicly available data on co-administration with other vaccines remain limited, which is unfortunate considering nearly half of RSV vaccine recipients during this past season received it on the same day as at least one other vaccine, mostly influenza and COVID-19 vaccines. Based on this body of evidence, the work group concluded that the desirable anticipated effects of protein subunit RSV vaccination were moderate or large in adults 75 and older. They felt that the undesirable anticipated effects were small or moderate, and that desirable effects outweighed the undesirable effects. Next, we'll discuss protein subunit RSV vaccination of adults 60 to 74 with risk factors, starting with grade. The outcomes here are the same as those used for adults 75 and older. The same 4 clinical trials provided evidence for grade. The certainty assessments were also the same as for protein subunit vaccination in adults 75 and older, except that the prevention of medically attended RSV lower respiratory tract disease achieved high certainty rather than moderate. Again, we'll evaluate additional unpublished data to inform this policy question. Here are the results of benefit risk modeling for vaccination of adults 60 to 74 at increased risk of severe RSV disease with either GSK's Arexvy or Pfizer's Abrysvo. Per 1 million vaccinations, the overall numbers of RSV-associated hospitalizations, ICU admissions, and deaths preventable over 2 seasons are lower than they were for the general population 75 and older. However, they still universally exceed the number of attributable cases of Guillain-Barré syndrome as estimated through the FDA-CMS partnership. Now, especially for adults younger than 75 who have longer remaining life expectancy, it's important to consider duration of protection. Waning of protection over time is well known with other vaccines, and efficacy in both the Pfizer and GSK clinical trials showed some waning with increasing follow-up time after vaccination. Here we're showing efficacy estimates against the 2 co-primary outcomes in Pfizer's large phase 3 trial. Efficacy fell by approximately 10 percentage points from the first 12 months to the second 12 months. Importantly, after month 12, the median follow-up per participant was only 6 months. So Pfizer's vaccine may exhibit more waning beyond the estimates in the rightmost column, even when looking at the latter 12 months. And here are the corresponding efficacy estimates against the single primary outcome in GSK's clinical trial. Again, we see marked waning from the first 12 months to the second 12 months. Of the 2 manufacturers, only GSK has evaluated efficacy following revaccination. When clinical trial participants were administered a second dose of Arexvy 12 months after the first, they did not experience increased efficacy compared with adults who had received a single dose only at the start of the trial. Efficacy in season 2 for single dose recipients was 58.5%, while it was 58.3% for 2-dose recipients. Taking all of this evidence into account, the work group felt that the desirable anticipated effects of protein subunit RSV vaccination were moderate or large in high-risk adults 60 to 74. They felt that the undesirable anticipated effects were small or moderate, and that the desirable effects outweighed the undesirable effects. And here, I'll hand it off to my colleague Lauren Roper, who will continue this presentation.
Thank you, Dr. Melgar. We will now review the benefits and harms section for Moderna's mRESVIA RSV vaccine. I will go into a bit more detail for grade of the Moderna vaccine than was shown for the protein subunit vaccines, as this is the first time that RSV data
for Moderna have been evaluated using GRADE. The first PICO question is use of mRESVIA in adults 75 and older. This slide shows the GRADE effect estimates for benefits. Data was available from Moderna's 2-3 randomized controlled trial in adults 60 and older. The mean follow-up was 18 months post-vaccination per participant. For the outcomes deemed critical for decision-making, vaccine efficacy against medically attended RSV lower respiratory tract disease using the co-primary endpoint of at least 3 signs or symptoms was 39%. We had serious concern for imprecision due to the width of the confidence interval, as well as serious concern for indirectness, as the estimate includes all adults 60 and older, not limited to those 75 and older. Efficacy against hospitalization for RSV respiratory illness was 80.1%. We again had serious concern for indirectness, as this outcome included all adults 60 and older, as well as very serious concern for imprecision due to the width of the confidence interval, as well as fragility of the estimate. There were no RSV hospitalizations observed in the vaccine arm and 2 in the placebo arm, so efficacy was calculated using a 0.5 correction factor. This outcome was also evaluated at an earlier cutoff date than the previous outcome, with about 8 months post-vaccination per participant. Shown here are the GRADE effect estimates for harms. Data was evaluated again using the Moderna phase 2-3 trial in adults 60 and older, as well as an earlier phase 1 trial. Only participants 60 and older and who had received the phase 2-3 vaccine formulation or placebo were included from the phase 1 trial. Focusing on the critical outcomes, the relative risk for serious adverse events following Moderna's mRESVIA was 1. There was serious concern for inconsistency, as the phase 2-3 trial observed a relative risk of 1, but the phase 1 trial observed a relative risk of 5. There was also serious concern for indirectness, as all adults 60 and older were included in the estimate. Notably, there were no events of inflammatory neurologic events observed in either trial within 42 days of vaccination, so that this outcome was not evaluated in GRADE. Shown on this slide are the summary GRADE findings for use of Moderna mRESVIA in adults 75 and older. The vaccine likely reduces RSV LRTD in adults 75 and older. It may reduce medically attended RSV LRTD. The vaccine may reduce hospitalization for RSV respiratory illness, but the effect is very uncertain. Vaccination with Moderna's mRESVIA may result in little to no difference in serious adverse events and likely increases severe reactogenicity events. Additional outcomes had no data or no events observed in the trial. Now I will review some additional data not specifically captured in GRADE. Data on co-administration with mRESVIA and other adult vaccines is limited to clinical trial data evaluating safety and immunogenicity of co-administration with influenza and COVID-19 vaccines. Co-administration of mRESVIA with seasonal quadrivalent influenza vaccine, as well as mRESVIA with adult COVID-19 bivalent vaccine, met non-inferiority criteria for immunogenicity. These findings were presented at the February 2024 GRADE meeting, ACIP meeting. After reviewing the evidence for Moderna's mRESVIA in adults 75 and older, the majority of the work group felt that the desirable anticipated effects were moderate to large, undesirable anticipated effects were small, and the balance between the desirable effects relative to the undesirable effects favored the intervention. Now we'll review Moderna's mRESVIA in adults 60 to 74 at increased risk of severe RSV disease. Looking at the GRADE benefits for this population, the critical GRADE outcome effect estimates and certainties are the same as were shown for the 75 and older age group, as they included all adults 75 and older, all adults 60 and older. Shown here are the effect estimates for harms following Moderna's mRESVIA, and again, the effect estimates and certainties were the same as were reviewed for 75 and older. Shown here are the GRADE certainty findings for Moderna's mRESVIA in adults 60 to 74 at increased risk. Moderna's mRESVIA reduces RSV LRTD, may reduce medically attended RSV LRTD, and may reduce hospitalization, but the effect is very uncertain. Vaccination with mRESVIA may result in little to no difference in SAEs and likely increases severe reactogenicity events. Looking at Moderna's vaccine efficacy over time, RSV LRTD with at least 2 signs or symptoms was 56% from month 0 to 12 and 30% from months 12 to 24 with a mean follow-up of 7 months per participant. RSV LRTD with at least 3 signs or symptoms was 55% from month 0 to 12 and 36% from months 12 to 24, again with a mean follow-up of at least 7 months per participant. Among adults 60 to 74 at increased risk, the work group felt that the desirable anticipated effects were moderate to large, also that the undesirable anticipated effects were small, and unanimously felt that the balance between desirable effects relative to the undesirable effects favored intervention. Now we will transition from benefits and harms and will discuss the domain of values. This domain is evaluated for RSV vaccination generally, regardless of product. And here we'll explore how older adults feel about the potential, desirable and undesirable effects of RSV vaccinations. First, we'll discuss how concerned the populations are about RSV as a cause of disease. In CDC's Omnibus survey, 28% of adults 60 to 74 were very or moderately concerned about RSV disease. Among adults 75 and older, this increases to 36%. An additional 30 to 40% in each group reported being a little concerned. Now, how has this concern translated to adults seeking RSV vaccination? After 1 full season of vaccine availability, we've seen that approximately 20 to 30% of older adults, depending on the age group, have reported receiving an RSV vaccine in CDC's National Immunization Survey. You'll notice that adults 70 to 79 and 80 and older have higher vaccine uptake than those 60 to 69, consistent with the previous slide. This may also be driven by access issues among 60 to 74 who mostly do not yet qualify for Medicare. Finally, I'd like to briefly note how patients value vaccine protection versus risk of adverse events. While we do not have any data specifically looking at how patients value estimated protection against RSV in relation to potential risk of GBS, there are a few considerations. Adults are willing to accept some rate of vaccine-associated adverse events for the benefit of preventing disease. Individual baseline and vaccine-associated risk of GBS may differ by age group and presence of chronic conditions. And willingness to accept risk of GBS after vaccination may differ by health status and age and perceived risk of RSV-associated disease. To summarize the data available on values, in the first RSV season after RSV vaccine availability for 60 and older, an estimated 20 to 30% of US adults in this age group received an RSV vaccine. Vaccination uptake was higher among adults 70 and older than among adults 60 to 69, and we do not have data on how adults value the risk of protection against RSV against potential risk of GBS, but this may vary by age or other factors. When asked, do adults 75 and older feel that the desirable effects of RSV vaccination are large relative to the undesirable effects, the work group majority opinion was yes or probably yes, and that there was probably not important uncertainty about or variability in how much this population valued the main outcomes. When asked, do adults 60 to 74 at increased risk feel that desirable effects of RSV vaccination are large relative to the undesirable effects, the work group majority opinion was probably yes, and that there was probably not important uncertainty about or variability in how much this population valued the main outcomes. Now we'll discuss data informing whether RSV vaccine recommendation would be acceptable to key stakeholders and if RSV vaccines will be feasible to implement. These two domains will be covered together as much of the data informing them are cross-cutting. First, we would like to review provider attitudes about shared clinical decision-making as the proposed recommendations move away from shared clinical decision-making. In a survey of general internal medicine physicians regarding pneumococcal and HPV vaccine using shared clinical decision-making, most physicians strongly or somewhat strongly agreed that shared clinical decision-making required more time than routine recommendations. Most respondents also thought that it creates confusion, and just over 40% either strongly or somewhat strongly agreed that shared clinical decision-making was hard to explain to patients, and they did not know how to implement this type of recommendation as CDC intended. While these data are not RSV specific, they can inform our understanding of acceptability for shared clinical decision-making for providers. So are there any feasibility benefits from transitioning away from shared clinical decision-making? CDC and ACIP have heard feedback that RSV shared clinical decision-making has been difficult to implement. Shared clinical decision-making conversations are challenging and time-consuming, especially compared with routine universal recommendations. Shared clinical decision-making also does not have a clear call to action. Next, standing orders, often used by medical assistants, nurses, and pharmacists, are difficult under shared clinical decision-making. Approximately 80% of all older adult RSV vaccinations have been given in pharmacies. While pharmacists are qualified vaccinators, not all providers who give vaccines are comfortable with the shared clinical decision conversation or feel it is within their scope of practice. And lastly, in the specific instance of RSV vaccines, there are also concerns about the ability to complete the type of benefit-risk discussion intended by ACIP. Next, I'll talk about some of the financial and insurance barriers we have seen with RSV vaccine to consider whether any of these barriers may improve with revised recommendations. First, RSV vaccines have a relatively high acquisition cost, and currently the cost is unknown for Moderna's Mrezvia. It is likely a costly upfront investment to carry RSV vaccines, especially in smaller practices. This is one reason providers may be less likely to stock the vaccine and refer patients to pharmacies. RSV vaccines are also billed under Medicare Part D. Part D is described as more challenging to implement than Part B, which is another reason providers may be less likely to carry the vaccine in their practices and instead refer patients to pharmacies. Next, looking at additional complexities regarding RSV feasibility, there are multiple RSV vaccine products licensed, which may cause confusion. These products have different storage and handling requirements. Notably, Moderna's Mrezvia requires frozen storage or refrigerated use within 30 days. And the adult vaccine schedule is complex, including multiple products with differing schedules. Summarizing acceptability and feasibility considerations for a universal recommendation in adults 75 and older. A universal recommendation in this age group might improve feasibility by making vaccination the default and providing a stronger, more decisive recommendation. It also increases ease in generating standing orders and clinical decision support tools. Standing orders may be particularly desirable in this age group to facilitate vaccination in long-term care facilities. Finally, it covers those at highest risk of severe RSV disease without asking providers to complete an extensive individualized risk assessment. However, some considerations that might decrease feasibility and acceptability, the addition of a universal recommendation in only 75 and older might cause confusion. Additionally, these revisions do not decrease the overall complexity of the adult schedule, and in fact, adds another new important age cutoff for a vaccination that is not aligned with another vaccine. Lastly, revising the recommendation when education about the initial recommendation is still ongoing may lead to confusion. Summarizing how a transition to risk-based recommendation in adults 60 to 74 might impact feasibility and acceptability. A risk-based recommendation will provide more clarity to providers and the public about who should get an RSV vaccine compared with shared clinical decision-making. And again, moving away from shared clinical decision-making facilitates simplified standing orders, clinician decision support, and overall messaging. However, even if more feasible than shared clinical decision-making, a risk-based recommendation is still more challenging to implement than a universal recommendation. Providers need education on the indicated risk conditions, and overall recommendation is still complex. Although we have attempted to align proposed risk conditions for RSV as much as possible with other adult vaccines, this recommendation will not align with any other vaccine. And again, revising the recommendation so soon after an initial recommendation may lead to confusion. A majority of the work group felt that recommending RSV vaccines for adults 75 and older would be acceptable to key stakeholders, and that recommending RSV vaccine for adults 60 to 74 at increased risk would or probably would be acceptable to key stakeholders. Overall, the work group felt that the recommendation with protein subunit RSV vaccine among all adults 75 and older would or probably would increase feasibility, and this was also true for Moderna's Mrezvia among adults 75 and older. And moving to those 60 to 74 at increased risk, for protein subunit vaccine, the work group again felt that RSV vaccination would or probably would be feasible to implement, and again, this was also true for Moderna's Mrezvia. Next, we'll review resource use. Because the committee saw Dr. Hutton's cost effectiveness model and Dr. Ortega Sanchez's review of this model and manufacturing models, I will only share work group summary deliberations here. At current list prices, RSV vaccination is likely cost effective for adults 75 and older and adults 60 to 74 with risk factors for severe RSV disease. RSV vaccination is likely not cost effective in adults 60 to 74 without risk factors. Therefore, a universal vaccination in adults 60 to 74 is likely not a reasonable and efficient allocation of societal resources. There remains substantial uncertainty in the key parameters that impact cost effectiveness. And for all three manufacturers, the work group felt that if RSV vaccine list prices were substantially reduced, then RSV vaccination may be cost-effective intervention for a broader adult population. The work group members felt that the vaccination with protein subunit RSV vaccine and Moderna's mRESVIA in all adults 75 and older is or probably is a reasonable and efficient allocation of resources. A small minority of work group members polled varies or don't know. For adults 60 to 74 at increased risk, work group members again felt that vaccination with protein subunit vaccines and Moderna's mRESVIA is or probably is a reasonable and efficient allocation of resources. Now I'll hand to Dr. Amadea Britton to continue the presentation. Thank you.
Thank you, Lauren. I'm now going to be reviewing the final domain, equity. In this domain, all RSV vaccine products are considered together and will be focused on how the proposed policy recommendations might impact equity, and specifically if they might impact equity differently than shared clinical decision-making. We know that RSV disease does not impact everyone equally. We've previously reviewed with the committee that among adults hospitalized with lab-confirmed RSV infection and RSVNet, the median age at hospitalization among Black, Hispanic, and American Indian Alaska Native adults, highlighted here in red boxes, is approximately 10 years younger than the median age among white adults. Now let's look at what this means in terms of absolute risk of hospitalization. In this figure, we are showing the RSVNet RSV-associated hospitalization rates by race and ethnicity for ages 60 to 74 on the left and 75 and older on the right. You can immediately see that for all race and ethnicities, incidence of RSV-associated hospitalization is higher among those 75 and older. However, Black adults had 1.5 times the rate of hospitalization as white adults in the 60 to 74 age range. We've discussed before that this may be, at least in part, due to earlier onset of certain chronic medical conditions that increase risk of disease at younger ages. Now let's look at uptake of RSV vaccine by race and ethnicity to see if RSV vaccination under shared clinical decision-making may be addressing some of these disparities. This figure shows cumulative RSV vaccination coverage by race and ethnicity among Medicare fee-for-service beneficiaries 65 and older with Medicare Part D. In brown at the top, you can see that white non-Hispanic beneficiaries have the highest uptake of RSV vaccine at just over 20%, while Black non-Hispanic beneficiaries have about half that, and Hispanic beneficiaries have only about 6% coverage. Now, looking at RSV vaccine uptake across other sociodemographic categories from data in the National Immunization Survey, you can see that vaccination coverage was significantly lower among adults who live in rural areas, are uninsured, have lower household income, or reported an educational level of high school or less. Overall, RSV vaccine uptake after the first year of RSV vaccine availability has not been equitable across racial ethnic groups or among persons with different sociodemographic characteristics. Now we will consider how a universal recommendation among those 75 and older might impact equity. The practicality and value of issuing a simple and clear message may remove barriers to vaccination. In addition, adults with undiagnosed chronic medical conditions, which may be the result of limited access to care, would be automatically included in the recommendation. However, universal recommendations in and of themselves do not guarantee equity. Even if coverage increases across all groups, disparities between groups may remain. We have seen this with influenza vaccine. Next slide. And how might a risk-based recommendation in adults 60 to 74 impact equity? Again, transitioning away from shared clinical decision-making and clarifying who is at risk, even if a risk-based recommendation is not as simple as a universal one, might remove some barriers to vaccination. A risk-based recommendation might also increase coverage among racial and ethnic minority groups in whom the prevalence of chronic conditions is higher in the 60 to 74 age range. However, adults with undiagnosed chronic medical conditions, disproportionately adults, again, with less access to care, may be deemed ineligible for vaccination, and some of these adults may have obtained RSV vaccination under a shared clinical decision-making recommendation. Overall, workgroup members felt that a recommendation among all adults 75 and older would increase or probably increase health equity, and a recommendation among adults 60 to 74 at increased risk would probably increase equity. That concludes the review of ETR domains, and we will now discuss the summary and proposed votes. Here's the summary of all ETR domains discussed today for the policy question of whether adults aged 75 years and older should receive a dose of RSV vaccine. And now here is the summary of all domains for the policy question of whether adults 60 to 74 at increased risk should receive a dose of RSV vaccine. Summarizing the workgroup's overall motivations for recommending these policy changes today, the workgroup notes that last June's shared clinical decision-making recommendation was made in the setting of uncertainty about both the estimated benefits and potential risks of RSV vaccination. And shared clinical decision-making was intended to facilitate individualized risk-benefit discussions in the setting of this uncertainty. However, we have heard from providers and patients that shared clinical decision-making has implementation drawbacks. We also now have real-world evidence of robust protection against RSV-associated hospitalization during the first season after vaccine availability among adults 60 and older, including among key populations of concern. On the other hand, uncertainty remains regarding the magnitude and potential risk of Guillain-Barré syndrome, and the workgroup believes the GBS signal continues to warrant close attention and additional follow-up. Today's proposed recommendations are intended to maximize RSV vaccination among persons most likely to benefit and minimize RSV vaccinations among persons least likely to benefit. The workgroup also discussed the role of potential preferential recommendations between products, but felt that the strength of the available evidence did not meet the standard for a preferential recommendation at this time. Reasons cited by the workgroup included current safety analyses are interim and based on only a small number of GBS cases. There's also unknown relative duration of protection across products. The need for revaccination and any potential risk of GBS associated with additional doses is also unknown. And lastly, changes based on limited evidence may have unintended and long-lasting programmatic consequences. Considering all domains together for the policy question of RSV vaccination among adults 75 and older, just over half the workgroup felt desirable consequences clearly outweigh undesirable consequences, and just under half felt desirable consequences probably outweigh undesirable consequences. For the policy question of RSV vaccination in adults 60 to 74 years at increased risk, the majority of the workgroup felt desirable consequences probably outweigh undesirable consequences, and a minority felt desirable consequences clearly outweigh undesirable consequences. For both of these policy questions, the workgroup felt there was sufficient information to move forward with the recommendation. And today, the workgroup is recommending both interventions. The following is the proposed vote language. You will note 3 important footnotes. The first, RSV vaccination is recommended as a single lifetime dose. Persons who have already received RSV vaccination are not recommended to receive another dose. Next, these recommendations would supplant the current recommendation that adults 60 years of age and older may receive RSV vaccination using shared clinical decision-making. And lastly, the clinical considerations presentation, CDC will be responsible for providing risk factors, but we'll talk about those in the clinical considerations presentation that's directly following this. Now, we'd like to transition to discussing the use of RSV vaccine among adults aged 50 to 59 years at increased risk of severe RSV disease. Please note, only the use of GSK's Arexvy was considered because to date, only Arexvy has been licensed for this expanded age indication. As you will see, the work group began the ETR process, but did not believe there was sufficient information to complete ETR and move forward with a recommendation at today's meeting. In this section, I will review the work group's deliberations to date and explain the work group's rationale. First, the work group did poll and review evidence on public health problem for adults 50 to 59 at increased risk. We'll start by looking at the total amount of RSV disease among the general population of adults aged 50 to 59. This figure shows the estimated annual number of RSV-associated hospitalizations among adults with ages 50 to 59 highlighted in the red box. The estimated total number is 10,000 to 20,000 a year. Now, let's focus on those adults 50 to 59 with risk conditions. This is the same slide you saw earlier in the older adult public health problem domain. As a reminder, it shows rates of RSV-associated hospitalization by age and presence of chronic medical conditions from RSVNet. In black are rates of hospitalization among adults who have none of the conditions studied in the analysis, and in blue are rates among adults with each of these specific conditions. On the far left in black, you can see that adults 50 to 59 who have none of the selected conditions have low RSV hospitalization rates. However, rates among adults 50 to 59 with certain conditions are comparable to the general rate among adults 75 and older with none of the conditions. When polled, the work group felt that RSV is, or probably is, a disease of public health importance among adults 50 to 59 years at increased risk. Now moving on to benefits and harms among adults 50 to 59. First, we'll look at grade for this age group. Please note again, we are only reviewing data on GSK's Arexvy. The benefits and harms outcomes of interest here were the same as adults 75 and older and 60 to 74. However, there are no clinical efficacy data among adults 50 to 59. Therefore, grade is based on immunobridging data. These data were previously presented to ACIP, so I'm only describing the grade method and benefits harms outcome summary today. First, to assess benefits, we considered whether the immunobridging data suggests the immune response in adults 50 to 59 with risk conditions is comparable to that in adults 60 and older, for whom clinical efficacy estimates exist from GSK's pivotal phase 3 trial. In this table, you can see the immune response among adults 50 to 59 with risk conditions compared to adults 60 and older, measured via geometric mean ratio, or GMR, of neutralizing antibody titers. Non-inferiority criteria were met for both RSV-A and RSV-B antibodies. For grade benefits, we therefore used the phase 3 trial efficacy estimates for each outcome of interest, but downgraded all outcomes for indirectness. Harms outcomes data were taken from the immunobridging trial data directly, as safety was assessed in the immunobridging trial. Now here is the summary of both benefits and harms outcomes. Overall, there was moderate, low, or very low certainty for the outcomes of interest, and recall again that all benefits were downgraded for using immunobridging data as a surrogate for efficacy. Now for additional considerations outside of the immunobridging data. Here are the results again from Dr. Hutton's risk-benefit analysis showing avertable disease per potential GBS per 1 million doses of GSK Arexvy. From a population perspective, the estimated numbers of outpatient visits, hospitalizations, ICU admissions, and in-hospital deaths exceed the range of estimated GBS attributable risk. However, the number of averted deaths may be on the same order of magnitude as the number of attributable cases of GBS. As reviewed for adults 60 and older, there are a number of additional considerations, including the fact that revaccination at 12 months does not appreciably increase efficacy, the optimal timing of revaccination remains unknown, and a lack of data in adults with immune compromise. Taking all this together, just over half the work group felt that the anticipated desirable effects of GSK Arexvy RSV vaccination were moderate. However, just under half polled another way, with the minority saying desirable effects were small. For undesirable anticipated effects, just over half the work group felt undesirable effects would be small, but about 1/3 felt they would be moderate. And when considering whether desirable effects outweigh undesirable effects, half of the work group felt the balance was unclear, and half felt the evidence favored the comparison, which was no vaccination in this age group. After completion of this domain, the work group felt they did not have enough information to complete ETR and concluded there is currently insufficient evidence to make a recommendation regarding RSV vaccination in adults 50 to 59 at today's meeting. So what does this mean? The work group's position today represents an opinion that additional information is needed to determine the best policy for RSV vaccination in adults aged 50 to 59 years. As demonstrated during the public health problem domain, the majority of the work group feels that RSV-associated disease is or probably is a public health problem in this group. So this does not mean the work group feels RSV protection in this age group is unimportant. The opinion is also not a recommendation against the use of RSV vaccine in adults aged 50 to 59. Rather, the work group believes more information is needed to make a population-level policy recommendation. The decision to postpone making a recommendation is primarily driven by uncertainty in the balance of estimated benefits of RSV vaccine and potential risk of GBS, specifically among adults 50 to 59. Among adults 50 to 59, in whom the absolute rates of RSV-associated disease are lower, the balance of risks and benefits is more uncertain than among older age groups. This includes adults 50 to 59 with risk conditions. In addition, because the absolute burden of RSV disease is lower in this age group than in older adults, the work group felt there's less public health urgency to accept a high degree of uncertainty. The work group recognizes that postponing a policy recommendation today may mean some adults aged 50 to 59 who might benefit will not receive RSV vaccine this fall. To that end, the work group will continue active deliberation on the best policy recommendation in this age group as more data become available, and will bring a recommendation for ACIP's consideration as soon as the work group believes there is sufficient evidence. Before making a recommendation for adults 50 to 59, the work group would like to review additional data. Most importantly, the work group would like to review at least one complete season of safety surveillance data that has an active comparator group. Although depending on uncertainty of these findings, additional data may also be needed. The work group has also indicated they would like to review immunobridging data in adults with immune compromise. Clinical trials, including adults with immune compromise, are underway. And finally, the work group would like to see additional data on duration of protection and immune response after revaccination. As previously discussed, the work group notes that to date there is no evidence revaccination will restore protection, and this becomes increasingly important in younger age groups. The work group recognizes equity is an important concern in the use of RSV vaccine in adults aged 50 to 59 years, and they considered equity in their deliberations, including the impact postponing a vote might have on equity. However, after deliberation, they continued to feel uncertainty in risks and benefits did not support a recommendation at this time. The work group is committed to ongoing assessment of RSV vaccination in adults, and this includes adults aged 50 to 59 years and, pending licensure, use of RSV vaccine in adults less than 50 years. The work group will continue to review data as soon as it is available from clinical trials, real-world vaccine effectiveness studies, and safety monitoring. While the timeline of availability of sufficient safety and other data is unknown for a recommendation in adults 50 to 59, the work group will present to ACIP the status of their deliberations as soon as there are updated considerations. The work group believes the policies proposed today incorporate what we have learned to date while acknowledging the best policy may continue to evolve. That concludes ETR, and with that, I'll hand it back to Dr. Melgar to present clinical considerations, after which we will open for questions and discussion.
Thank you, Dr. Britton. Now I'll briefly present to the committee some clinical considerations for use of RSV vaccines in adults 60 and older. We'll cover the implications of transitioning away from current shared clinical decision-making recommendation, defining who is at increased risk among adults 60 to 74 for the risk-based recommendation, the timing of RSV vaccination for those who are recommended, and co-administration of RSV vaccine with other adult vaccines. Under the recommendation framework proposed by the work group, all adults 75 and older, regardless of whether they have one of the listed chronic medical conditions or risk factors, should receive a single dose of RSV vaccination. And all adults 60 to 74 with certain chronic medical conditions or other risk factors for severe RSV disease should receive a single dose of RSV vaccination. These recommendations would replace the shared clinical decision-making recommendation, meaning that adults 60 to 74 without risk factors would no longer be recommended to receive RSV vaccination. Now, we'll discuss who among adults 60 to 74 would be recommended to receive RSV vaccination under a risk-based recommendation. This is the proposed list of chronic medical conditions included in the recommendation. Conditions and risk factors were selected based on evidence of association with increased risk of severe RSV disease or strong rationale that the condition would impact the outcome of a respiratory infection. A balance was sought between providing broad categories that are not overly rigid, but also specific examples in each category so that clinicians have guidance on which patients to prioritize for RSV vaccination. Conditions include lung and cardiovascular disease, moderate or severe immune compromise, and other chronic systemic illnesses. There's also a proposed clause for conditions that a healthcare provider determines would increase risk of a severe respiratory infection, but have not been explicitly listed here. Although the recommendation is not intended to exhaustively denote every possible risk condition, note that less severe stages of diabetes, obesity, and chronic kidney disease are excluded due to inconclusive evidence of association with severe RSV disease, as are mildly immune-compromising conditions, for example, short-course corticosteroid use for less than 2 weeks. And here, we'd like to briefly show the proposed examples of each category. Due to time constraints, we won't linger here, but we can bring the slide back up if desired during discussion. And notably, this list is not finalized, so feedback from the committee will be taken into consideration. Lastly, the list of risk factors in the recommendation would not be limited to chronic medical conditions. Older adults residing in long-term care facilities and those who are frail would be recommended to receive RSV vaccination, as would older adults with other individual factors determined by the clinician to increase the risk of severe respiratory infection. And we'll close this talk with a recap of the recommendations for vaccination timing and co-administration, as discussed at prior ACIP meetings. RSV vaccination will have the most benefit if given in late summer or early fall, just prior to the onset of RSV season. In most of the US, this means from August to October. However, as noted in the voting language, this is not a recommendation for revaccination. Adults who have already received a dose of RSV vaccine do not need to receive another dose this year. Although adults may need additional doses in the future, the optimal timing is not yet known, and as we've seen, there are no clinical trial data to demonstrate restoration of efficacy through revaccination. And finally, in accordance with CDC's general best practices for immunization, co-administration of RSV vaccines with other adult vaccines is acceptable. This includes giving RSV vaccines at the same visit with seasonal flu, COVID-19 vaccines, and other vaccines indicated for adults 60 and older. So with that, this concludes both presentations, and I think here we'll take questions.
Okay, that was a tour de force. Well done, all three of you. I would love to start with questions before we start with discussion. So does anyone have any questions or need things clarified? Dr. Daly, you look like you're posed and ready.
So thanks so much for that presentation. Clarifying question, perhaps Dr. Britton or Dr. Melgar. There was a comment about additional data on GBS for 50 to 59-year-olds, but where is that going to come from, or is it more precise estimates for an older age group from which we will infer safety in a younger age group? Over.
It's the latter. So, you know, without the vaccine is now licensed for those 50 to 59, but the data that we're looking for is going to be coming from additional doses in 60 and older, and then inferring. And I'm not sure if this entirely came through from the FDA presentation, but there are a lot of doses that were administered that they just haven't been able to sort of evaluate yet because they cut off, their analysis in October. They also are planning to do chart review, and they're also expanding to more sort of Medicaid beneficiaries or Medicare, a larger population. So overall, they expect to have more data from 60 and older.
Any other questions? All right. I know it was super clear. It was amazing. All right. I would love to hear a discussion about thoughts of the current recommendations and if anyone has any thoughts on a motion. You don't have to do a motion right now. Denise.
Oh, thank you. I had some concerns about the recommendation that the recommendation to replace the shared decision-making, meaning that adults ages 60 to 74 without risk factors would no longer be recommended. I think it's really hard to decrease access to a vaccine that we think is safe and effective, and I worry about what that means. It would be nice to say it's recommended for those with risk factors, and those without risk factors may still receive the vaccine.
Does someone from the work group want to discuss why it was risk factor based?
I think we spent a long time deliberating this, and overall, it seems like people without risk factors have a lot less potential benefit. So I think what you're talking about might be people with, zero risk factors who have no comorbidities, perfectly healthy, may not benefit, but there are people that might not be included in the clinical considerations, and I also have some concerns on that. There was nice phrasing with the COVID-19 vaccination that we might want to consider here. It was sort of on a case-by-case basis, providers caring for these patients can administer, it was specifically about additional doses of vaccine, but based on clinical judgment, where the benefits of vaccination outweigh the potential risks. That was specifically for immunocompromised. There might be very rare situations, but in general, we really don't want to make a recommendation where people who just want to get the vaccine go get the vaccine, because we don't actually feel that that is recommended for a lot of different reasons.
To tag on to what Dr. Cotton said, and then I'll go to Dr. Melgar real quick, I think the group also felt like there was an unknown risk of Guillain-Barré syndrome, and so they were really looking at risk-benefit, and until that risk is known, that ratio is harder to determine in those with no risk factors. Dr. Melgar?
So we do have a backup slide that attempts to make the same benefit risk comparison, specifically among adults 60 to 74 who don't have either of any of the 6 common medical conditions that were evaluated. And that's slide 179. I don't know if it's possible to bring that up. Oh, it is different number, maybe 178.
You know what?
Yeah. Thank you. So this is analogous to some of the slides that were shown during the evidence to recommendations presentation, but specifically among adults 60 to 74 who do not have any of the 6 common chronic medical conditions. And again, balancing the benefits of RSV vaccination in terms of prevented hospitalizations, ICU admissions, and deaths over 2 RSV seasons, compared with the same attributable risk of Guillain-Barré syndrome as estimated by the FDA CMS analysis. And I guess similar to the comparison that was made for adults 50 to 59 with chronic medical conditions, the balance of benefits and harms is much less clear than it is for adults 60 to 74. And this was part of the rationale for the work group's deliberations and considerations, culminating in a recommendation to move to risk-based and omit persons without certain risk factors from the recommendation. Thanks.
Dr. Long?
Remind us, Dr. Melgar, I don't think that we're going to make a recommendation against giving vaccine to those 60 to 74. Wasn't that just making sure that everybody understood that we were removing a shared clinical decision against that? And we also added a lot of leeway of other conditions that the physician or provider felt might increase the risk. And those could be broadly interpreted. but we were really trying to protect the worried well until we knew about Guillain-Barré. And also, the cost effectiveness in this age group is beyond the pale.
Dr. Jameson.
So just to be clear, if I'm 62, currently I can get the vaccine with shared decision making, and if these recommendations are voted on and passed, I would not be able to access the vaccine. I think that's a big deal with a safe and effective vaccine. It would be much different if we were starting from ground zero and 62-year-olds were not eligible for the vaccine. Now they are today, they won't be tomorrow. And I think that sends a powerful message about what we believe about the safety and effectiveness of the vaccine.
Dr. Cotton, you have a comment in response to that?
Yeah, it's that we think that with a risk-based approach, you are much more likely to get the vaccine than you are right now. If you're 62 right now under shared clinical decision-making, which basically is confusing to providers, I can say in my own institution, people find it befuddling. Many clinicians and patients, due to vaccine fatigue, have kind of thrown up their hands. What we're trying to do is make it more likely that people will get the vaccine when they need it. And we think that this will allow for much better vaccine distribution. We really think it'll enhance equity as well, because certainly not everyone has access to doing shared clinical decision-making with a provider. And so we're hoping that clarity on the risk will be helpful, so that we're hoping that 62-year-old would be more likely to get vaccine in this current situation.
Dr. Laird.
I actually am 62 years old. I have not gotten the vaccine, and I am comfortable not getting the vaccine because I do not have any of these risk factors. And I understand your concerns, Dr. Jameson, that this is a significant change. I am comfortable with that change. I think it's good for the ACIP to make new recommendations based on new information, which we have. And so I respectfully would disagree and would say this is an appropriate step forward. Thank you.
Dr. Brooks?
Yeah, not wanting to beat a dead horse, but I think this is one of those where it's close. I don't have risk factors, and I did get vaccinated. I'm glad I did prior to our vote, which may go in favor of this. But I think this is a really important slide. You have it as a backup slide, but this, maybe we didn't anticipate the discussion regarding this, but this is important. I mean, this is also over 2 seasons, not 1 season. So you got, 500, only 400 to 500 hospitalizations in that age group over 2 seasons. The only caveat I would say is something someone else said. There may be those 60 to 74 with unknown, undiagnosed chronic conditions that got vaccinated, that were protected. They didn't even know they had, let's say, diabetes, because no one ever checked their A1C. But on balance, I have to agree with Dr. Lair and say that it's close, but you shouldn't vaccinate people who really don't need the vaccine. And it is going backward, but I think it makes a statement that sometimes we change our minds. Based on data.
I'm assuming, Dr. Cotton, you have a response to that. Do you? Dr. Shaw, can you wait? Okay, so I was going to say, Dr. Brooks, one quick question before Dr. Cotton makes her comment. You're okay not getting your RSV vaccine this year?
I already got it.
Oh yeah, you got your first dose, so you're not eligible. Okay, sorry, Dr. Cotton.
I think I'd like to emphasize from the work group perspective that everything that we're talking about now is sort of as it is June 2024, and things are evolving, and we have had many, many hours of meetings, deliberation. We're waiting on data from the FDA. This is a week-by-week, month-by-month rollout, and we will revise recommendations when we have additional information. Right now, we do worry about safety. We have some concerns, not major concerns, but nonetheless, we don't feel that it's ready for a large-scale recommendation. And then, honestly, the cost is significant. This is, if you go out of pocket, it is pretty much $400. And that is, I know it's, quote, free under the Inflation Reduction Act, but let's just say nothing is free. we are paying for that. And so this is quite a major recommendation, potentially with a huge number of people affected. But we do hope to evolve our response over time.
Dr. Shaw.
Thanks. That was an incredible presentation. Since a lot of people get, I think, vaccinated at pharmacies, I was wondering, some of these medical conditions are quite specific. You know, stage 4 chronic kidney disease is based on creatinine clearance, or diabetes with end organ damage is a little bit more. How equipped do we think, you know, pharmacists are to kind of screen for that kind of stuff?
I think that's an issue with our payment system for adult vaccines. So we need a VFA, vaccines for adults. You know, I say this every meeting, and I'll probably say it 3 times more, but it is time, vaccines for adults. And it is time for so vaccines also can be given in the physician office where they actually know medical issues. So that's huge, but you are correct, it's hard to tell in a pharmacy where they do get their vaccine. Dr. Daly.
Yeah, so I want to make a couple big picture comments. First, I just want to thank the work group leads, you know, the extent to which you tackled the hard issues. You know, I really, really appreciate that. And so thank you so much. I mean, it was a dazzling presentation, but there's all that work behind that we want to thank you for. So the second is an observation that I've had over time, that our vaccine recommendations settle over time. It takes us a little while to get there. And that's hard, because if we make a different decision today than we made a year ago, the whole immunization delivery system in the country needs to change to accommodate that. But I think that's okay, because that's in the setting of some uncertainty. So Dr. Jameson, I have the same concern that you do, but I reflect on the fact that it takes a couple years for the recommendations to settle. It is hard to now say, yesterday you were recommended, today you're not. But I think that's a little bit the nature of the uncertainty when we're facing that decision. So I personally, I'm supportive of a universal recommendation over age 75. I'm supportive of a risk-based recommendation 60 to 74. While we all need to recognize that's going to be hard too. And we're going to get feedback that that's hard. And a year ago, I voted for shared clinical decision-making, and I did so for a couple reasons. One was a numeric imbalance of Guillain-Barré syndrome in clinical trials, an uncertainty about the duration of protection. And then after that, I heard about how hard it was to implement shared clinical decision-making. And as you guys know, I practice in Kaiser, and we have sophisticated electronic medical record. And so we have a lot of levers that we can push, which is provider prompts, patient prompts, standing orders. Those work for a should recommendation. They really don't work for a may recommendation. They just, for a whole variety of reasons that we don't need to go into, because you summarized it so well. So, but I still don't think that was quote unquote a bad decision or a wrong decision. I just think, given the uncertainty that we had, that was the decision that we made a year ago. It takes a little while to settle. And so I'm in support of the decisions that the work group has come to the table with, the policy decisions, because we have more certainty, including some real world effectiveness data that I can use as we get more safety data. So again, it's okay that it takes a little time for these recommendations to settle, even though it's hard for the system. And I think you brought the data to us for me to feel comfortable making a decision today on the policy decisions. Over.
Dr. Jameson.
That was well said, thank you. I agree with you, Dr. Daly, that these decisions will take a while to sort of fully form, and we're still waiting for a lot of data. And so that's why the way I was thinking about it, and again, the work group has thought about this a lot more deeply, was that why not make, for that reason, because we're going to have more data in the future, why not make an incremental recommendation rather than saying if you're 62 you can get it today and you can't get it tomorrow, saying that if you have a risk factor you should get it, if you don't have a risk factor you may get it, and with shared clinical decision-making, it may be that your physician says, you don't need it, you don't have a risk factor, but not cutting off that access, because I'm worried about what that message sends by cutting off access to somebody who's 62. But again, I agree that, we'll have more data in the future, and maybe this is a reasonable next step.
We have a couple questions online that I'd like to get to, but I do want to say something, Dr. Jameson. The vaccine is licensed, so if you're 62 years of age, you can get the vaccine. You will pay out of pocket. And what we saw this year is the 62-year-olds who got the vaccine were well-educated, insured. They were a different population than what would not get it if they could. I'm going to let Dr. Goldman talk since he had his hand up for so long.
Thank you so much. I really appreciate the presentation. It's very thorough, and I wanted to bring the perspective of general internal medicine and solo private practice. I vaccinate extensively and have been giving the RSV vaccine out to the patients appropriately since the beginning. My concern, I share with Dr. Jameson as well, that we're going to be sending the wrong message, not only to the patients, but also to physicians who want to be vaccinating their patients, because it gets confusing. When you go from shared clinical to risk-based to we're not going to recommend at all for this group, I think it sends the wrong message and is going to create a lot of confusion and implementation. The idea of an incremental recommendation is a good one because it still gives that little escape valve for those patients who want it to be able to get it and get it covered. There may be very well-educated patients who want it but can't afford it. And again, we do need a vaccine for adults program. I'll plug that as well. But I do think it's important that while we have the risk base and get away from shared clinical decision-making, we should not now take it away from the 60 to 64-year-olds who may still need it, not know they have problems, not know they're at risk, but would benefit from the vaccine. So from my perspective, I think if we pass it as is, it's going to create a lot of implementation issues and confusion for patients as well as practicing physicians. Over.
Thank you. Dr. Acker.
Thank you. This is Emily Acker on behalf of BIO. We're concerned that not bringing an FDA-approved vaccine through to a vote sends a bad precedent and creates equity issues, as we've all been talking about for vaccine access. As you know, insurers are unlikely to cover the cost of a vaccination without an ACIP recommendation, and without insurance coverage, adults who do choose to be vaccinated must pay out of pocket. I think the data that we've seen today shows that the vaccines are effective in the real world, and the cost effectiveness analyses are on par with other vaccines that are approved and recommended in the US. So we feel that the lack of a vote is a missed opportunity based on the evidence we've seen, and sets a poor precedent and equity considerations moving forward.
Thank you, Dr. Zahn.
Yeah, thank you, Dr. Talbot, and thank you for all the great presentations. I apologize if I've missed this, but for the 60 to 74-year-olds who are chronic risk, what proportion of that age group would qualify to have a chronic medical condition?
Can you bring up slide 161?
They are prepared for you today. Hang on.
And the only reason I ask is it feels like, and maybe I'm remembering this wrong, it feels like a COVID conversation that we had where there was initially recommendations for an at-risk population. Sorry.
Sorry, 161? Not 61.
Oh.
Yeah, they're trying to find the slide.
Advance one more. So this is using NHANES data, and we basically asked them to use the conditions that we would, to the best of their ability, that we would include in this recommendation. So one thing to note about this is that many studies that look at population prevalence of comorbidities include hypertension, which is not a risk factor that's associated with RSV, severe RSV disease. So this specifically removes that. And so this is looking at the prevalence in each age group based on sort of a narrow definition and a broader definition that would be covered under a risk-based recommendation. If you have any questions about this, please let me know.
Dr. Zahn, does that answer your question?
It does. I mean, just a comment that it's just worth noting whether a very large proportion of the population, fits in being at risk. It kind of makes sense to make a more universal recommendation, but that helps. Thank you very much.
All right, Dr. Freihofer.
Sandra Freihofer, representing the AMA, but speaking as a practicing physician, and I echo the concerns of Dr. Goldman. And Dr. Cotton's comment about how we handled COVID vaccine really resonates with me. We gave an option or a little wiggle room to the physicians that care for these patients, who know these patients the best. And I would really encourage the ACIP voting members to consider for those patients aged 60 to 74 who don't have a specific risk factor to be allowed to give this vaccine with that little wiggle room. I greatly appreciate the clarification today of the risk factors that for severe RSV disease. That has been very helpful. And I also appreciate the clarification that hypertension is not a risk factor for severe RSV disease, but would clearly support, in my opinion, keeping that shared clinical decision-making for those 60 to 74 who don't have a risk factor. Thank you.
Thank you. Would y'all mind, Dr. Lair, I promise I'm coming to you. Would y'all mind putting up the proposed language for the vote as Dr. Lair asks his question?
So I have a comment and then I'd like to make a motion. I commend the work group. I've heard about 3-hour meetings getting prepared for this ACIP meeting. I've heard about 178 slides and backup slides of over 100. The amount of work that went into this is extraordinary and very clear, and I appreciate all the hard work that went into it. I agree with your recommendations, and so I'm going to make a motion in a second to go forward. I would ask the work group in the next months to year to look more closely at the risk groups in the 50s. I think that some risk groups in the 50s do have significant risks and do have significant benefits. You have that slide where chronic kidney disease has a 6 times higher risk. There's transplant patients who have significantly higher risks, and that might be hard to parse out. But I do worry about people who are at high risk who might not be getting it at this current time. I'm sure you'll be doing that, but I just want to give my encouragement to do that. I also want to thank you for the clinical considerations as a practicing physician, having that, I think it's slide 110 in my office that I can show to people that these are the people who are at the highest risk is very helpful to me. So thank you for making my life easier. Having said all that, I'd like to make the motion.
Yeah, we need to go back to the slide with the motion. And Dr. Lair, we will need 2 motions because it is 2 votes. Okay. So we'll start with 1 motion at a time.
So I move that we accept the language of number 1. ACIP recommends adults 75 years of age and older receive a single dose of RSV vaccine.
Do we have a second?
Be approved.
Thank you, Dr. Long. All right.
Then motion number 2, I move that ACIP recommends adults 60 to 74 years of age who are at increased risk of severe RSV disease as defined below receive a single dose of RSV vaccine be approved.
A point of order. I'm not seconding. You can only address 1 motion at a time.
Yes.
So, Jamie, you might want to hold off on number 2 for now.
I think we can put 2 up for discussion.
1 was put up and and seconded. Are you wanting to change?
No, I think that we should just deal with the first motion first.
Robert's rules, I
Robert's
think you
rules would say you can't have
discuss
two motions at the same time.
after there is a second.
I thought we were done discussing. My apologies. Anyone would like to discuss the first motion? Dr. Longwell. Good call, Dr. Brooks.
Just, can you put that slide back up, Amadea, that you had? Is that hard to do?
Yeah, it's 161.
Oh, if it's hard to do, it's okay. So let the record show I belong to that greater than 75 age group and did get my vaccine last year. And after we began to look at the data in the more data that became available, I was not sure that I needed to have gotten that vaccine and taken that risk of Guillain-Barré syndrome, even in that age group. And the preponderance of evidence was that everybody 75 and older, because there is a dramatic increase in those without underlying conditions at that age. We did know and we did discuss at length, and we had practitioners that very much did not want a risk-based recommendation. We know that it's difficult, so we knew all of that. And we thought with the data that we have, three things really. The first was this going to be boostable when you got into those age groups that were more at risk and when you did develop a condition? Or would we be immunizing people at 60 who then would not be boostable? So we don't have these data about the boostability, about the decay of that second dose whenever it would be recommended. So that was the first thing. The second was the tremendous cost and the very few, much reduced hospitalizations. And obviously the concern over the safety, were we really, was it really good for us to, I think also put a little bit at jeopardy the trust in the system. We know you're not at extreme risk at the age of 60 if you have no underlying conditions. We don't know for sure what the risk of Guillain-Barré will be, but we believe there is a risk, and we don't know exactly what that was. So that really, those things contributed to our recommendation.
Thank you. Any other comments, statements, discussion? Dr. Schechter.
Just a couple of comments about the path ahead and the months after the vote. Two aspects about age I'd be interested in more data about. One is if the risk of Guillain-Barré changes between 60 and 80 plus, and whether those static estimates for both vaccines are applicable at all the age groups, along with the data that's being collected at 50 to 59. And then looking at this last presentation, wonderful presentation with the hospitalization by age group, I'm just wondering if we'll have additional data about whether increased risk really does start at 75, or whether there's any earlier increase to that risk. Thank you.
Very good points. Anyone else? Okay, Dr. Laird, would you like to do motion 2? Unless someone's going to. Okay, go for it.
I'm happy to do motion 2. I move that we accept motion 2 as written. ACIP recommends adults 60 to 74 years of age who are at increased risk of severe RSV disease, as defined by the CDC extra information, receive a single dose of RSV vaccine. I recommend that be approved.
I second that motion.
Thank you, Dr. Cotton. Discussion. Yes, Dr. Daly.
So I'm in support of this, but I want to know what comes next, kind of a little bit to your point, Dr. Schechter, and sort of we know implementing risk-based strategies are also difficult for perhaps different reasons. And I think, Dr. Leary, you've already said sort of when we have a risk-based recommendation, we grab that, put that up, thumbtack it to our office, and I do think that's helpful, but there still is a lot of communication. There's a socialization there. And then I think we may need, to your point, Dr. Jamieson, we then may need some language that addresses patients who say, I have no risk factors, but I want to get vaccine. So it's hard to know how to address that in the clinical considerations, to be honest. But I feel like sort of full transparency, how do we communicate that? Thank you.
I'd like to make one comment before we all go to lunch, unless someone else has a comment. It is okay for us to reevaluate vaccines and use them as they are needed. We're one of the few countries that does not do that. Great Britain is very good at saying, do we really need 4 doses of pneumococcus in our kids? Do we really need that many doses of HPV? And so I think that only lends us credibility in saying we have reviewed this. This is the right use of medical funds. This is the right way to save lives. This is the right way to reduce risk of vaccines. And we should be comfortable having those conversations. Yes, messaging is hard, but I really think it's time for us to be okay with not doing what we've done for 40 years. And that will take a while for us to get used to. As you say, settle in. Okay. Any other comments, discussion? Dr. Lair, he's not hungry apparently.
I think the section that says other chronic medical conditions that a healthcare provider determines increases risk of severe disease is a flexible point that could be used by many practitioners. Yeah. Thank you.
Yeah. We tried to make that permissive clause quite permissive. So we also have under other risk factors, so it doesn't even really have to meet the definition of a chronic medical condition. So that will be like part of CDC's communication materials. But if you're somebody where a physician can find literally nothing that they think increases your risk of severe respiratory disease, then you wouldn't meet the permissive criteria.
Dr. Sineas.
I was going to make that exact comment that I think that clause is essentially shared clinical decision-making. So it allows for that flexibility for somebody who wants it and has that discussion with their doctor about what their increased risk might be.
Just as a matter of reference, we rarely give colonoscopies to 30-year-olds unless there's a reason. So on that note, we will take a break, and we will be back exactly at 1:50, and we'll start our next session then. Thanks, everyone. All right, welcome back, everyone. All right, welcome back, everyone. We'll be moving on to the combined diphtheria and tetanus toxoid and acellular pertussis, inactivated poliovirus, Haemophilus influenza type B conjugate, and hepatitis B vaccine, otherwise known as Vaxilis. Dr. Lair will start us off.
Thank you. Although we don't usually use brand names, I will use Vaxilis as shorthand instead of saying everything that Dr. Talbot just said. This session is focusing on an additional recommendation for Vaxilis. Next slide. This is the meningitis and Hib vaccines work group. I'd like to thank Dr. Chen, who's also on the work group. You can see the ex officio members, the liaisons, and the CDC contributors. I'd especially like to thank Dr. Collins for walking us through this process. Next slide. For background, it's fairly clear that there is a benefit to PEDVAX-Hib, which is a Hib vaccine PRP-OMP, and it's preferentially recommended for American Indian and Alaska Native infants. Historically, Hib meningitis has peaked at an earlier age among AI-AN infants, and this PEDVAX-Hib vaccine provides a protective antibody response after the first dose and is more protective for these infants. However, Vaxilis, which uses this component of Hib, does not currently have a preferential recommendation for the AI-AN infants because it contains PRP-OMP in a lower amount than PEDVAX-Hib, and we didn't have any post-dose 1 immunogenicity data which were previously available. So next slide. So the policy question is, should Vaxilis be included with PEDVAX-Hib in the preferential recommendations for American Indian and Alaska Native infants based on the Hib component? And spoiler alert, my regrets to Dr. Collins, the work group is recommending the intervention. I just stole your thunder. Next slide. In the past, we have already presented the epidemiology of invasive Hib disease in the AI-AN populations and the evidence supporting the existing preferential recommendation. We now have clinical trial data on the post-1 immunogenicity of Vaxilis and PEDVAX-Hib, showing that Vaxilis is non-inferior, and we gave you the preliminary work group considerations in the past. So next slide. Today's agenda is the evidence to recommendations and the proposed recommendations for the use of Vaxilis among AI-AN infants. And then there'll be also an updated Vaccines for Children resolution from Dr. Jean Santoli. I think that's the final slide, and we can move on to Dr. Collins.
Good afternoon. As a reminder, Haemophilus influenzae type B, Hib, polysaccharide conjugate vaccines remain the primary prevention strategy for Hib disease. These vaccines consist of Hib capsular polysaccharide, abbreviated PRP, conjugated to carrier proteins, either tetanus toxoid, abbreviated PRPT, or outer membrane protein of meningococcal serogroup B, abbreviated PRP-OMP. They are highly immunogenic via activation of T-cell-dependent immunity. 95% of infants develop protective antibody levels after a primary series. The estimated clinical efficacy is 95 to 100%, and invasive Hib disease is uncommon in children who are fully vaccinated. Current Hib vaccines licensed and available in the United States are shown here. They include 3 monovalent vaccines and 2 combination vaccines. Regarding the combination vaccines, the Hib component of Pentacell is PRP-T, and the Hib component of Vaxilis is PRP-OMP. PEDVAX-Hib is preferentially recommended for American Indian and Alaska Native infants. The ACIP recommendations shown on this slide predate the licensure of Vaxelis and note that vaccination with a 2-dose primary series of a Hib vaccine that contains PRP-OMP, that is PEDVAX-Hib, is preferred for American Indian and Alaska Native infants to provide early protection because these vaccines produce a protective antibody response after the first dose. A booster dose, dose 3 in this case, of Hib vaccine is recommended at age 12 through 15 months. For the booster dose, there is no preferred vaccine formulation for American Indian or Alaska Native infants. Vaxelis does not currently have a preferential recommendation for American Indian or Alaska Native infants because post-dose 1 immunogenicity data were not previously available and is not equivalent to PEDVAX-Hib because it contains a lower dose of both PRP and OMP as shown in the table. As noted by Dr. Lehr, the policy question is, should Vaxelis be included with PEDVAX-Hib in the preferential recommendation for American Indian and Alaska Native infants based on the Hib component? For the first ETR domain of public health problem, the work group considered the question, is invasive Hib disease among American Indian and Alaska Native infants a problem of public health importance? Work group members noted that, before the introduction of effective vaccines, Hib was the leading cause of bacterial meningitis and other invasive bacterial disease in the United States, primarily among children aged less than 5 years. The most common clinical syndromes of invasive Hib disease in the post-vaccine era are bacteremic pneumonia, bacteremia without a focus, and meningitis. Work group members also noted that the incidence of invasive Hib disease among children aged less than 5 years declined more than 99% with introduction of Hib vaccines, as shown in the top graph. However, American Indian and Alaska Native children aged less than 5 years have a 31-fold higher incidence of invasive Hib disease compared with non-Native children, as shown on the bottom graph. For this slide and other workgroup determination slides, darker blue shading corresponds with a more common workgroup response, and majority opinions are represented by the orange rectangles. The workgroup interpretation for public health problem was yes. Now to benefits and harms. This table shows the PICO components. The population is American Indian and Alaska Native infants. The intervention is Vaxelis. The comparison is PEDVAX-Hib, and the outcomes selected by the workgroup were invasive Hib disease, post-dose 1 immunity, post-primary series immunity, and serious adverse events. Overall, 2,332 records were identified and screened, and 1 study was included in the grade review of the evidence. This table shows the workgroup determinations regarding the importance of each PICO outcome and whether it was included in the evidence profile. Invasive Hib disease, an important outcome, was not included in the profile due to a lack of evidence. The other 3 outcomes were included in the evidence profile. Post-dose 1 immunity, which was critical, post-primary series immunity, which was important, and serious adverse events, which was a critical outcome. The available evidence on immunity and serious adverse events were assessed using data from 1 phase 4 prospective open-label randomized controlled clinical trial. The trial enrolled healthy infants born at gestational age at least 35 weeks, aged 42 through 90 days at the time of first vaccination, and identified as American Indian or Alaska Native by the parent or legally authorized representative. Infants were randomized to receive Vaxelis or PEDVAX-Hib. According to the routine childhood immunization schedule, Vaxelis was administered at ages 2, 4, and 6 months, and PEDVAX-Hib was administered at ages 2 and 4 months. The trial compared antibody levels before vaccination versus day 30, 120, and 150 post-dose 1. Safety monitoring for serious adverse events was performed on day 0, 30, 60, 120, and 150. For post-dose 1 immunity, the anti-Hib IgG geometric mean concentration, or GMC ratio, of Vaxelis to PEDVAX-Hib 30 days post-dose 1 met the pre-specified non-inferiority criterion. The proportion of infants with anti-Hib concentration above the putative correlate of short-term protection, 30 days post-dose 1, was similar between groups, 75.7% for the Vaxelis group and 71.2% for the PVAX-Hib group. The latter outcome was used for the grade evidence profile. The grade evidence profile for post-dose 1 immunity is shown here. The evidence certainty began as high because the study design was a randomized control trial. The workgroup downgraded for serious imprecision because of the wide absolute confidence interval, and the final evidence certainty was moderate. For post-primary series immunity, the proportion of infants with anti-Hib concentration above the putative correlate of long-term protection, 150 days post-dose 1, was higher in the Vaxelis group, 83.6%, than in the PVAX-Hib group, 71.7%, with a p-value less than 0.05. Antibody titers were not collected beyond day 150 post-dose 1. The grade evidence profile for post-primary series immunity is shown here. The evidence certainty again began as high. The work group downgraded for serious imprecision because of the wide absolute confidence interval, and the final evidence certainty was moderate. General safety data on Vaxelis, which were also presented in February, are shown here. In pre-licensure clinical trials, the safety profile of Vaxelis was consistent with that of licensed comparator vaccines, except for a higher rate of fever than with Pentacel. However, rates of fever-related medical events were similar between groups. A post-licensure analysis of data from the Vaccine Adverse Event Reporting System, VAERS, from June 2019 through June 2023 did not identify new or unexpected safety issues. For the grade assessment, the workgroup considered data on serious adverse events among American Indian and Alaska Native infants enrolled in the HIVVAX study. The frequency of serious adverse events was similar between groups, 5% for the Vaxelis group and 7% for the PVAX-Hib group. The most common serious adverse event was acute respiratory infection, and no serious adverse events were deemed related to study participation. The grade evidence profile for serious adverse events is shown here. Again, the evidence certainty began as high. The workgroup downgraded for serious imprecision, again because of a wide absolute confidence interval. The final certainty was moderate. This table shows a summary of the grade assessment just presented. No data were available on invasive Hib disease. For the other three outcomes, data were available from one randomized control trial. For the critical outcomes of post-dose 1 immunity and serious adverse events, the Vaxelis and PVAX-Hib groups were similar. For the important outcome of post-primary series immunity, the Vaxelis group had a more favorable antibody response. The final grade evidence type was moderate. For the question, how substantial are the desirable anticipated effects overall and for each main outcome for which there is a desirable effect, the workgroup determination was moderate. For the question, how substantial are the undesirable effects overall and for each main outcome for which there is an undesirable effect, the workgroup determination was minimal. Regarding whether the desirable effects outweigh the undesirable effects, the workgroup determination was that it favors both Vaxelis and PVAX-Hib. The overall certainty of evidence for the critical outcomes was moderate. Now to values. For the values domain, limited data were available. Workgroup members noted that Vaxelis would provide an additional option for American Indian and Alaska Native infants. In collaboration with CDC's Office of Tribal Affairs and Strategic Alliances, the National Center for Immunization and Respiratory Diseases held a listening session with tribal communities in January of 2024. Among 80 attendees, only 9 were from tribes or tribal serving organizations, and 46 were from Indian Health Service. Key questions and concerns raised by participants for workgroup consideration were, will Vaxelis offer the same protection as PVAX-Hib? The need to monitor for possible breakthrough cases, and the importance of considering data on safety and side effects. The workgroup has incorporated these considerations into the evidence to recommendations framework. For the question, does the target population feel the desirable effects are large relative to the undesirable effects? The workgroup determination was probably yes or yes. For the question, is there important uncertainty about or variability in how patients value the outcomes? The workgroup did not achieve a majority consensus, with the plurality favoring probably no and others favoring don't know or probably yes. Now to acceptability. For this domain, limited data were available. Workgroup members noted that Vexelis would reduce the number of injections to complete the childhood immunization series for those who receive it, and may therefore improve acceptability for parents, guardians, and medical providers. Workgroup members also noted that CDC's General Best Practice Guidance for Immunization and the American Academy of Pediatrics Red Book both state a general preference for combination vaccines over separate injections of equivalent component vaccines. Finally, the proposed policy option to add Vexelis retains flexibility for providers to continue using PFAX-HIB if desired. The General Best Practice Guidance for Immunization regarding combination vaccines is shown here. Potential advantages include improved vaccine coverage rates, timely catch-up immunizations, reduced shipping and stocking costs, reduced costs for extra healthcare visits necessitated by deferral of vaccination, and facilitation of additional new vaccines into vaccination programs. Potential disadvantages include adverse events that might occur more frequently with combination vaccines than with individual components, confusion and uncertainty about selection of vaccine combinations and schedules for subsequent doses, and extra doses of certain antigens in the combination product. For the question, is the intervention acceptable to key stakeholders, the workgroup determination was probably yes. Now to resource use. As a reminder, Vexelis protects against 6 infections with fewer injections. This table shows 3 options for how either Vexelis or PFAX-HIB can be used with other vaccines to complete the routine childhood immunization series for the 6 infections covered by Vexelis. Note this is not all immunizations in the childhood series. Option 1 uses Vexelis for the primary series for a total of 5 injections. Option 2 uses PFAX-HIB and the combination vaccine Pediarix, which protects against diphtheria, tetanus, pertussis, polio, and hepatitis B for a total of 7 injections. Option 3 uses the individual component vaccines for a total of 12 injections. We will consider the cost of these 3 options in the coming slides. For each of the vaccines listed on the previous slide, the Pediatric Vaccines for Children's Program price list is shown here with public and private sector cost per dose. The estimated costs of each of the 3 options are shown here. The columns correspond to the number of doses of each vaccine to complete the childhood series using that option, total CDC cost for vaccines only, total CDC cost for vaccines plus administration, total private sector cost for vaccines only, and total private sector cost for vaccines plus administration. Cost ranges reflect different costs for the DTaP and hepatitis B vaccine options. And as specified in the footnote, assumptions were made to estimate vaccine administration costs based on the available literature. As highlighted here, vaccine-only costs are higher for option 1, that is, using Vexelis. However, total costs are similar, accounting for administration costs. In summary, the workgroup noted cost is similar for Vexelis and other vaccine options that cover the same pathogens, accounting for administration costs. Workgroup members also noted that resource use of Vexelis has been acceptable for the general U.S. population, and that it would be equitable to use the same standard for American Indian and Alaska Native children. Regarding, is Vexelis among American Indian and Alaska Native infants a reasonable and efficient allocation of resources? The workgroup determination was yes. Now to equity. For the equity domain, limited data were available. work group members noted that the option to use a combination vaccine may improve equity by improving reliability of the vaccine supply and improving Hib vaccination uptake among American Indian and Alaska Native populations, who are disproportionately at risk for invasive Hib disease. Regarding what would be the impact of using Vaxelis among American Indian and Alaska Native infants on health equity, the work group determination was moderate. Now to feasibility. Regarding feasibility, work group members noted that Vaxelis has been widely used in the general U.S. population, with more than 7.4 million doses distributed in the United States as of Q1 of 2024. Adding Vaxelis to the preferential recommendation for American Indian and Alaska Native infants would increase flexibility for patients and providers and reduce the number of injections to complete the childhood immunization series for those who receive it. Neither Vaxelis nor Pdvax-Hib require reconstitution, and the shelf life of Vaxelis, 4 years, is longer than that of Pdvax-Hib, 3 years. Workgroup members also noted Vaxelis cannot be used for the booster dose, and that clinics will need to stock additional products for the booster dose. Stocking Pdvax-Hib for the Hib booster dose would maintain parent, guardian, and provider flexibility to choose this for doses 1 through 3. Stocking a tetanus toxoid conjugate Hib vaccine, PRPT, is also an option. A Vaxelis primary series with a heterologous booster, PRPT, was shown to produce a robust immune response in a small study. However, this option has a risk of inadvertent administration of PRPT for doses 1 through 3, with a less robust immune response following doses 1 and 2 compared with PRP-OMP vaccines. Regarding whether using Vaxelis among American Indian and Alaska Native infants is feasible to implement, the workgroup determination was yes. A summary of the workgroup determinations for each of the ETR domains is shown here. Overall, the workgroup determinations were favorable, as indicated by the orange shading. For the balance of consequences, the majority of workgroup members think desirable consequences probably outweigh undesirable consequences in most settings, with the remainder thinking they clearly do. The workgroup agreed there was sufficient information to move forward with a recommendation. Regarding the PICO question, should Vaxelis be included with Pdvax-Hib in the preferential recommendation for American Indian and Alaska Native infants based on the Hib component, the majority of workgroup members favored recommending the intervention. The draft proposal language from the workgroup is: ACIP recommends DTaP, IPV, Hib, Hep B, Vaxelis should be included with PRP-OMP, Pdvax-Hib, in the preferential recommendation for American Indian and Alaska Native infants based on the Haemophilus influenzae type B Hib component. I would like to acknowledge the workgroup members and others listed here who made this presentation possible. Thank you, and I'm happy to take any questions.
Any voting member questions? Yeah, Dr. Schechter.
Thank you. On slide 6, I was just curious to what degree the current level of infections in American Indian and Alaska Native kids are post immunization versus after immunization.
And I think it's slide 9. Is that the correct one?
Yes, slide 9.
Okay.
Sorry.
We don't have that data available. We have looked in sort of our active bacterial core sentinel surveillance data at cases among children aged less than 5 among American Indian Alaska Native infants versus non-Native infants and children. And the median age is similar, and the percentage that are unvaccinated is similar. So 32% of cases are unvaccinated among American Indian Alaska Native infants, and among other infants, 31% were unvaccinated. The time period is slightly different for the data I just listed. It was from 2003 to 2023 versus the data on this slide, which are only 2011 through 2020, though. You're welcome.
Sorry, Dr. Long.
Did the work group consider any unintended consequences of this approval? I'm thinking about extra antigens, and if this vaccine was the one you chose to stock because of maybe you're buying certain producers' vaccines, et cetera, would it have any unintended consequences on the non-American Indian Alaska Native population? Not unintended consequences of lack of efficacy. I'm thinking about money.
Could we have slide 34, please? So this, again, I showed it earlier, but it shows the different options. It's sort of regarding the first aspect of your question about the extra antigens. And as you know, with Vaxelis, there is sort of an extra extraneous dose of hepatitis B vaccine that's given at age 4 months. The work group did discuss this. I think it's sort of been generally accepted that that's okay because my understanding is providers are sort of using Pediarix in the same fashion, which also provides an extra dose of hepatitis B antigen. And so that was not something that sort of the work group felt was necessary to alter the decision-making over. And could you repeat your second question?
It took me a while to even understand this slide, but because I haven't thought about it, and I don't talk about these things by their trade names. But in effect, if you decided to just bring this into your office, it would certainly be, I thought we were comparing for American Indian, Alaska Natives, how many shots they get. But this is what would happen to the whole population if you did this. So you would decrease numbers of immunizations, and the cost part of it that you said was equivalent when you considered administration costs, that would be for the entire population, not just for those that you had to use an OMP?
Correct. If you go up 3 slides, you can see the costs.
But aren't there other combination vaccines that you're not showing us here? You're only showing the ones with...
No, in private practice, in most pediatric offices, we were using Pediarix for years. And then when Vaxelis came along, we started using Vaxelis simply to minimize the number of injections. And most of us in private practice felt that the additional cost was worth fewer injections for the infants, and the insurances usually reimburse us at the additional cost. So we're not losing any extra money by having the combination vaccines. And then slide 45, I think, gives some other feasibility things that the work group discussed. And so this is a lot of the feasibility implementation things that came up when we were discussing it.
And this is Dr. Collins. Dr. Long, I'll add that the 3 options, they're not exhaustive of every single possible combination of vaccines that one could use to complete the childhood series. We were trying to capture sort of the various options that use Hib combination vaccines and we don't sort of capture all the different sort of DTaP combination vaccines and other vaccines there, but we're just trying to sort of gauge like a general range of options and costs of those options.
Dr. Daly.
Thanks so much for the presentation. Dr. Collins, 2 pragmatic questions. One is and this may be a question for Dr. Santoli as well, but what proportion of American Indian Alaska Native children get vaccines through VFC versus through private, or just some rough ballpark? I'm trying to get a sense of sort of scope and scale, and then I've got a second pragmatic question.
I don't know that we know the answer to that question. I mean, obviously all those children are entitled, but there are other ways that some Native American children get vaccines because there's so many different ways that they can get care. So I don't know that we have the answer to that. I don't know if you do, Jen. I don't.
I don't have that data either, no.
Okay, and I don't know if Dr. Clark is on, but sort of programmatically, how does this impact?
Dr. Clark has his hand up.
Okay.
Perfect time.
And then
Dr. Clark.
I've got to follow up after that. Thanks.
Okay.
Thank you. Appreciate the opportunity. So first of all, with regard to the question about proportion of American Indian Alaska Native infants who received their vaccines through the VFC program, and as was mentioned, that entire group is eligible regardless of where they received their vaccinations. But I can tell you that 100% of American Indian Alaska Native infants who receive their care at an IHS tribal, federal, or urban facility get their vaccines through the Vaccines for Children program. And then I'm happy to comment a little bit about the agency's perspective on this, if this would be the appropriate time.
Yes, please.
Thank you. So I did want to acknowledge the work of the Johns Hopkins Center for Indigenous Health and the CDC's Arctic Investigation Center for their work on the Phase 4 study that was just summarized. And I also wanted to thank the work group and ACIP for undertaking the review. As was already mentioned, although not common in the post-vaccination era, invasive Hib disease does remain a problem in Indian country. And notwithstanding the study limitations such as small sample size and potential concerns with generalizability, based on the available evidence, IHS supports an ACIP preferential recommendation for Vaxelis in American Indian and Alaska Native infants. We also support post-implementation surveillance of invasive Hib disease in tribal communities, which is planned to look for breakthrough infections. Given the non-inferiority in the immunogenicity study of the post-dose 1 Hib component of Vaxelis compared to PEDVAX Hib, the potential durability of protection and the advantages of being able to offer a multivalent vaccine option to reduce total injections and potentially support greater vaccine acceptance among our high-risk American Indian and Alaska Native population, we do feel that this preferential recommendation is warranted. And in addition, since, as I mentioned, all American Indian and Alaska Native infants are covered by the VFC program, IHS also supports a VFC recommendation for Vaxelis. Thank you.
Dr. Clark, could I just clarify? I think what you mean, I think what you're trying to say is that you are the IHS supports adding Vaxelis to PEDVAX Hib as a preferential recommendation, not Vaxelis alone as a preferential recommendation. Is that your point?
Yes, sir. Thank you for that clarification.
Dr. Daly, would you like to ask your other question?
Yeah, so Dr. Collins, I think I've learned over the last 3 or 4 years to always ask about vaccine supply because it's been problematic at times. So is there any concern? I mean, I realize that in this case it may be less critical because there's other options, but is there a concern about vaccine supply for this product? Thank you.
That is more of an immunization services division question, but I will note just that in 2020, an estimated 1.1% of the U.S. population identified as American Indian or Alaska Native alone, so I don't think it's a large population relative to the general population in terms of taxing the vaccine supply. And then I also wanted to add regarding Dr. Clark's point earlier about infants who are seen in IHS clinics receiving VFC vaccines, that the 2020 U.S. Census found that 87% of those who identify as American Indian or Alaska Native alone, or sort of a combination racial group, live outside of tribal statistical areas, and so they can live anywhere. 13% live on reservations or on other trust lands, and 60% live in metropolitan areas.
Any other questions? Yes.
Yeah, David Castle, FDA. Just on slide 16, just for curiosity, I just wanted to understand the moderate certainty. Oops, must have a different. It's the one that has the great evidence table. Maybe it's one more forward. Correct, that one. So I understand the moderate certainty is based on the confidence intervals. That's the absolute effect. But if you look at the 95% confidence interval for the relative risk, it doesn't include 1, which strikes me as meaning you're pretty certain that it's at least non-inferior, no?
Yet this is sort of a distinction about what the certainty is telling us. It's not telling us how certain we should be in the decision we're making. It's how certain we should be in the effect estimates that are shown. And it relates to sort of really largely the small sample size is sort of what's reflected in the wider confidence interval around the absolute risk was the reason for the downgrade. But you're correct that the confidence interval does include 1 and would suggest there's no difference between the two groups.
No,
but
sorry,
it's
you're on
based
the
on
wrong
a
slide.
small.
You're on the wrong. This is 150 day. I was speaking to. So I must have a different slide set here. It must be maybe 2 forward. There you go. So if you look at the 95% confidence intervals of the relative risk, it does not include 1 and suggests that it's certainly non-inferior and may possibly be superior.
Right, yep, and this is for post-primary series immunity, where the study did show that there was a higher proportion who achieved that immunologic correlative protection 150 days post-dose 1 in the Vaxelis group. And I think for the work group, this was an important outcome, whereas the other 2 were critical outcomes. And the work group did consider whether Vaxelis alone should be included in the preferential recommendation without Pete-Vax-Hib. But I think on balance with the other ETR considerations and things such as feasibility and vaccine supply, my sense from the discussions was that that was not favored. But Dr. Lehr, if you have other thoughts.
Sorry, I'm not being really clear, Mike. I'm just trying to figure out what would it take to be a high certainty here, given the 95% confidence interval doesn't include 1.
So I think we've got 2 different concerns here. One issue is a question of is this significant or not? And it doesn't include 1, and so that's a sense that it might be more effective. But the moderate is actually a grade level moderate, which means how certain are we that this is going to hold up if we did 10 more studies of this in the future? And because it's a relatively small study, there is a chance that this study is actually not correct and might be changed in the future. So high level of certainty is it's unlikely to change in the future. Great experts can correct me. Moderate is there's a chance that it would be correct. And then low and very low are more likely that if we did more studies that the information we have here might change. So I think the moderate is might be a different answer to what you're looking for or what you're commenting on. And I can take it offline if you want. Okay.
Thanks, Dr. Lehr, that's correct.
Any other questions? Well, yeah, Dr. Santoli has to, do we do motion? Hang on. Oh, pardon me, you're correct, Dr. Lehr, we need a motion.
What you just said, Dr. Lehr, just not related to actually these data, but so these degrees of certainty is for it being non-inferior, not being superior. You're not commenting on the superiority of this. You're commenting on the non-inferiority, I believe. So it's pretty close to high certainty that in more studies it would not be non-inferior, but I understand there's an absolute number problem, but I don't know that we've ever established a number problem of sample size.
So I think I'll approach that offline in the future because it's 2 different points, I think. Okay. So can I make a proposal?
Yeah, can we have the language for the motion? Sorry, I looked at the wrong part.
Slide 51, please.
So I make a motion that the ACIP recommends DTaP, IPV, Hib, Hep B, brand name Vaxelis should be included with PRMP, OMP, PEDVAX-Hib in the preferential recommendation for American Indian and Alaska Native infants based on the Haemophilus influenza type B Hib component be approved.
We'll remove the extraneous Hib.
Are you seconding? Okay, thank you. All right. Any additional discussion? She's feeding me. All right, none. I'm going to hand it over to Dr. Santoli.
Okay. Just as a note, the yellow font or highlight in this presentation represents the changes to the existing resolution. So the purpose of this resolution is to update the recommended vaccination schedule and intervals section to, number one, add a preference for Vaxelis in children who are American Indian Alaska Native, and number two, to better align with the existing ACIP recommendations. There's no change to the eligible group section of the resolution. For the recommended schedule and dosage intervals, you will see that there's a change at the language above the table that just clarifies the 3 to 4 doses, including a booster dose. And then on the next slide, I'll show you all of the table notes, but to note that table note 3, which was previously in the first row of the table for PRP OMP, is now also in the final row of the table. And that is indicating that the vaccine is preferred for American Indian Alaska Native children. And then, because we removed a footnote about not having enough evidence for Vaxelis footnote, table note 6 became table note 5. And we replaced the word may be used with should be used. And this is simply all of the table notes shown on one slide, and we did add in a definition of what the OMP stands for, because we didn't have that in before. Table 2, minimum age and intervals, is unchanged. In addition, we've updated one of the bullets in this section to be more clear. I think it was less than 60 months, but we changed it to 59 months to be consistent with the language in the recommendations. And here again, an update was made to the description of when the booster dose would be administered to be more in line with the ACIP recommendations. Table 4 it's across multiple slides. There's no changes in the first 2 rows. In the 3rd row, we had less than 59 months and updated that to be less than or equal to. No other changes in these rows. Here are the footnotes to that table, no changes. No changes to the recommended dose or the precautions and contraindications. And then finally, no changes to this statement, which indicates that a future publication within the next 6 months will be incorporated into the resolution by reference. And that's it.
Dr. Long.
Could you show us one of the slides again that has the should language on it? I have a problem. I'm not finding things in the book. It's probably my problem, but I haven't seen this before. But what are we shoulding? I'm assuming it's still applying just to the American Indian, Alaska Native population, right?
No, this is for...
And we know that that's the header of this whole thing?
Well, this table actually goes beyond Native Americans, so the changes were twofold. One was to better align with the recommendations. The other was to address the preference for Vaxelis. This is, let me go back here so you can see it in the context of the table. Previously, this indicated that Vaxelis was not licensed for a booster dose, and any other Hib conjugate vaccine licensed for the booster dose may be used. We got some feedback from Office of General Counsel that the use of the word may there was confusing when we meant should be used, and so we made that change.
I understand that. I misunderstood that you were talking about this vaccine should be used. You were talking about you need to use a different vaccine. Thank you.
Yeah, I was going to ask if there's any more conversation first. Dr. Lair is ready to make a motion or a proposal, or both. Do we have language for the proposal already written? I'm waiting for the language for the proposal. I figured. There we go. Is this the, okay. Yeah, I think so. We're looking for the VFC. Okay, this is the proposed language.
So,
yes, ma'am.
Now that I understand that slide, and I asked, was the header of all of this Alaska Natives and American Indians? With the should, we want to be sure if someone uses this for the general population that they also should give a booster with a different product. So where is that going to be clear, Dr. Lair?
yes, so the whole resolution is updating the entire HIB for the entire country. And the should is saying, if you use you should not use Vaxelis for the booster dose. You should use something else for everybody. So this is the resolution for the entire country and has a comment in there with regard to Alaska Native and American Indians. So I would like to make a motion, this is Dr. Lair, to approve the Vaccines for Children resolution for vaccines to prevent Haemophilus influenza type B HIB be approved.
Dr. Sinanis, is that a second?
I second that motion.
Thank you. Any further discussion? Okay, I think we're good, which actually ends us a little bit early, right? Or am I like off? I am not. Our break wasn't until 2:50 and it's 2:40. All right, so we will break until 2:55. That way we're all back in time for public comment. So you can check your email or do whatever you need to do. Thank you. Welcome back, everyone. It is now 3 p.m., and we will reconvene the meeting to begin oral public comment. I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via lottery. For our speakers today, we have a limited public comment period, and in order to make it through all the listed speakers, it is extremely important each speaker limits his or her or their remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. As a gentle reminder, our committee appreciates diverse viewpoints that are respectful in nature and focused on the issues being discussed at our meeting. Thank you again to our speakers, and we look forward to your comments. Our first speaker is Mr. Louis Ferdinand from Voices for Vaccines. You may begin.
Yeah, hi, this is Noah. I'm the communications coordinator at Voices for Vaccines. I just wanted to touch on one aspect of the RSV vaccine recommendations, which is the shared clinical decision-making for adults over 60. I know this group is kind of leaning away from it, and I would support moving away from it. I think it's confusing for people, not just because it doesn't really give clear guidance on what they should or shouldn't do, but also because we're coming off the back of another, newish vaccine for people that they're being recommended to take seasonally, which is COVID vaccines. And with the booster doses, I think there was some confusion around the rollout with the timing and the different, variant vaccines, and I still get questions about that. So given that there's some lingering confusion, and I assume even less kind of public awareness and information around RSV and the, 3 different immunizations for it, it would be nice to have a clear message coming in as to what to communicate to people. Just generally, I've noticed that there seems to be a bit of a communications void. Organizations that typically educate about vaccines, I've seen less messaging about it, and I just assume that's because there isn't a super clear message to communicate as of right now. So I think it would go a long way just to have that clear recommendation, given that this is a serious and burdensome disease for the public. Thank you.
Thank you for your time and comments. Our next speaker is Ms. Reese.
Hello, my name is Dorit Rice. I'm a professor of law at UC Law San Francisco, formerly Hastings. First, congratulations to the new members, and thanks to all of you for your service. Second, I just want to mention that as a parent, combination vaccines are a good thing because less needles is better. In regard to RSV, I agree with the previous commenter about the need for simplicity and clarity in recommendation. That's really important, especially for new vaccines. However, while I understand the need to only recommend necessary vaccines, consider that the vaccine for adult program is not on the immediate horizons. Taking away shared clinical decision-making for adults under 75 will create serious equity issues for those who cannot afford a $400 vaccine. Remember that these are often the same people who may have undiagnosed underlying conditions that put them at high risk of RSV. I hope you reconsider and not take away shared clinical decision-making for that, even at the price of clarity. Finally, I want to mention, just for the committee's information, that 2 recent legal decisions can and probably will affect the committee or CDC's work. In a recent decision in Braidwood versus Becerra, the Fifth Circuit implied at least that it may consider previous ACIP recommendation as unconstitutional, given the lack of approval. It's a problematic decision. I hope the government is considering to appeal, and I hope the CDC is involved in those discussions. And on a more positive note, and the decisions that came out today, which you couldn't have heard because you were doing other things, in Mercy versus Missouri, the Supreme Court rejected the challenge to CDC and other agencies' communications with government and social media on the grounds that it didn't show the communication led directly to effect. So that at least potentially opens the door to more communications between CDC and social media platform. Thank you for your time.
Thank you. Dr. Cass.
Hi, thank you for the opportunity to speak. My name is Elias Cass. I'm a naturopathic physician specializing in pediatric primary care and vaccine hesitancy. Babies and young children have been frequently left behind in COVID-related prevention, and so it is vitally important that recommendations for this fall's updated COVID vaccine include babies 6 months and up, and that primary care offices be supported in distribution and administration of these vaccines, as most young children cannot be vaccinated in pharmacies. I am hoping that Novavax authorization will extend down to 6 months, as I found that many of my families who otherwise enthusiastically vaccinate are still apprehensive about mRNA vaccines, and their children are experiencing multiple COVID infections as there are no other options for this age group. The CDC must emphasize layered prevention, including engineering controls like clean indoor air, as well as individual controls like masks, and not rest on a vaccine-only approach. These approaches would also help with other respiratory viruses like RSV. Last year's rollout of nirsevimab was eagerly anticipated and incredibly frustrating, and we're hopeful that this year will be smoother, and we're so excited to have Abrysvo for use in pregnancy, as RSV disease in infants remains a significant burden and contributes to a lifetime of complications. Thank you for your careful consideration of all these issues. I always learn a lot from listening to these meetings.
Thank you very much for your input. Mr. Ford. Okay, we'll come back. Ms. Clark.
Yes, hi, good afternoon. My name is Lindsay Clark, and I serve as a Senior Vice President of Health Education and Advocacy at the Alliance for Aging Research. Thank you for this opportunity to comment. Our main message today is this: when the ACIP delays a vote because they think they need more data, the committee is inadvertently hampering vaccine data collection. This is because public and private payers generally require the FDA's approval and an explicit ACIP recommendation before they will cover and pay for any new vaccine. This makes more data collection on new vaccines improbable if they're not being covered and paid for. With that in mind, here is what we'd like to see ACIP vote on without delay. ACIP should get rid of its RSV and pneumococcal vaccine shared clinical decision-making recommendations for older adults. A report that was released yesterday by Champions for Vaccine Education, Equity, and Progress finds that SCDM vaccine recommendations create complex and unnecessary access hurdles, particularly for underserved communities. You can find that report at cveep.org. Second, there are 2 FDA-approved RSV vaccines for use in adults age 60 and older. We would like to see ACIP vote on a universal RSV vaccination for all adults ages 60 and older. Additionally, ACIP should vote to recommend the one RSV vaccine that received FDA approval for expanded use in adults ages 50 and older. We appreciate the CDC's commitment to bridge vaccine equity gaps, and a 50-plus RSV vaccine recommendation would be an important first step. According to the CDC's own RSV net data, every year an estimated 42,000 adults ages 50 to 64 years old are hospitalized due to severe complications from RSV. The data suggests that earlier and higher rates of asthma, congestive heart failure, or COPD in underserved communities leads to earlier RSV onset and higher risk of hospitalization and severe outcomes, including deaths. We encourage ACIP to consider data on the 2 RSV vaccines separately and not delay consideration of a reduced age recommendation. Similarly, ACIP should vote on a universal pneumococcal vaccine recommendation for adults ages 50 and older. CDC data presented 3 years ago at the June 2021 meeting showed that an age-based recommendation starting at age 50 could address racial disparities in pneumococcal disease risk and vaccine uptake and provide cost savings. Fifth, we ask you to please continue to support and vote on a preferential recommendation for enhanced flu vaccines. And last, please vote as soon as possible after the FDA approves or authorizes the 2024-2025 COVID-19 vaccines. We would like to see updated vaccines available in August on the same timeframe as annual flu vaccines. We appreciate the ACIP and the excellent team at the CDC. Thank you so much.
Thank you for your comments. Mr. Ford? I don't believe he's come, so that will be the end of our public comment section, and we can move on to our votes. Our first vote is for the RSV vaccines. There's actually 2 votes. If we could have the proposed language. Is the video turned on? Sorry for the delay. We're trying to work out the cameras. We are now on camera and we're ready to vote. So the first vote, ACIP recommends adults 75 years of age and older to receive a single dose of RSV vaccine. Currently, RSV vaccination would be recommended for a single lifetime dose only. Persons who have already received RSV vaccinations are not recommended to receive another dose. These recommendations would supplant the current recommendation that adults 60 years of age and older may receive RSV vaccination using shared clinical decision-making. Adults 60 to 74 years of age who are not at increased risk of severe disease would not be recommended to receive vaccine, although Part B is really our next one, so hang tight. All right, we will start with the vote. Oliver Brooks.
Oliver Brooks, vote yes. No
Also, any
conflicts.
conflicts?
I said no conflicts.
Okay, thank you. Wilbur Chen.
Wilbur Chen, no conflicts, yes.
Sybil Sineas.
Sybil Sineas, no conflicts, yes.
Matt Daly.
Matt Daly, no conflicts, yes.
Denise Jamison.
Denise Jamison, no conflicts, yes.
Camille Cotton.
Camille Cotton, no conflicts, yes.
Jamie Lair.
Jamie Lair, no conflicts, yes.
Sarah Long.
Sarah Long, no conflict, yes.
Rob Schechter.
Rob Schechter, no conflicts, yes.
Al Shaw.
Al Shaw, no conflicts, yes.
All right, and Kip Talbot, no conflicts, yes. So 11 yeses and no nays. Is that what you got? Okay, all righty. Vote number 2. Okay. ACIP recommends adults 60 to 74 years of age receive, sorry, I skipped the line. ACIP recommends adults 60 to 74 years of age who are at increased risk of severe RSV disease receive a single dose of RSV vaccine. Once again, RSV vaccination is recommended as a single lifetime dose only. Persons who have already received RSV vaccination are not recommended to receive another dose at this time. This recommendation would supplant the current recommendation that adults 60 years of age and older may receive RSV vaccination using shared clinical decision-making. Adults 60 to 74 years of age who are not at increased risk of severe disease would not be recommended to receive RSV vaccination. CDC will publish clinical considerations that describe chronic medical conditions and other risk factors for severe RSV disease for use in this risk-based recommendation. All right, we'll do reverse order this time. Al Shaw.
Al Shaw, no conflicts, yes.
Rob Schechter.
Rob Schechter, no conflicts, yes.
Sarah Long.
Sarah Long, no conflict, yes.
Jamie Lair.
Jamie Lair, no conflicts, yes.
Camille Cotton.
Camille Cotton, no conflicts, yes.
Denise Jamison.
Denise Jamison, no conflicts, yes.
Matt Daly.
Matt Daly, no conflicts, yes.
Sybil Sineas.
Sybil Sineas, no conflicts, yes.
Wilbur Chen.
Wilbur Chen, no conflicts, yes.
Oliver Brooks.
Oliver Brooks, no conflicts, yes.
All right. Kip Talbot, no conflicts, yes. Once again, 11-0. So the motions pass, both of them. So we get to see more RSV vaccination. Can they comment now? All right, so if anyone wants to comment on their RSV votes, please feel free. Dr. Lair?
I realized when talking to people that the general public might not know why we're so concerned about Group B's Guillain-Barré syndrome. And so for those who don't know, Guillain-Barré syndrome is a neurological disorder, ascending paralysis. Patients who have it often end up in the hospital for 3 to 4 months, might be intubated, and might die. And so it is not a small consequence. It's not fevers. It's not even a febrile seizure. So I just wanted to clarify why we have such significant concerns about the possible risk of Guillain-Barré with RSV, and that's why I was much more comfortable with the risk-based than the age-based for the 60 to 74-year-olds. Thank you.
Thank you. Anyone else? Okay. Matt. Sorry, Dr. Daly.
No, not, thanks. No, two quick points. One is that as you were reading the language, I felt like adding "at this time" to both those sentences. So I just to acknowledge that we'll sort of have that conveyed, because that's important, sort of based on what we know today. And then to Dr. Lair's point, sort of to the listening public, Guillain-Barré syndrome is quite a serious condition. Fortunately, it's rare, and we're gathering more data about it. And so for those who are recommended for RSV vaccine today, that recommendation is you're going to get substantial benefit and avoid a serious illness that may put you in the hospital. So that, we always sort of want to have that communicated as well. So I think we have lots of opportunities for disease prevention out there, and let's go get them.
Any other comments? Okay, fantastic. We can move to our next vote. I'm going to cheat like Dr. Lair did. ACIP recommends Vaxelis should be included with, PRP OMP. Do you say PediVax or PedVax? PedVax-Hib. I'm definitely an adult doctor. In the preferential recommendation for American Indian and Alaska Native infants based on Haemophilus influenza type B Hib component. All right. Dr. Daly.
Matt Daly, no conflicts, yes.
Sybil Sineas.
Sybil Sineas, no conflicts, yes.
Denise Jameson.
Denise Jameson, no conflicts, yes.
Camille Cotton.
Camille Cotton, no conflicts, yes.
Jamie Lair.
Jamie Lair, no conflicts, yes.
Sarah Long.
Sarah Long, no conflict, yes.
Al Shaw.
Al Shaw, no conflicts, yes.
Wilbur Chen.
Wilbur Chen, no conflicts, yes.
Robert Schechter.
Robert Schechter, no conflicts, yes.
Oliver Brooks.
Oliver Brooks, no conflicts, yes.
Kip Talbot, no conflicts, yes. I think the motion passes 11-0. It's nice to know I can add. Okay. Any comments? Okay, next vote. This is the Vaxelis VFC vote. It's to approve, don't laugh at me. Approve the Vaccines for Children resolution for vaccines to prevent Haemophilus influenza type B Hib. And since Dr. Lair was laughing at me trying to say VFC, I'm going to let him vote first.
Jamie Lair, no conflicts, yes.
Sarah Long.
Sarah Long, no conflict, yes.
Rob Schechter.
Rob Schechter, no conflicts, yes.
Al Shaw.
Al Shaw, no conflicts, yes.
Oliver Brooks.
Oliver Brooks, no conflicts, yes.
Wilbur Chen.
Wilbur Chen, no conflicts, yes.
Sybil Sineas.
Sybil Sineas, no conflicts, yes.
Matt Daly.
Matt Daly, no conflicts, yes.
Denise Jameson.
Denise Jameson, no conflicts, yes.
Camille Cotton.
Camille Cotton, no conflicts, yes.
Kip Talbot, no conflicts, yes. This motion passes 11-0. Okay. Is the team ready? We're going to move on to chikungunya, which is great because we're early. So our first introduction will be done by Dr. Wilbur Chen.
Okay, let's bring up the slides. Let's go to the next slide. The chikungunya vaccines work group was initially assembled in May of 2022 and has been developing policy options for ACIP's consideration for the use of chikungunya vaccines among U.S. persons at risk of chikungunya, including travelers, laboratory workers, and residents of U.S. territories and states with risk of transmission. Next slide. The work group has given presentations at 5 previous ACIP meetings. So to briefly recap, this included presentations at the October 2022 meeting, in which we provided the overview of chikungunya disease and a description of the live attenuated chikungunya vaccine. In February 2023, clinical sequelae of chikungunya and the epidemiology of chikungunya globally and among U.S. travelers was presented. June 2023, the work group provided the assessment of the value of a vaccine to travelers and on infection among laboratory workers. October 2023, the work group provided the ETR, the evidence to recommendations framework for the use of live attenuated vaccine among U.S. travelers and laboratory workers. Next slide. And then the 5th meeting was February 2024, earlier this year. The recommendations for the use of live attenuated chikungunya vaccine among U.S. travelers and laboratory workers was approved by the ACIP. Next slide. So an overview of today is that there will be an update on chikungunya vaccines, and then there will be 2 presentations focusing on populations at risk of chikungunya in U.S. territories and states. The first presentation will provide an overview of the epidemiology of chikungunya in U.S. territories and states. The second presentation will provide a cost-effectiveness analysis of the use of live attenuated chikungunya vaccines in adults living in U.S. territories, and the session will end with a brief presentation outlining the next steps of the work group. Next slide. So I'd like to acknowledge the many people who contribute to this work group. I want to thank Matt Daly as the co-ACIP member of the work group for his valuable involvement in the work group discussions. I want to thank Susan Hills as the CDC lead, who is always prepared, ushering the work group forward with her carefully crafted discussions, shepherding the discussions, and just her great leadership overall. I also wanted to thank each of the ex officio, liaison, and experts that have been invited as consultants for their important contributions to the work group. Next slide. And I want to thank all of the many CDC members who have also contributed and supported the success of the work group. Thank you.
Thank you, Dr. Chen. Dr. Hills, I think we're ready to be shepherded.
So to update ACIP members on the status of chikungunya vaccines in the United States, in addition to the live attenuated vaccine that was licensed last year, recently a second chikungunya vaccine has been submitted to FDA for licensure. The vaccine is a virus-like particle vaccine, and it's manufactured by Bavarian Nordic. The BLA submission to FDA was completed just last week on June 17th, and based on this, licensure is possible during the first half of 2025. The intended age group for licensure is adolescents and adults aged 12 years and older, and the vaccine has a single dose schedule. There won't be any presentations on this vaccine today, but there will be presentations both by the manufacturer and the work group at the October ACIP meeting. And as a reminder, the other chikungunya vaccine licensed in the United States is a live attenuated chikungunya vaccine manufactured by Valneva as IXCHIQ. It was licensed on November the 9th, 2023, and is currently approved for use in adults 18 years and older. This vaccine also has a single dose schedule, And as Dr. Chen mentioned, recommendations for the use of this vaccine in adult travellers and laboratory workers were approved by ACIP in February earlier this year. And we're now considering use in US territories and states with risk of transmission. So with that brief update, I'll hand back to you, Dr. Talbot, for any questions before I move on to the next presentation.
Any questions? I think they're ready to go. Dr. Hills, you can start the next session.
Thank you very much. So before I describe the epidemiology of chikungunya in US territories and states with risk of transmission, I'd like to provide just a brief reminder on chikungunya. So chikungunya is a mosquito-borne disease, and the key vectors that spread the virus to humans are Aedes aegypti and Aedes albopictus mosquitoes. Chikungunya virus is typically transmitted in tropical and subtropical regions, although occasional transmission in temperate areas has occurred. As you can see on the map, there are approximately 120 countries and territories globally where transmission has been documented. The virus periodically causes large outbreaks, and when they occur, attack rates are often high, with 1/3 to 3/4 of the population affected. Peak virus transmission is usually during the wet season, related to an increase in mosquito populations. Clinical illness is characterized by fever and joint pain, which is typically severe and can be debilitating. Other symptoms can include headache, rash, myalgia, and anorexia. In the absence of specific antiviral treatment, the approach to management typically involves rest, fluids, and the use of analgesics and antipyretics. Serious complications are rare, but they can include presentations like myocarditis, hepatitis, and neurologic illnesses such as Guillain-Barré syndrome and meningoencephalitis. Deaths are also rare, and they're reported mostly in older adults, particularly those with comorbidities, and young infants infected perinatally or by mosquito bites. Acute symptoms of chikungunya usually resolve in about 7 to 10 days. However, some patients have a continuation or relapse of their joint symptoms in the months after acute illness, and they can experience other symptoms like fatigue. Studies have reported variable proportions of patients with persistent symptoms, but up to 1/2 of patients may have ongoing arthralgia of variable severity at 3 months after infection, and up to about 30% at 12 months after infection. So now I'll describe the epidemiology of chikungunya in US territories with risk of transmission, and I'll begin with Puerto Rico. So for context, Puerto Rico is the largest US territory with a population of about 3.2 million and a size of about 3,500 square miles. It's located in the Caribbean, so has a tropical climate and has an established population of Aedes aegypti mosquitoes. Dengue is an endemic disease in Puerto Rico. The data I'm going to use to describe the epidemiology of chikungunya in Puerto Rico were compiled from different sources of passive and sentinel surveillance data, because there's no one data source that provides completely accurate and comprehensive information. This is because during the course of the outbreak, surveillance activities, reporting practices, and laboratory testing approaches changed. So for example, when laboratory capacity was exceeded early in the outbreak, testing was prioritized for certain groups, and when the number of suspected cases reached thousands per week, only certain types of cases were required to be reported. So as a result, the key points in considering these data are that the numbers of reported cases are generally a substantial underestimate of true cases, but the data overall provide a reasonable representation of the actual disease epidemiology. The data I'm presenting also represent confirmed and probable cases based on certain laboratory criteria. Confirmed cases are those with clear laboratory evidence of infection, generally by detection of chikungunya virus nucleic acid by RT-PCR. Probable cases are those with IgM antibodies alone in serum or CSF. There are a few reasons why a person with IgM alone is considered a probable case. One of the key concerns is that IgM antibodies can persist for months or years after acute infection. So the presence of IgM antibodies may signify a past infection and be unrelated to the patient's current acute illness. Studies have shown that at 13 to 18 months after acute chikungunya virus infection, 56% of patients might still have detectable chikungunya IgM antibodies, and at as long as 2 to 3 years after infection, 11% might still have IgM antibodies. In the Caribbean region overall, chikungunya emerged in 2013, with the first case reported in St. Martin Island in December of that year. Subsequently, there was a rapid increase in countries and territories reporting virus transmission. In Puerto Rico, the first locally acquired laboratory-confirmed case of chikungunya occurred in early May 2014. So this graph shows laboratory-confirmed and probable chikungunya cases reported to the Puerto Rico Department of Health by year from 2014 onwards. The substantial outbreak in 2014 is clearly evident, and as you can see, numbers dropped dramatically after that year. Although cases were reported through 2020, the last symptomatic clinical disease case with laboratory confirmation based on RT-PCR testing was in October 2017. We believe it's very likely there's been no local transmission of chikungunya virus in Puerto Rico since that time. So this graph shows cases by month of illness onset during the outbreak years of 2014 to 2015. You can see that once viral transmission commenced in May 2014, there was a rapid increase in the number of cases, with the outbreak peaking 4 months later in September 2014. In the following year, in 2015, there was a small seasonal increase in cases in the middle of the year, and that's when the weather in Puerto Rico is hot and humid and rainfall is heaviest. But there really was no substantial transmission after the very intense transmission during 2014. In relation to the demographics of the chikungunya cases, illness that occurred in a similar proportion of females and males. And in terms of age groups, there was a higher percentage of cases in children aged 0 to 19 years. There were a lower but similar percentage of cases in the other age groups. However, the higher percentage of cases in children might have been biased by laboratory testing practices. This map shows chikungunya cases by municipality. The higher number of cases, which is represented by the darker shading, not surprisingly, were in areas of higher population density. But really the key point depicted by this map is that cases occurred throughout almost all areas of the island. 2 studies have provided data on the proportion of the Puerto Rico population that was likely infected during the outbreak. One study was a household cluster survey among persons who were aged 1 to 50 years, and this was conducted in a municipality in southern Puerto Rico a few years after the outbreak. 31% of the participants had evidence of past infection. The other data were from testing of blood donor samples collected in March 2015, and 23% of those samples had evidence of chikungunya virus infection by IgG. So based on these data, with a seroprevalence rate of 30%, about 1 million persons in Puerto Rico are estimated to have been infected during the chikungunya outbreak in Puerto Rico. On the basis of estimates that about 65 to 85% of all chikungunya virus infections are symptomatic disease cases, this translates to about 650,000 to 850,000 clinical cases of chikungunya in Puerto Rico during the outbreak. So next I'll describe the epidemiology of chikungunya in the US Virgin Islands. USVI is substantially smaller than Puerto Rico. It has a population of about 105,000 persons. And being in the Caribbean region, USVI was on heightened alert for chikungunya after its detection in the region in 2013. The first locally acquired case in USVI was detected and reported in early June 2014. And the case was reported from St. Thomas, which is one of the 3 large islands in the archipelago, and is shown on the upper left there on the map. St. Thomas subsequently went on to have the largest number and highest rates of probable and confirmed cases, and you can see that on the graph in the light grey colour, although the outbreak rapidly spread to the other 2 large islands, St. John in the medium grey colour and St. Croix in the darkest grey colour. The last laboratory positive case in the outbreak in USVI was detected at the end of February 2015. About a year after the outbreak ended, a seroprevalence survey was conducted, and 31% of the persons sampled had evidence of past infection. Based on these data, about 33,000 persons in USVI are estimated to have been infected during the chikungunya outbreak, and with 65% to 85% of all chikungunya virus infections being symptomatic disease cases, about 21,000 to 28,000 clinical cases of chikungunya likely occurred in USVI during that 8-month outbreak period. So I'll now present some brief information on chikungunya virus transmission in the other US territories and freely associated states, although data are relatively limited. In American Samoa, an outbreak began in June 2014. The extent of the outbreak is unclear, but unconfirmed reports suggest at least 823 suspected cases occurred. The duration of the outbreak is also unclear, but there was no evidence of ongoing transmission by the end of 2015, when a Zika outbreak began in American Samoa. In the 2 remaining US territories of Guam and the Commonwealth of the Northern Mariana Islands, chikungunya cases have never been reported. And transmission has been reported in 2 of the 3 freely associated states. In the Federated States of Micronesia, an outbreak occurred in Yap State and lasted just over 12 months from August 2013 through August 2014, although 86% of the cases occurred during the peak of the outbreak from October through December 2013. Ultimately, 1,761 suspected cases were reported for an attack rate of 155 clinical cases per 1,000 population. And that equates to about 15% of the population seeking healthcare for a clinically compatible illness during that outbreak. In the Marshall Islands, an outbreak began in February 2015. The duration and extent of the outbreak are unclear, but unconfirmed information suggests more than 1,000 suspected cases occurred. And in Palau, no cases have ever been reported. So in summary, among 8 US territories or affiliated states, 3 territories and 2 affiliated states have had outbreaks of chikungunya. When outbreaks occurred, they were explosive and spread rapidly. For Puerto Rico and USVI, where information is available, seroprevalence surveys suggest about 30% of the population was infected, which equates to about 20 to 25% of the whole population having clinical illness, with most cases occurring during a peak transmission period of about 6 months. All outbreaks in the US territories and freely associated states began from 2013 to 2015, with the last evidence of any ongoing confirmed transmission being in 2017 in Puerto Rico, and it was much earlier in the smaller island nations. And finally, the timing of future transmission or outbreaks is unknown, and we can't predict with any certainty the patterns of future transmission in these areas. And now I'm going to discuss evidence of chikungunya virus transmission in US states. And I'd like to remind you that the vectors for chikungunya virus, as I mentioned earlier, are Aedes aegypti and Aedes albopictus, and these maps provide an estimate of the potential ranges of these vectors in the United States. The first local transmission of chikungunya virus in the continental United States occurred in Florida in 2014. So this occurred at the time an extensive outbreak of chikungunya was ongoing in the Americas, and the US had seen a dramatic increase in chikungunya cases among travelers returning to the United States from those areas. After the first locally acquired case was identified in June, 11 additional cases were reported, and all occurred in 4 counties in southern Florida, which you can see outlined on the map. 2 patients lived within 1,500 feet of each other and was assumed to be linked as part of a cluster, and the others all appeared to be sporadic cases. No local transmission of chikungunya virus in Florida has been reported since that time. And 1 case of locally acquired chikungunya also occurred in Texas, in Cameron County, in November 2015. The county is on the border with Mexico, but the patient denied any international travel prior to illness onset. No additional cases were identified. Thank you, and I'll hand back to you, Dr. Talbot, for any questions.
Thank you. Any questions from the work group? Dr. Lair.
Thank you for your presentation. You said the timing of future transmission or outbreaks is uncertain. Do we have any evidence of a waxing or waning pattern in other parts of the world, like in Southeast Asia, that this happens every 2 years or every 4 years, something like that?
Yeah, thank you for that. It's variable, basically. Typically up to 15 years is the interval that is considered where outbreaks might occur. But there is a little bit of difference, of course, between countries in Southeast Asia, for example, or in South America that are contiguous with other countries. And so there can be importations and some ongoing transmission in local areas that then spread from area to area to area. In islands and in, there's these locations that are sort of more isolated with populations where the virus has come through, affected about 30% of the population. We expect it might, quite some time between outbreaks, and for example, La Réunion had an outbreak in 2005-06, and it's now 2024, and they haven't seen no further transmission. So, you can never predict with, importation and the right ecologic conditions, and other factors, but we expect particularly in these island locations that it might be quite some time between outbreaks.
Dr. Long.
Yes, I know we're not talking about a vaccine now, but just trying to think about the plausibility. What is anybody thinking about? Because these outbreaks seem to be rapidly on and then off. You mentioned 6 months, but just looking at what happened to the Virgin Islands, it looked like it was over in each island in about 2.5, 3 months. How are you thinking about this? Thinking about immunizing 1 million people in Puerto Rico, for instance, in a very short period of time. Is that how the vaccine would be thought to be potentially used?
Thank you for that question, Dr. Long. That is exactly what the work group is currently considering and trying to work out at the moment. So you're about to hear a presentation on the cost effectiveness of the use of the vaccine in the US territories, and that considered 2 scenarios: use during an outbreak or routine use in the territories. We're also considering, factors, as you mentioned, like feasibility, acceptability of vaccination, and all those factors, and we will be aiming to present those pieces to ACIP when the work group has had a chance to discuss them further over the next 6 to 12 months.
Dr. Daly.
Yeah, thanks so much for that. Can you just briefly, and if this comes on a later slide, let me know, but briefly remind us about two things. One is mortality and serious long-term morbidity in adults, and sort of what proportion of cases end up with that. And then just what surveillance for poor neonatal outcomes looks like, and whether we infer that from other countries or whether we have surveillance from U.S. territories on poor newborn outcomes. Thanks.
Thank you. Yeah, so based on a meta-analysis and systematic review that we did at CDC, we found long-term arthralgia and potentially other symptoms like fatigue. The rates at 6 months were about, 3 months were about 50%, and at 12 months about 30%. And that's a varying severity that can range from mild right through to severe. And then mortality is low, it's rare, it's particularly in those older age groups over 65 years, particularly with comorbidities, and the younger infants, and either infected perinatally or through mosquito bite. And it's round about 0.1 to 0.3% for mortality. The data we have on perinatal transmission and the impact in infants, the best data came from La Réunion when they had their outbreak in 2005, 2006, and they did some very comprehensive surveillance. So those are the sort of the data that we have primarily been using to address that issue, although there are some other studies from South America and Southeast Asia.
I think Dr. Brooks was in line before you. Dr. Brooks?
I was asking the same thing as Dr. Daly, the morbidity and mortality. Thank you.
Well done. Okay, Dr. Lair.
On slide probably around 10, you talk about IgM antibodies lasting for months to years. And I guess in my basic training, I was taught that they disappear by about 6 weeks. So I guess 2 questions. Is there something special about chikungunya, obviously? And is this common in other infections that I don't know about where the IgM persists? Thank you.
Yeah, so this is not uncommon for arboviruses. So for example, for West Nile virus, we found IgM antibodies also persisting for years after infection, yellow fever, after yellow fever vaccination persisting for long term. So I would say it's more the rule than the exception for arboviral diseases. So yeah, it's not an uncommon phenomena that we've found with chikungunya.
Any other questions? Thank you so much. I think we'll move on to Dr. Staples for the cost effectiveness of the attenuated vaccine. Yes, while they're pulling up the slides, absolutely.
Back to Dr. Hill, thinking about the acute transmissibility of this and then the quick off. What percentage of populations are usually infected in a typical outbreak? I bet that's going to come in cost effectiveness, if you don't want to answer that, but what is it, Dr. Hills, do you know?
So the percentage of all populations that are infected in based on seroprevalence studies ranges from about 20% to up to about 80%.
Wow.
In our territories, in both territories where seroprevalence studies were done, 31% of the population was infected. but depending on, multiple factors, such as, these were naive populations. So depending on background seroprevalence, but depending also on factors like environmental conditions and when the outbreak starts. Does it begin at the beginning of the wet season, or if it begins at the end of the wet season when transmission and mosquito numbers are decreasing? What is the population density? What vector control measures are implemented? Are the houses screened? And all those factors can really impact what percentage of the population gets infected in different locations.
All right, thank you. I want to introduce Kelly Kilburn, who's a Preventive Effectiveness Fellow with the Arboviral Diseases Branch, who will present on the cost effectiveness of the vaccine. Thank you.
I'm Dr. Kelly Kilburn, and I will be presenting on the analysis of the cost effectiveness of the live attenuated chikungunya vaccine among adults living in U.S. territories. I want to thank all of my co-authors for their contributions. None of the authors have conflicts of interest to report, and we're providing you with a standard CDC disclaimer. I will be covering the research question, methods, the results, sensitivity analyses, limitations, and then a summary of results. The general research question we aim to address is, what is the cost effectiveness of using a single dose of Valneva's live attenuated chikungunya vaccine among the population aged 18 years and older, living in U.S. territories that previously experienced an outbreak of chikungunya, namely American Samoa, Puerto Rico, and U.S. Virgin Islands. Now to cover the methods used for this analysis. These are the basic elements to our economic model. We use a population-based model that includes the entire population of the 3 U.S. territories. The time set for our model is 1 year. In each 1-year interval, there are changes occurring to the number of people vaccinated, the seroprevalence, and the present value of costs, among other things. We then run the model starting in the year 2024 for a total of 30 years. We use a standard discount rate of 3% to discount future costs and outcomes, and we included both societal and healthcare payer perspectives. And for the last element, outbreak timing, there are little data on the time between chikungunya outbreaks in island nation or territories. The best data we could find was from one modeling study in the Philippines that estimated an average of 17 years between outbreaks. Since the last outbreaks in the territories were in 2014, we assume that there would be one chikungunya outbreak in 2034 or 20 years after the start of the last outbreaks. Our intervention is the use of the live attenuated chikungunya vaccine in adults. We decided to explore 2 intervention strategies depicted in this table, routine and outbreak vaccination, and compared each to no vaccination. For the first strategy, routine vaccination, we estimated annual vaccination coverage would be 20% based on the uptake of annual influenza vaccine in Puerto Rico. Vaccination coverage during the outbreak year in 2034 would reach 70% total across the adult population. For the second strategy, outbreak vaccination, it is assumed that no one in the population receives the vaccine prior to the outbreak response. During the outbreak year, all adults in the population are targeted with vaccination coverage reaching 70%. This is based on COVID vaccination coverage in Puerto Rico. To expound upon these 2 strategies, we present a visual comparison across the time horizon of the model. In 2024, the first year, there's initial vaccination of adults in the routine strategy only. After the first year, we model annual vaccination of new adults aged 18 years for the routine strategy. However, all adults would be eligible in practice. In 2034, a chikungunya outbreak occurs, and the vaccination campaign targets non-vaccinated adults. After the outbreak, there is continued annual vaccination of new cohorts of 18-year-olds until the end of the time horizon. In the outbreak strategy, vaccination only occurs during an outbreak campaign in 2034 and targets all adults. We estimated the following population-level health outcomes for each vaccination strategy: symptomatic cases, hospitalizations, chronic joint pain cases, deaths, and quality-adjusted life years lost, QALYs. We also estimated economic outcomes for our two perspectives: societal costs, that includes vaccination, medical expenses, and lost productivity, and healthcare payer costs, which excludes lost productivity. For our analysis approach, we calculated incremental cost-effectiveness ratios comparing vaccination to no vaccination. Cost-effectiveness is measured as the dollar per outcome averted using the estimated health and economic outcomes from the previous slide. Using at-risk software, we ran the model using Monte Carlo simulation with 1,000 replications to estimate results with 95% confidence intervals. Then, we conducted sensitivity analyses to estimate how results would be impacted by changes to certain model decisions and input values. I now want to note some of the model assumptions. We assume that chikungunya confers lifetime immunity and that outbreaks would stop once a certain level of seroprevalence was reached in the population, which we are referring to as halting seroprevalence. In this demonstration of halting seroprevalence, there is baseline level of population seroprevalence from the last outbreak, which is reduced over time due to mortality and new birth cohorts, as seen with the slight downslope of the line here. When an outbreak occurs in 2034, there will be an increase in the seroprevalence due to infection or vaccination of the population. The outbreak will halt once the seroprevalence level is reached, shown as the dotted line, and then decline again over time. Now, I will review some key model inputs. This slide shows infection inputs, including the value we used in the base model and the range of low and high values used to establish a distribution and in the sensitivity analyses. First is baseline seroprevalence, which is the level of population immunity from the prior outbreak. We used data from Puerto Rico and USVI sera surveys, where 31% of each population were estimated to be infected. We estimated that 72% of people infected with chikungunya virus become symptomatic based on the USVI sera survey. Next are inputs for the health outcomes. We estimated 43% of symptomatic chikungunya cases are care-seeking based on data from the previous outbreaks in US territories. 10% of care-seeking cases go on to be hospitalized. The rate of symptomatic patients who go on to have chronic joint pain is 35% based on a recent meta-analysis. And last, the death rate from chikungunya among hospitalized patients is 1% based on data from Puerto Rican hospitals. Vaccine effectiveness data are not available for the current approved live attenuated chikungunya vaccine. So we use the 6-month vaccine seroresponse rate of 96.3% as the input of potential efficacy. We estimated vaccine-induced immunity will decay by 5 percentage points every 5 years based on rates of antibody decay seen following similar live attenuated or chimeric vaccines. This graph depicts the declining seroresponse for someone who is vaccinated in 2024. Next are the quality inputs. In this table, the health utility weight for a non-hospitalized acute case of chikungunya is 0.63, which is applied for a duration of 7 days, giving a total loss of 0.01 QALYs. Hospitalized cases are expected to be greater in severity and have a total loss of 0.02 QALYs. These two health utility weights are based on an acute case of dengue, since no direct health utility weight has been developed for the acute phase of chikungunya. Chronic joint pain cases last longer and result in a loss of 0.24 QALYs. Next, I will review the methods of the sensitivity analyses. We conducted 2 types of sensitivity analyses. First, in the univariate analysis, we varied the input of 1 parameter at a time using the first and 99% values of the input ranges to calculate the cost per QALY gained. Second, we evaluated different scenarios based on changing the values of static input choices we made for the base model, given uncertainty in these inputs. In the first scenario, we changed the year of that single outbreak to 2029 or 2039. In additional analyses, We varied input choices for vaccination coverage and halting seroprevalence together by using a low and high value for each input. Halting seroprevalence varied from a low of 30% to a high of 80% based on data from the Caribbean. We altered the vaccination for routine and outbreak as shown here. This graph shows health outcomes over the 30-year time horizon, comparing no vaccination in gray with the outbreak strategy in dark blue and the routine strategy in light blue. While both strategies avert substantial numbers of health outcomes compared to no vaccination, the outbreak strategy averts fewer outcomes than the routine. In the outbreak strategy, 67% of all health outcomes are averted, and in the routine strategy, 90% of these outcomes are averted. We also see the same trends with QALYs lost. As expected, more doses are delivered during the 30-year time horizon in the routine strategy. And thus, the routine strategy results in a higher vaccination cost of $436 million, while the outbreak strategy has a cost of $356 million. In terms of total societal costs, vaccination in either strategy leads to lower net costs than without vaccination because of the large number of health outcomes averted. For the routine strategy, shown in the top line, costs are $566 million for no vaccination and $496 million with vaccination, which is a savings of 12%. For the outbreak strategy, shown in the bottom line, costs are $547 million, which is a savings of 3% compared to no vaccination. In contrast, from the healthcare payer perspective, the costs for the vaccination strategies are higher than the vaccination. Again, the major difference is that this perspective does not consider lost productivity costs. Combining the change in outcomes with the cost of each strategy, we estimated cost effectiveness measures. Results in this table are for the societal perspective. Cost effectiveness ratios indicate cost savings for all outcomes for the routine strategy. And negative values are not reported to avoid difficulties with the interpretation of negative ratios. In the outbreak strategy, there are cost savings for the cost per case averted, and all other outcomes in the strategy have a net cost. The largest value is for the cost per death averted at close to $400,000. Of note, we found similar trends of the routine strategy being more cost-effective from the healthcare payer perspective. For the sensitivity analyses, I am just going to focus on the cost per quality gain from the societal perspective for simplicity. This graph shows the top 10 influential inputs from the univariate sensitivity analysis for both strategies. The routine is in light blue and the outbreak is in dark blue. For the routine strategy, there are a few inputs without visible bars, as all values fell into the negative range. The input with the largest influence on cost per quality gained is baseline seroprevalence, shown on the top row with the largest estimated cost effectiveness ratios. When baseline seroprevalence was set at the high level of the input range, or 40% seroprevalence, the cost per quality gain reached around $13,000 for the routine strategy and $20,000 for the outbreak strategy. The next set of results show the impacts of changing the outbreak year. If the outbreak occurs 5 years earlier, in 2029, the routine strategy is again cost saving, and the outbreak strategy has a net cost of around $4,000, which is higher than the mean of $59 for the base model. If the outbreak occurs 5 years later, in 2039, both strategies are cost saving. Last, these are the results from varying both halting seroprevalence and vaccination coverage together. Starting with 30% halting seroprevalence, the low value, all vaccination scenarios have net positive costs. In this case, low vaccination has the lowest cost per quality gain, since higher vaccination increases costs, but does not prevent more cases and thus qualities gained. Then, with 40% halting seroprevalence, the base value, high vaccination has net costs. Base and low vaccination scenarios have cost savings. Low vaccination, again, has the lowest cost per quality gained amongst these scenarios. Finally, an 80% halting seroprevalence results in all scenarios being cost-saving. High vaccination has the lowest cost per quality gained amongst these scenarios, since many more cases and health outcomes are averted, giving halting seroprevalence is much higher at 80%. There are several limitations of our model, and most of which are due to uncertainty of inputs. For one, there is no efficacy or effectiveness data available for the current vaccine. Model inputs are based on seroresponse data, as it was not feasible to generate vaccine effectiveness for initial licensure due to the infrequent and unpredictable nature of outbreaks. Second, there's limited evidence on outbreak frequency in the same geographical locations. And third, quality health utility weights are mostly taken from disease proxies, since no direct health utility weights have been determined for acute chikungunya fever. In summary, we found that using the currently licensed chikungunya vaccine in U.S. territories would avert 67 to 90% of all cases and associated health outcomes compared to no vaccination. However, the cost of vaccination would range from $356 to $436 million, which is a notable price for a disease where there's a lot of uncertainty in outbreak timing and how large the outbreak might be in a population with some immunity. Additionally, the routine strategy has cost savings, and the outbreak strategy has mostly net positive costs from the societal perspective. Results from the healthcare payer perspective were similar, but all outcomes for each strategy had net positive costs. Finally, in our sensitivity analysis, the seroprevalence inputs of baseline and halting seroprevalence had the largest impacts on the cost effectiveness. The assumptions about the seroprevalence needed to halt an outbreak being the most important. Thank you for your time, and I will turn it back to Dr. Talbot.
I'd like to open this for questions. Dr. Brooks.
Yeah, thank you for that presentation. Somehow I don't think I would have predicted the cost savings, but it's there. My question is, how does seroprevalence factor into your calculation? I mean, do you test, and if they test positive, you don't vaccinate them? I want to understand that part. But still, you vaccinate them, right?
Yes, this vaccine is not conditional on testing for a previous outbreak. We are assuming everybody would be eligible for vaccination despite having been exposed in the past.
So then would seroprevalence have any effect, since it's supposed to confer lifelong immunity? I'm just missing that part.
Yeah. If you could move to slide 44. We did try to model the overlapping immunity that might occur in our model, and so this is representation of what it looks like. The vaccine total for the routine strategy would be about 16% of the adult population, or total population. And then overlapping would be based on the just the level of seroprevalence in the population, and which would result in about 5% overlapping immunity.
May I just clarify from the seroprevalence studies you showed in Puerto Rico and elsewhere, does it appear that it's closer to 30%, the seroprevalence for that in the years after the outbreaks subsided, seroprevalence was 30%? Is that an accurate summary?
The serosurveys for USVI and Puerto Rico were about a year after the outbreaks, and so we modeled a decay of the seroprevalence just based on the mortality and new birth cohorts. So at the start of 2024, I believe the seroprevalence in our model population is about 28%.
Dr. Lair.
Thank you for your presentation. Could you explain a little bit more about slide 7, the routine vaccination strategy? It says annual vaccination, but I don't think that means someone's going to get a vaccine every year. How does it work? Oh, so when they turn 18, so all adults, and when they turn 18, they get 1 dose, and then in the outbreak, anyone who hasn't gotten a dose would get 1 at that time?
Yes, for the routine strategy, the 70% would include those who had already been vaccinated. They would not be revaccinated for the outbreak response. And so the total is not in this slide, but I believe it's about 42% of adults will be vaccinated in the outbreak response for that strategy.
Thank you.
Dr. Sinayas?
Hi. How would these analyses change if we do have an approved vaccine down to age 12?
Thank you for this question. This has not been addressed in our current model. We are expecting to adjust our model once the new data comes out for the new vaccine and for the adolescents. So we will come back to you with those answers.
Dr. Daly?
Yes, I have 2 questions. Both are sort of related to what Dr. Brooks asked. If you could let me know if my interpretation is correct about his question about seroprevalence. If there's high seroprevalence, then it costs more to protect because baseline seroprevalence is high. Those who are seropositive are not going to get disease, and so essentially, okay. So around cost effectiveness, it is better intuitively than I was expecting, and I don't know why, compared to other vaccines. And is it cheaper, or is it because most people who are seronegative get sick, and then most people who get sick get symptomatic? So why is this better from a cost effectiveness standpoint than other vaccines that we're evaluating this session?
That's a great question, and we did a lot of sensitivity analysis to understand really what is going on there with our different inputs, such as vaccine costs, such as seroprevalence, but really what it comes down to is the high symptomatic rate. The symptomatic rate we're modeling is 72%, but does go up to about 90%. And compared to other vector-borne diseases, that's very high. And so there's a lot of clinical cases. There's a lot of lost work, so that factors into the lost productivity costs for the societal perspective. You can see with the healthcare payers perspective, when you don't include that, those lost productivity costs, it's not cost savings.
And then just to add on to that, maybe it's also that, so you assume most of the population is vulnerable. That's 70% is not seropositive. You assume most of the population then gets sick and gets symptomatic. But then if you vaccinate, you get lifelong immunity, which means you're protected for decades, sort of regardless of when the outbreak happens, correct?
That's correct, yes. The current data is from the clinical trials, which suggest it works very similarly to the natural immunity from infections, yeah.
Dr. Cotton?
Thanks for a very interesting presentation. I'm interested in hearing more about the context of the immunocompromised host. I do think if we were to vaccinate a lot of people at 18, similar to MMR, we might get this live vaccine into people before they become immunocompromised, at least for a good number of people who often acquire immunosuppressive states later in life. But I'm wondering if you can comment on what large-scale vaccination would do for immunocompromised patients who are living in that situation. I have a special interest in travel medicine and immunocompromised hosts, so thinking about that. Thanks.
Okay, yeah, so that wasn't, we use the population-based model that wasn't explicitly separating any populations out, but we do expect that immunocompromised people would not get the vaccine if that was not recommended for them, and they would be protected by herd immunity. this level of halting seroprevalence could be reached really quickly with vaccination.
Dr. Jameson?
Thanks also for an interesting presentation. I, like Dr. Brooks and Daly, was surprised that it was cost savings, even though I think the cost of the program was $400 million. And it seems like and correct me if I'm wrong, the cost effectiveness is really based on the likelihood of a widespread outbreak, and the likelihood of a widespread outbreak is based on the overall seroprevalence. So I just wondered if you could comment, knowing the seroprevalence and knowing the history in these regions, how likely is it in the next 10 or 20 years to get a large widespread outbreak?
Yes, that is an assumption of our model, that we are modeling an outbreak within the next 20 years. And so it certainly is dependent. If that did not occur, there would be a lot of cost incurred without those benefits. As Dr. Hills suggested, it's very uncertain. There hasn't been any good models that have been developed to predict when these outbreaks will occur. I know we searched a lot for the data that could help inform our model, and we really didn't find anything that was relevant to, except for one study that we mentioned about the Philippines that was relevant to an island nation where there wasn't, like Dr. Hills mentioned, it's not contiguous with other states, other locations, because in other locations there could be outbreaks that are more frequent, but they're not in the same exact location. They might be in one city, and then next year they're in a different city. So it's a little different for these islands that are contained geographically. But I would turn it over to Dr. Staples if she has any thoughts about predicting outbreaks.
Yeah, I don't think we have any good data for it. I mean, essentially, you have to have an ongoing outbreak, as we know when we had the outbreak, previously with large outbreaks and spread and transmissibility of people movement, as people being one of the ways this is spread, we're more likely to see an outbreak. But, right now with the higher levels of population immunity, we haven't reached that potential yet. And knowing when we're going to reach that potential and where that is something that we're not clever enough to figure out right now.
Dr. Chen?
Yeah, I think these are all great questions, and I guess maybe we can look at slide number 12. So I think you brought out this concept, but maybe didn't talk about it enough, or maybe you could remind us again about the halting seroprevalence. It's slide, it looks like slide 12 on my set, but it's the, yep.
18.
Maybe you can talk about this again and remind us, and maybe I think there's a lot of uncertainty about that, what that level is, but that's what our model is also based on, right?
That's right. So in the model, the halting seroprevalence is the value with that, at least in the no vaccination scenario, we would reach that level of seroprevalence, and then there would be no more infections. There obviously would be an increase over this halting seroprevalence value with vaccination during the outbreak response. This level of halting seroprevalence was based, as I mentioned, on this study in the Philippines that found that outbreaks occur about every 17 years, but it also saw that after multiple outbreaks, I think it was at the third outbreak that 40% was that level that was reached in the population. So even though they had the baseline levels, seroprevalence maybe of around between 20 and 30%. 40% was the population level that was reached. That obviously varied slightly based on age because of whether or not they were alive for the previous outbreaks. But this level was adjusted in the sensitivity analyses, and we saw that at higher levels of halting seroprevalence, 80%, which that was a value that was seen in Jamaica, that level of seroprevalence in the community, you would get this cost savings would be greater based on just the vaccine reducing more health outcomes. However, if the halting seroprevalence lowered to 30%, which was what the SARA survey found after the previous outbreak, there would be, the cost would be greater based on not averting as many outcomes. Based on the baseline seroprevalence that was already in the community, you would have much fewer infections, and so vaccination would cost more without saving more, not lives, but cases and hospitalizations.
It's a fantastic discussion. Dr. Long.
Does your thinking about the use of this require annual seroprevalence data in the country so you don't immunize a bunch of people unnecessarily? And I assume you're not thinking of doing serology before you decide to immunize someone in an outbreak.
That hasn't been considered for the strategies. And no, for the vaccination strategies, we are not considering any serology tests. Does that answer your question? Okay.
All right, phenomenal conversation. I think we are now moving on to, we'll have Dr. Hills back to talk about the next steps for the work group. What?
Thank you. I'll just wait for my slides to come up. Thank you very much. So for orientation purposes for ACIP members, because our work group is now considering 2 chikungunya vaccines and 4 different recommendations for each, I wanted to provide a brief outline of next steps for the chikungunya vaccines work group over the next 12 months. So today you've just seen the presentation on cost effectiveness of use of the chikungunya vaccine in US territories. And as Dr. Long brought up earlier, the work group is really needing to consider additional data to think through how this vaccine would best be used. So we're gathering those data and discussing them, and they include the acceptability and value of a vaccine to both the providers in territories and relevant populations in the territories, and the feasibility of vaccine administration in different scenarios. Overall, the work group is going to continue to develop policy options for recommendations for various at-risk groups to present to ACIP for your consideration. For the live attenuated vaccine, we already have approved recommendations for the use of the vaccine in travellers and laboratory workers, and we'll be considering use among residents of US territories with risk and with US states with risk. For the virus-like particle vaccine, we'll be considering recommendations for all 4 risk groups. I did just want to note finally that our 2 ACIP members will be rolling off ACIP and therefore off our work group. So Dr. Wilbur Chan and Dr. Matt Daly have been exceptionally supportive and engaged and really provided excellent input to the work group. So I did want to publicly thank them for their contributions to the work group. And with that short update, thank you, and I'll hand back to Dr. Talbot.
We also will miss Dr. Chen and Dr. Daly. Okay, so last session, hang in there, y'all. Dengue vaccines, and we're going to start off with the Dengvaxia discontinuation by Dr. Berggren.
Thank you. I'll just wait for my slides to come on.
Sounds good. Thank you. While we're waiting for the slides, we will actually have both talks. They're short, don't worry, about the discontinuation and vaccine updates back to back, and then we'll ask questions.
Thank you. I'd first like to start by extending my thanks to the CDC and members of the ACIP for allowing Sanofi to present today regarding Dengvaxia's next steps. My name is Nicholas Berger, and I'm the U.S. Director of Scientific and Medical Affairs at Sanofi for travel and endemic vaccines. Next slide. Before detailing the next steps for Dengvaxia, I'd first like to review Dengvaxia's indication, dosage, and administration, and the ACIP recommendation for Dengvaxia. Dengvaxia is indicated in the U.S. for the prevention of dengue disease caused by dengue virus serotypes 1, 2, 3, and 4. Dengvaxia is approved for use in individuals 6 through 16 years of age with laboratory-confirmed previous dengue infection and living in endemic areas. Dosage and administration of Dengvaxia consists of 3 0.5 milliliter doses spaced 6 months apart at 0, 6 months, and 1 year. In 2021, ACIP recommended vaccination with Dengvaxia for children aged 9 through 16 years, having evidence of a previous dengue infection and living in areas where dengue is endemic. Dengvaxia is recommended as a 3-dose vaccination series administered 6 months apart at month 0, 6, and 12 for the selected pediatric population. Evidence of previous dengue infection, such as confirmation with previous laboratory-confirmed infection or a highly specific serodiagnostic test, will be required among eligible children before vaccination. Next slide. Moving to next steps for Dengvaxia. The live attenuated dengue tetravalent vaccine, Dengvaxia, is being discontinued due to low demand globally. This decision is not due to any concerns regarding quality, safety, or efficacy. Due to the unique situation surrounding dengue immunization, we at Sanofi felt that it was important to notify the CDC and Puerto Rico programs well in advance of discontinuation in order to allow for alternative planning and to allow for us to work together in order to maximize immunization while the product is available. Dengvaxia is the first licensed vaccine for the prevention of dengue disease and has been available globally since 2015. Dengvaxia was licensed in the US in 2019 and was recommended by the ACIP in 2021. Efforts have been made to facilitate implementation of the screen and vaccinate approach as recommended by the WHO in 2018 and the ACIP in 2021. However, utilization of Dengvaxia has been and continues to remain low globally and in Puerto Rico. Despite an increased incidence of dengue in different parts of the world, use of Dengvaxia has remained low. Puerto Rico's immunization program is the only public program using Dengvaxia. Furthermore, Dengvaxia is indicated for people with prior dengue infection and requires a 1-year vaccination schedule. Thus, Dengvaxia is not intended for acute dengue outbreak control. Dengvaxia will continue to be distributed through public, that is VFC, and private markets globally, including Puerto Rico, where it is currently recommended by the ACIP through the product's expiry. The last doses of Dengvaxia will expire at the end of August 2026. Given the 3-dose series needed for full immunization, individuals should start the vaccination series for Dengvaxia no later than August 31st, 2025. Next slide. I'd like to conclude by extending my gratitude to the CDC and ACIP for allowing Sanofi the opportunity to present this information to the ACIP. And we look forward to continuing to collaborate with the CDC and Puerto Rico Department of Health to maximize the opportunity for prevention that Dengvaxia provides. Thank you.
Thank you so much for that. And if you'll hold on a little bit longer for questions in a few minutes. Dr. Wong, can you update us on vaccines, dengue vaccines?
Absolutely. And would you mind if I shared my screen so I can control the slides? Over.
Okay, you should be good to go now.
Okay. Let's see. There we go. Well, good afternoon, and thanks for having me. I want to start with a quick update on current dengue epidemiology. And so we know that dengue is increasing globally, and this map that I'm showing you shows the countries where locally acquired dengue cases have been reported from March 2023 to April 2024. And so the first thing you'll notice is that countries all over the world have reported dengue cases, including in Europe. And second, you'll notice that Central and South America are almost all the darker brown color, indicating the highest level of case notification rates. So zooming in on the Americas for 2023, I'm showing you the annual number of cases reported to PAHO since reporting began in 1980 to 2023 at the end there. So you can see that 2023 was previously the highest year on record with over 4.6 million cases. And that shocked everyone until we got to 2024. We're barely halfway into 2024, and we've already broken that record. We now have nearly 10 million cases reported as of June 25th. So 2024 is the new winner of all-time highest dengue cases in the Americas. So turning our attention over to the US, we should first acknowledge that if we're talking about all US health jurisdictions, including the territories and freely associated states, that we have 6 with endemic dengue transmission, with American Samoa, the Federated States of Micronesia, the Marshall Islands, and Palau in the Pacific, and Puerto Rico and the US Virgin Islands in the Caribbean. But perhaps the area most making headlines is Puerto Rico. So these are the case counts for Puerto Rico by EpiWeek. So on the right-hand side, you can see that the dashed blue line is 2023, cases for 2023. The dashed gray line is the historic median, but the dashed red line is what I want you to focus on. That line is the epidemic threshold, which our epidemiologists calculated based on decades of historic data. Now, when cases rise above that line, it's predicted large outbreak years later on during the high season here in Puerto Rico. So the solid blue bars on the left are the case counts now for 2024. And as you can appreciate, we're now over that epidemic threshold for 21 weeks now. So where are we with Dengvaxia? Well, the first doses of Dengvaxia were administered in late 2022. This picture here is a news article of the Puerto Rico chief medical officer and the clinic director where the first vaccines were administered. And since that time, 264 total doses have been administered. And this bar graph shows cumulatively administered doses by year, with 13 doses administered in 2022, climbing to 149 in 2023, and a cumulative total of 264 as of June 11th, 2024. Since it's a 3-dose series, we can also break down that data to understand how many people have been protected. At least 145 people have been given at least 1 dose. 87 people have received dose 2, and 32 have finished the series. And while those numbers are relatively modest, the implementation of this vaccine has been complicated by the multiple visits and touch points with the healthcare system that it requires to determine eligibility and start vaccination. As you can see in the diagram, a person has to go to the clinic for evaluation, then they have to go to a lab for pre-vaccination testing for previous dengue infection, then they have to go back to the doctor for result interpretation, and if the result is positive for past dengue infection and thus they're eligible for the vaccine, they have to go to the vaccine clinic and get their first dose and schedule dose 2 and 3. As you can imagine, getting the system up and running has been challenging and slowed implementation. Through this multi-step process, we can appreciate some of the barriers that we've identified to uptake that have included the pre-vaccination testing, the complex billing process for providers, and the limited vaccine messaging that's occurred in these years. Sanofi worked with CDC to communicate the discontinuation, and we've made this information available on our website and in the most recent Dengue Health Alert Network communication. We have been working closely with the Puerto Rico Department of Health to prepare for this discontinuation. As for other vaccines, you know that we had presented multiple times on TAC 003, but that this was voluntarily withdrawn by the manufacturer in July 2023, as we updated in the last meeting. The TV003, TV005 vaccine, using formulations developed by NIH and licensed to Merck and Butantan, has shown some progress. The phase 3 trials are ongoing in Brazil, and the 2-year follow-up data that they recently published showed promising efficacy and safety. However, no dengue 3 or 4 were circulating at the time, limiting the ability to evaluate VE for those serotypes. So we're eagerly awaiting the 5-year follow-up data later this year. This vaccine has not yet been submitted to the FDA. After Dengvaxia is discontinued, there will be no dengue vaccines available in the US after discontinuation. As stated earlier, the FDA is not currently reviewing any dengue vaccines, and our work group will be paused until new applications are submitted to the agency. While vaccines are one component of reducing dengue morbidity, and it is unfortunate that we're now without that tool, we're now focusing in the US on strengthening the other pillars of control: excellent clinical management, robust surveillance, and effective vector management. So in conclusion, we know that dengue cases are rising globally and that Puerto Rico has declared a public health emergency due to the large number of dengue cases. After Dengvaxia is discontinued, there will be no other vaccines in the US, and that given that no vaccines are currently being reviewed by FDA, the ACIP work group will be paused. And while it's unfortunate not to have a vaccine, we're now focusing efforts on dengue control with the other components that I showed earlier. So many thanks to our dengue vaccine work group members here, and a special thanks to Michel Flores-Febo, Parker Acevedo, Diana Duran, and the PRDH for their support with this vaccine and for the implementation, though brief, of Dengvaxia. We can now take questions, and I have the work group co-leads on this call as well. Thank you.
Thank you so much. So questions from the voting members for Dr. Berggren and Dr. Wong. Dr. Shaw.
Yeah, hi, thanks very much. I was just wondering, am I correct that the TV 003 to 005 vaccine does not seem to have the same issues about protection in seronegative versus seropositive children as Dengvaxia did, at least initially?
We have not started reviewing that data, and so I know the 2-year data that they published did show excellent protection in seronegatives and in seropositives against dengue 1 and dengue 2, but we're eagerly awaiting sort of the end of the trial to sort of evaluate that data in more depth. And I don't know if my team leads, Dr. Paz-Bailey or Dr. Adams, have anything to add.
Yes, thank you, Josh. I think it's important to note that during the trial period, only dengue 1 and dengue 2 circulated, and as Josh was saying, the vaccine was efficacious among both seropositives and seronegatives. Unfortunately, they did not have circulation of dengue 3 and dengue 4. So learning more about that and about the longer term follow-up is going to be important.
Thank you. Dr. Lair?
Thank you for your presentation. Following up on that question about TV003, based on the data you have now, is it a 2-dose vaccine that's 3 months apart? Can you just tell us a little bit about age groups that they studied it in so far? Thank you.
Sure, thanks. I think I'll hand that over to Dr. Paz-Bailey.
Yes, it's a 1-dose vaccine. It's also a live attenuated vaccine, and the age groups included in the trial go from 2 years of age to 55.
Thank you.
I may have that detail not completely right, but it covers children and adults.
Thank you. And do you have any information about Takeda and withdrawing TAC3? Because it's being used in other parts of the world. Was that more putting it on pause because they didn't have the data and they might come back? Do we have any information from the manufacturer about what they're thinking?
So Qdenga was voluntarily withdrawn from FDA due to the aspects of data collection. We don't have information at the current time on the possibility of resubmission, and I think Takeda might be better positioned to answer that. But obviously, our ACIP dengue vaccine work group is going to be ready to reconvene when new dengue vaccines are planned to be submitted to FDA. And I don't know, Gabrielle, if you have anything else to add to that.
Nothing to add, Josh. Thank you.
So for Dr. Kaslow, is there something special about a voluntary withdrawal that means something different than, or is there anything we should know about that?
Thank you for the question. I really am not at liberty to speak about that.
Yes, Dr. Chen.
Yeah, I'll just comment that we've now heard from two different groups, the dengue branch and also the arbovirus branch as well, you know, with the chikungunya. So just reminding folks that even though we don't see these diseases here in the U.S., and even though the chikungunya work group is going to be talking about trying to figure out if there are going to be recommendations for U.S. states that might be at risk, we have an N of 12 from Florida and an N of 1 in Texas. And so, you know, exceedingly few numbers, but with global warming, with kind of other changes, I think that we're going to probably see more of these cases in our U.S. territories and perhaps the southern states. So, you know, we'll continue to see if dengue lands on our shores, but certainly is afflicting our U.S. territories. So just continuing to demonstrate that we have a lack of data for a lot of the things that we discuss, and so it's very hard, I think, and I have to just say the work group, the CDC leads are doing their best, and I'm very impressed with what they've been doing with the very little data that they have, and helping us to kind of have these robust discussions to try to figure out what we can do with these vaccines that are coming down the line. Thank you.
Yes, Dr. Schechter.
I think others can speak with greater detail and knowledge about this, but from a distance, I just wanted to acknowledge the effort it took in Puerto Rico to try and deliver Dengvaxia and the preparation that went on for a long time. And my heart goes out from a public health department to those who strive so valiantly, regardless of the results.
Very true and very well said. Oh, sorry. I'm looking right at Dr. Cotton with her hand raised. Yes, Dr. Cotton.
So I'd just like to comment that although there are a small number of cases in mainland U.S., there certainly are plenty of cases in the territories, and these are important diseases for immunocompromised patients. And again, I believe that all of these vaccines are live vaccines, so can't be given to immunocompromised. So it's really quite a vulnerable population that is not protected, and also not protected by herd immunity. So it's a disappointing time to not have any vaccine candidates. Obviously, we're kind of at the end of the process, so it's not our job to say that companies should submit to the FDA, but it is disappointing that Brazil and Brazil's rolling out a massive dengue vaccine campaign, and we're closing up shop. So that doesn't make a lot of sense.
We're still waiting for Bavarian Nordic to continue to work with the work group to share their data, but that's a VLP, so that can be theoretically given to the immunocompromised.
That would be great.
And so that's a chikungunya vaccine that's coming up, and the Bavarian Nordic, the Takeda, if it does come back to the U.S. for consideration, that was also not a live vaccine, so that could be used potentially for the immunocompromised.
I'm getting a lot of questions from travel patients if they could go to other countries to get these vaccines. So perhaps we should think about doing it within the U.S.
And pardon, was that a question directed for dengue vaccines or for the chikungunya vaccines?
I think it was, Joshua, it's Camille Cotton. I think it was more of a discussion in general.
Oh, got it.
Just,
thanks.
Any other questions? We appreciate these last two speakers. The committee has actually completed its business for today. Are there any objections to recessing? Dr. Long apparently has none. All right, hearing none, today's ACIP meeting is now in recess. The committee will reconvene tomorrow morning at 8 a.m. Bye, y'all.
Thanks so much.